Hello, 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 hello. Mic check testing 1 2 3. Hello, hello, hello 1 2 3. Hello, hello 1 2 3. Hello, mic check testing 1 2 3. Hello.
अस्सलाम वालेकुम बिस्मिल्लाहिर्रहमानिर्रहीम। तमाम कोलीग्स से रिक्वेस्ट है कि वो अपनी सीट्स पर प्लीज़ तशरीफ़ रखें ताकि हम बाकायदा आगाज़ कर सकें। जितनी जल्दी आप बैठ जाएंगे हम इंशाल्लाह विद इन मिनट्स बल्कि सेकंड्स हम गोइंग टू स्टार्ट। सर बस मैं सेटल्ड हो जाएं क्योंकि ये सेशन सर लाइव जा रहा है फेसबुक पे भी और यूट्यूब पे भी, तो इसलिए उम्मीद है कि आपकी थोड़ी सी एडवर्टाइजमेंट उधर भी हो जाएगी। मसूद साहब बाहर देखें, अगर कोई डॉक्टर साहबान हैं तो उनको अंदर ले आएँ प्लीज़। चलें सर फ्लावर्स।
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم. مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Bismillahirrahmanirrahim. Ladies and gentlemen, esteemed delegates, distinguished guests, and respected members of the organizing committee, Assalamu alaikum, and a warm welcome to the Primary Care Diabetes Symposium. It is with great pleasure and enthusiasm that I, Dr. Ahmed Shahzad, on the behalf of PCDA Pakistan and its chapter head Faisalabad, Dr. Ahmed Shahzad, stand before you today to inaugurate this significant event, which brings together healthcare professionals from various corners of our country. This symposium is organized in partnership with Faisalabad Medical University and Pakistan Society of Internal Medicine. Our gathering here is more than just a meeting of minds. It is a celebration of knowledge, expertise, and a shared commitment to combating one of the most pressing healthcare challenges of our time, diabetes. In the face of this growing epidemic, it becomes imperative for us as primary care providers to come together, share our experiences, learn from one another, and find innovative solutions to improve diabetes care and management. The diversity of expertise represented in this hall today is a demonstration to the dedication and passion that each one of you brings to the field of healthcare. We have professionals from various disciplines, each contributing a unique perspective to the conversation. It is this diversity that enriches our discussions and fosters a holistic approach to diabetes care. I would like to extend my heartfelt gratitude to our collaborating partners, our esteemed university, and the Pakistan Society of Internal Medicine for their unwavering support and encouragement, and I extend a warm welcome to each one of you. May our time together be fruitful, inspiring, and transformative. Let us work hand in hand to make a difference in the lives of those we serve. Thank you, and let the symposium begin. We are honored to have Dr. Ahmed Shahzad, Associate Professor of Medicine, with us today. Sir, I invite you to please come on the stage for the proceedings of the first session. Thank you.
Bismillahir Rahmanir Rahim. First of all, I want to thank a big thanks to Dr. Ahmed Shahzad for inviting me as a moderator in the first session. I wish to congratulate him and Dr. Ijaz Anwar and his team for organizing such a great event in Faisalabad. The organization doesn't mean just to create an ambience, but it is also collecting such a galaxy of superstars in the field of diabetes and creating such an aroma of learning that I'm very much eager to learn many things from you people, my senior colleagues. And on the behalf of Faisalabad, I welcome you all. Welcome to sirs in Faisalabad. You are coming from all the parts of the country. I'm very happy to see such a gathering, in particularly the first session of the meeting. This is again a great organization. So, for the ones who have come such an early morning and in time, so I want to have a clap for you. Thank you very much. So, starting our session, I will invite panel of experts first to the stage to have their seats. My first panelist is Professor Dr. Tufail Muhammad. He is from Faisalabad. He is a retired professor of medicine from Punjab Medical College. He is a renowned nephrologist and he is chief patron of PMA Faisalabad. My second panelist is my respected sir, Professor Dr. Amir Hussain. He is Professor of Medicine in Faisalabad Medical University and also the chief editor of our journal. My next panelist is Dr. Muhammad Salim Khan. He is from Kotli, Azad Kashmir. He is a renowned physician. He is fellow of Royal Colleges of Glasgow, Ireland, Edinburgh, and there is a long list of degrees. I can't talk all of them, but he is a very expert in his field, and he is examiner of MRCP as well. My fourth panelist is Professor Dr. Badr Bashir. He is from Independent Medical College. He is professor of medicine. He is a very nice fellow of mine. He's just like an elder brother, very expert, very clear in his concepts. My last panelist is Professor retired Colonel Shakil Ahmed Mirza. He is consultant physician, gastroenterologist, and diabetologist. Thank you, sir. So, here we will start our talks for the session 1. The first lecture is Lifestyle Modifications and Challenges for the Good Glycemic Control. The lecture will be delivered by Dr. Asima. She is from Karachi. She is Director Public Health Program in Bakai Institute of Diabetes and Endocrinology. She is Vice President of Primary Care Diabetes Association and working as Head of Department in Sindh General Hospital, Liaquatabad, Karachi. Please, ma'am, come to the stage.
Bismillahirrahmanirrahim. Assalamu alaikum. I am really grateful to the organizing committee of this mini symposium for giving me a chance to share some aspects of the topics which is given to me. In fact, the topic has 2 components, and each component is a very vast component as far as discussions are concerned. So I'll try to cover some of the aspects from both of these lifestyle modification and challenges for good glycemic control. I also want to congratulate the organizers for having such a nice and committed audience for this conference at such an early hour of the meeting. Okay. So, I am Dr. Asima Khan Niazi, and as Dr. Sab has given a very kind introduction of me, I am Vice President of Primary Care Diabetes Association, and I am working as the Head of Department of Diabetes in Sindh Government Hospital, Liaquatabad. Plus, I am Public Health Program Director at Bakai Institute of Diabetology and Endocrinology, and I am doing my PhD from University of York right now. Starting from the presentation, basically these are the facts, alarming facts that I am confident that everybody in the hall knows very well. So the important things are that at the start of this millennium, we have 151 million people with diabetics, and in just 21 years, this has almost 5-fold increased. The figures, the way we are just increasing in number of diabetic people is very alarming, and there are few more facts that those are more alarming than these. We know almost 4 in 5 people with diabetes are living in low and middle income countries. That means these are the diabetic population that has low restricted resources to combat the disease. Another fact is that the highest number of deaths right now in world is due to different conditions, different complications of diabetes, and a large number of diabetic people are like they don't know that they have diabetes, unknown diabetic people. So the facts are alarming. When we look at the contribution of Pakistan in this higher number of highest burden of diabetes, we see that Pakistan is on 3rd number in the world after China and India. We can see that right now we are at we are 33 million in number as far as the population of diabetes is concerned, and believe me, we can make up whole prevalence of diabetic people percentage wise. And this population will rise to 42.9% millions in 2030. But there is one more fact. Whatever number we are predicting since 20 to 25 years, we always get a higher number when we reach up to that year. So I seriously think that if we are not working hard to break up this cycle, we will get even higher than this number by the end of 2030. And almost 1 in 2 adults with diabetes are unaware that they have diabetes, and we have just discussed this fact. So, we had a survey in 2016 and 17, Buckeye Institute of Diabetes and Endocrinology, with different collaborators, of course with Ministry of Health and other significant collaborators. And we came across these figures, which later on accepted by IDF, and they have given the numbers for the Pakistan figures. So the prevalence of newly diagnosed diabetes was 7.1% at that time, 2016-17. And prevalence of non-diabetic at that time was 19.2%. So overall, we got 26.3% prevalence of diabetes. And most significant thing which we can appreciate over here, that rural and urban population, although there is a slight difference between the percentages of urban and rural, but that is not statistical significant. That means the usual urbanization and all these things which are claimed to be the most important factor in the increased prevalence of diabetes is equally present in urban and rural population in Pakistan. And prevalence of pre-diabetes is 14.4%. This is the most significant figure that we should target. Actually, we should target this figure. If, for example, we say that in next 5 years, this 14.4% population is also included, got diabetes, say, God forbid, got diabetes, all of these people, then the prevalence of Pakistan would be around 50 or more than that. And we can see that in urban and rural population, the figures are almost the same. These are the extra comorbids. Hypertension was found to be 46.2%, obesity alarming 73.1%, dyslipidemia in around 96%, and tobacco smokers were around 13.4% in this population. So, what is the most appropriate, most confident solution of this higher burden of diabetes in the world generally and in the Pakistan specifically? One answer: prevention. The concept of prevention is not new to the world. Like in 1921, this article was written in 1921, and they clearly said the prevention of diabetes mellitus. That was the concept by Jocelyn. So, and we later on tried to figure out that is it really a possible thing to just prevent the diabetes. So there are 2 landmark studies, though they are in the last part of the previous millennium, but the Hone study and the IGT, they both claim that 14% IGT convert to diabetes each year, and 50% of IGT, it was another study in South African, and they have got that 50% of the IGT patients convert to diabetes. They both studies have different genetic makeover, so they have large difference in the percentage of people who are going to convert to diabetes. So it's a fact that pre-diabetes will ultimately convert to diabetes. What should we do? Then Finnish diabetes prevention study was like in the very early part of this millennium. In 2003 it was published, and they gave us very promising figures. Then later on we have in studies in Finland, then Indian diabetes prevention program, and so on. A long list of prevention programs that claim that if we go for effective lifestyle modifications, we can have a very beneficial effect in the prevention of diabetes, or delaying, at least delaying of the diabetes. So we have different studies, and we can see the effect of relative risk reduction with each of these studies. I have just figured out the numbers which are due to lifestyle modifications. I'm particularly focusing on lifestyle modifications. These are like cumulative risk of diabetes that is reduced with these different. You can see that the first one is Galovis was published in 2018. It was a meta-analysis and of 63 different studies related to lifestyle modifications and prevention of diabetes, and it claimed that 29% cumulative risk reduction was possible with a significant lifestyle modification. Right. This concept was then later on propagated by IDF as well, that care and prevention through lifestyle modification is the only cost-effective solution of this high prevalence of diabetes. Right. And then we, as a Pakistani nation, we also emphasized on diabetes prevention and control as a part of an integrated non-communicable disease strategy. This article was written by Sania Nishda. Right. And then we have national action plans, and in each and every national action plan, we have clearly written that population-wide screening for high blood pressure and high-risk screening for diabetes and dyslipidemia is strongly recommended in all the national action plans. So when we talk about lifestyle modifications, these are very simple, basic 6 things that should be emphasized to each and every patient. Like mental well-being, we should care about. Physical activity, we should increase our physical activity. We should take care of the environment. We should have a very sound and sufficient sleep. Nutrition should be care of, and then substance abuse should be reduced. Are these very simple? What do you think? No, we have strong barriers to implement these simple steps. This is a very, very difficult task to achieve. So whenever we think to change anything, this is normal human behavior. There are many theories of change in human behavior, but this is most often recommended change theory. And we have a pre-contemplation state in which we normally don't agree that we do have any problem. Okay, थोड़ा सा वेट ज़्यादा है तो क्या हुआ? हल्की सी शुगर आई है, अभी तो ठीक है, बॉर्डर लाइन, डॉक्टर ने कहा बॉर्डर लाइन पे है, तो दवाई की तो ज़रूरत नहीं है अभी. तो वी डोंट एक्चुअली सी द रिस्क ऑफ हेल्थ. सो इसके बाद आती है जी कंटेम्पलेशन. राइट, आप समझना शुरू करें कि मैं अगर कुछ कर लूँ तो शायद बेहतरी आ जाए वो. एंड देन प्रिपरेशन स्टार्ट होती है, अब मुझे करना क्या है, कैसे ठीक करूँ इसको. फिर एक्शन, मेंटेनेंस, इसके ऑफ कोर्स रिलैप्सेस होते हैं. तो ये स्टेज ऑफ चेंज जो हम देखते हैं ये बहुत क्लोज है नॉर्मल ह्यूमन नेचर के. और पाकिस्तान में हम इसको जितने भी हम लोग प्राइमरी के लेवल पे या किसी भी लेवल पे प्रैक्टिस कर रहे हैं, वी मोस्ट ऑफन सी दीज काइंड ऑफ स्टेजेस इन ह्यूमन नेचर. So what are the typical barriers? Most often faced barriers. Lack of motivation and skills. Lack of motivation, we can all relate that. ख्याल है कि हमें अपनी सेहत सही करनी चाहिए, लेकिन हम उसके ऊपर उतना स्ट्रांगली एक्ट नहीं करते. लैक ऑफ स्किल्स, मेरा बहुत एक आम जो मिसाल के तौर पे हमने किसी खातून को बताया कि उसका वेट बहुत ज़्यादा है. शी डोंट नो एक्चुअली कि करना क्या है, उसको किस तरह से उसने बैलेंस करना है, क्या चेंजेस लाए अपनी लाइफ में. तो जब हम कम्युनिटी की बात करते हैं, वी आर नॉट टॉकिंग अबाउट द पीपल हु एक्चुअली अप्रोच सम फिजिशियन, वी आर टॉकिंग अबाउट अ जनरल पॉपुलेशन. जब हम सोशल मीडियाज़ के ऊपर मैसेजेस देते हैं तो हमारे पॉजिटिव मैसेजेस अगर 5 होते हैं, जो ठीक मैसेजेस होते हैं, तो हमारे गलत मैसेजेस 10 होते हैं. हमें इनफैक्ट हमने जो वो मिथ्स और नेगेटिव जो मैसेजेस होते हैं उनको उनके जहनों से डिलीट करने में हमारा ज़्यादा एफर्ट लगता है, बजाय से कि हम पॉजिटिव कोई मैसेजेस उनको देना शुरू करें. देन वी हैव लैक ऑफ सपोर्ट राइट. लैक ऑफ सपोर्ट, आपकी फैमिली की आपके साथ सपोर्ट नहीं है, आपको वो सफिशिएंट टाइम नहीं दिया जा रहा जो आप अपने ऊपर आप सर्व कर सकें, पीयर आपके पास सपोर्ट नहीं है, और फिर कम्युनिटी का एक नेटवर्क डेवलप नहीं हो रहा जिसके साथ आपको सपोर्ट मिले. अगर आपकी कम्युनिटी में, आपके गली मोहल्ले में 10-12 लोग हैं जो सुबह सुबह जाते हैं पार्क वॉक करने, तो आपके पास एक कम्युनिटी सपोर्ट होती है. जब आप ऐसा ही करेंगे तो आपको बहुत ऑड फील नहीं होगा कि अब आप क्या कर रहे हैं, और एक तरह से पॉजिटिव मोटिवेशन मिलेगी. फाइनेंशियल कंस्ट्रेंट्स अपनी जगह हैं. जो हमारे यहाँ ज़्यादातर कंसेप्ट होता है कि जिम जाना पड़ेगा, हेल्दी डाइट एक्सपेंसिव होती है, ये सारी चीज़ें जो एक मिथ्स हैं, ये भी मिथ्स हैं. हमें इनको क्लियर करना पड़ेगा कि आपको फिजिकल एक्टिविटी इंक्रीज़ करने के लिए सिर्फ एक अच्छे पेयर ऑफ शूज़ की ज़रूरत होती है, इसके अलावा किसी चीज़ की ज़रूरत नहीं है. जस्ट डू एंड वॉक, 1 घंटा वॉक कर लें, ठीक है. देन वी हैव कल्चरल बैरियर्स. हमारे खाने पीने के अंदाज इस तरह से हैं कि हम ज़रा सा भी उसको चेंज करना चाहें, हेल्थ की तरफ लेके जाना चाहें, तो आमतौर पे जो घर के जो लोग होते हैं जिनको वो बना हुआ खाना खाना होता है, उनको मज़ा ही नहीं आ रहा होता, उसमें ऑयल नहीं होता. तो ये कल्चरल बैरियर है. और हेल्थ और बॉडी वेट से रिलेटेड, हेल्दी बॉडी वेट से रिलेटेड डिफरेंट परसेप्शंस भी डिफरेंट होते हैं यहाँ पर. और फेयर ऑफ रेशियल हरासमेंट और अब्यूज़ व्हेन एक्सरसाइजिंग, और इस तरह के प्रॉब्लम्स जो हमारी सोसाइटीज़ में अनफॉर्चुनेटली अभी तक कॉमन है. एंड देन हेल्थ लिमिटेशंस. अगर हम अपने यही लाइफस्टाइल मॉडिफिकेशन हम किसी ऐसे पर्सन को बताएं जो ऑलरेडी डायबिटिक, हाइपरटेंसिव या डिफरेंट, तो एज ग्रुप मोस्टली ऐसा होता है, जॉइंट पेन्स हैं, डिफरेंट कार्डियो पर रेस्पिरेटरी फिटनेस के मसले हैं, या बॉडी कंपोजिशन ऐसी है कि जो बहुत ज़्यादा आप अप्लाई नहीं कर सकते हो फिज़िकल एक्टिविटीज़ को या हेल्थ बिहेवियर्स को. एंड देन डिफरेंट अदर मोटर फिटनेस, ऑल दीज थिंग्स. सो व्हेन वी टॉक अबाउट चैलेंजेस ऑफ गुड ग्लाइसेमिक कंट्रोल, उसमें एक तरफ तो ये लाइफस्टाइल मॉडिफिकेशन है जो फर्स्ट स्टेप है और जो बहुत मुश्किल है इम्प्लीमेंट करना. योर फर्स्ट स्टेप इज़ द मोस्ट डिफ़िकल्ट वन इन योर लाइफ. टेकिंग मेडिसिन्स इज़ ईजी. Doing exercise, changing your lifestyle, changing your nutrition pattern is different. So factor affecting like glycemic controls, we all know: diet, exercise, education, self-testing, medication, all these things. But we know when we go at the ground realities, we face some more difficult scenarios. What do you think? What's wrong with this picture? It's like coming from 2005 to 2023. What's wrong with it? The wrong thing is that decrease in percentage of patient with less than 7 controlled HbA1c is actually decreasing. 50% of population at best are at goal at very refined tertiary or secondary care centers where we have very strict controls and very good services provided. Then increase in percentage of patient with very poor control, and then unacceptable levels of morbidity and mortality that are continuously keep on increasing, right? So despite more than 40 new type 2 diabetes management options approved since 2005, we are at decline of good glycemic control, right? This is what we are getting from 1990s till date. We have so many options in medications, but the control is declining. So what is the reason behind this? This is like achievement of individualized targets decline from 68. These are the figures, different studies which have shown that the control group is declining despite all these available medicines. So the therapeutic inertia is the most commonly faced thing at our, specifically at primary care level. Failure to establish appropriate targets and escalate treatment to achieve treatment goals, responsible for substantial preventable complications of diabetes with associated excess in direct and indirect health care cost. So these are the different lapses. From first ODI to second ODI, and from second to third, there are a difference of around 6 to 7 years at each step. So we start adding medicines very late in the management of the diabetic patients. So this therapeutic inertia should be covered for glycemic control after lifestyle modifications. So we have discussed high burden of disease in Pakistan. We have discussed therapeutic inertia. We have discussed barriers to implement these lifestyle modifications at a nation. what should we do actually? What are the answers to these things? I'm sorry, this is a very busy slide, so maybe many of you feel difficult reading it. So, main thing is that raising awareness in the community. We at healthcare facilities can't do all the thing. Like most of the thing, 90% of the effort should be at the community level. So what would we show? Methods for raising awareness are using social media, electronic and print media, development of user-friendly mobile applications and websites. The examples are, targeted people are general population, policymakers, workplace officials, like providing a small gym at your workplace where we feel that 20 or more people are working there from 9 to 5. Availability of a small gym availability and time allocated for that use of that gym is like a very simple and decent thing that could be done. So these are different ideas at different community levels. And then we can just raise the awareness regarding rapid score to use that to calculate their own risk. And if you feel that you are at 4 or higher than that, you can consult your doctor for the screening. And now change in behavior and lifestyle modifications through these social media networks. And the expected changes, sustained modification in lifestyle, acceptance of risk as a potential threat to development of diabetes in future, and believing in the prevention of diabetes. So we should raise the awareness. And then the other aspect, we people who are educated, who know the risk, who know how to cover these risks, we can just have a strong advocacy to just to bring about the change in the policy, the increase in taxation in sugar sweetened beverages, labeling on the food options available, providing of healthy food options for the people, specifically at canteens of the children. I have taken quite a few lectures at the schools, and whenever I ask the children at the schools are very much motivated to use the healthy options, but the healthy options are actually not available at the canteen or cafeteria. So this is very important. The change in policies regarding these things should be advocated. And then monitoring and evaluation. This means that we should have regular surveys. We should have different CAP surveys to identify the difference in the health risk behavior or knowledge in the community, and difference in the BMI calculated. There are many ways by which we can monitor in the future, after 10 years, after 20 years, that all these efforts are bringing about some change in the community as a whole. So, Primary Care Diabetes Association, depending on all these aspects, which I have discussed for bringing change in the community, is doing many of the projects. I won't discuss these projects in detail. That would be done by Dr. Yasat in detail. But we have screening camps, awareness programs, different talks at the media, utilization of social media, advocacy, all these things. So we all hope for fighting better than we are doing right now, and have reduced prevalence in Pakistan in future. Thank you. Any questions and answers? Okay, the organizer was saying that questions would be asked at the end. Thank you very much.
Thank you very much, Dr. Asima, for such a wonderful talk and sharing real-time data. Condition of diabetes regarding prevalence and fate in Pakistan is really alarming, and you all people know that we are standing on number 1 in this championship. जैसे इकबाल ने कहा है ना कि रहमतें हैं तेरी अगयार के काशानों पर, बर्फ गिरती है तो बेचारे मुसलमानों पर. तो ये जो बर्फ गिरने से रोकने का जो तरीका है वो मैडम ने बताया बड़े एलेबोरेटेड तरीके से. दैट इज़ जस्ट लाइफस्टाइल मॉडिफिकेशंस, एंड प्रिवेंशन इज़ की टू सक्सेस in this field, in this championship to be defeated. My next speaker is Professor Dr. Hina Aisha. She is retired from Faisalabad Medical University. She was professor of pediatrics. She also served as Dean of Children Hospital Faisalabad. She was the pioneer for pediatric endocrinology in our institution. Not only the pioneer, but she make our department recognized by College of Physicians and Surgeons of Pakistan. She is my teacher. Please welcome Professor Dr. Hina Aisha, and her topic is Challenges in Type 1 Diabetes Management Type 1.
Bismillah, Alhamdulillah, Assalatu wassalamu ala Rasulullah, Amma Baad. Respected teachers, I can see our very senior teachers like Professor Muhammad Tufail, our younger brother Dr. Amir Hussain, Dr. Badr Bashir, and I'm very thankful to Dr. Ahmed Shahzad and Dr. Ijaz Anwar for giving me the chance to speak on this very important topic of type 1 diabetes, which family physicians often come across. So you all know what is type 1 diabetes. It is an autoimmune condition where there is a destruction of the beta cells. There are many silent events which lead to formation of reactive antibodies, and then there are activated T cells which just lead to beta cell apoptosis, and the result is lifelong dependence on insulin. It's one of the most common disorder of chronic disorder of the childhood. So if we look at the recent data according to latest IDF Atlas 2022, the people who are living with type 1, who were living with type 1 diabetes in 2022, they were 8.7 million, and out of this 1.52 million were type 1 diabetes of less than 20 years of age. When we looked at the new cases, there were 530,000 new cases in 2022 of type 1 diabetes, of which 200,000 they were below 20 years of age. And according to various published reports, there is a gradual increase in the incidence of 3 to 4% per year. The multinational project for monitoring the incidence of diabetes type 1 was taken up by the WHO in 1990, involving 114 populations in 57 different countries. So the striking geographical differences were seen, as in it was as low as below 2 per 100,000 to as high as 52 per 100,000 in Finland. But it was also interesting to note that out of the 10 countries who were having most of the type 1 diabetes, they were 4 of them. They had the population affected. That was the non-European population of Kuwait, Saudi, Algeria, etc. So there are so many challenges regarding management of. Although diabetes is a challenging disease, just Dr. Asma has told that the biggest challenge is lifestyle modification. But type 1 diabetes is many more fold challenging than type 2 diabetes. So I will touch some of them. So the latest agreed upon definition is a child or adolescent or adult having classic symptoms of hyperglycemia with hyperglycemic crisis and a random blood glucose of more than 200 milligram per deciliter, or a fasting blood plasma glucose of more than 126 milligram per deciliter. Rarely we do OGTT, but if it is more than 200 milligram per DL, then it's also labeled as diabetes. We should be very careful regarding looking at the HbA1c in young diabetic patients, because the disease is very aggressive in young patients. So HbA1c might not have the time to rise before the patient lands either into decay or he lands to a physician. Regarding the antibodies, according to the ISPAD, in resource poor countries like us, we don't usually go for antibodies, but we can go for antibodies if we are suspecting monogenic forms of diabetes in a very young population or with a strong family history, or we are suspecting type 2 diabetes because it's now also coming up in pediatrics. So onset is dramatic in children as opposed to the adults who are obese with diabetes. Young type 1 diabetics, they are either very lean or they are very malnourished. There is a failure to gain weight. Polyuria, polyphagia, polydipsia are the usual symptoms. Nocturnal enuresis. If a mother comes to you that my child was previously had a bladder control, but now he is just doing peeing at the night during sleep. So it can be a sign of diabetes. Candidal nappy rash in adolescents and vaginal candidiasis could be a presenting symptom. And symptoms usually are present only for a few days or weeks. When parents come to us, बड़ा गिल्ट फील कर रहे होते हैं, दे से पता नहीं कब से डायबिटीज़ हमें पता नहीं चला. सो बच्चों में इतना टाइम नहीं लगता. 13 to 80% of children in various reports, they present with decay. Sometimes it is an incidental finding. So challenges in diagnosis of diabetes. Early diagnosis is very important to avoid clinical presentation with acute complication. And as young children are unlikely to verbalize their symptoms, so recognition is a bit difficult. This can lead to a delay in the diagnosis. And as I have told you that the disease is very aggressive and they go into metabolic deterioration very rapidly. So we have to, this program is part of the awareness for the primary care physician about the type 1 diabetes. This was a study that highlighted that in case of delayed or misdiagnosis, it was 4-fold higher chance of child presenting with decay. And you know that diabetic ketoacidosis is the main cause of morbidity and mortality in children. Although many of the complications of diabetic ketoacidosis are same in adults and children, but children less than 5 years of age, they are more liable to have cerebral edema and cognitive dysfunction. So understanding the pathophysiology of diabetes has led to this classification about stages of diabetes, which depend upon the presence of autoantibodies and dysglycemia, and it can predict diabetes. So there are many preventive strategies that are studies are going on, that how we can prevent or delay diabetes, primary, secondary and tertiary level. So whenever a newly diagnosed patient comes to you, the management is urgent. We have to start insulin in as early as within 6 hours of presentation. If the patient is already in diabetic ketoacidosis, we have to hospitalize it. But ambulatory patients, now we see there are children who are presenting with type 1 diabetes, and they have adults with type 2 diabetes, so they are aware of how insulin is given. They are aware of how BGL is tested. So we can just monitor them by WhatsApp or messaging and send them home. But urgently caregivers have to be educated regarding insulin replacement therapy, basic nutritional plan, SMBG and ketone testing, hypoglycemia management. So all these are life-saving, and they have to be assisted with the psychological reactions and coping. Because when ये बम फूटता है उनके ऊपर कि हमारे बच्चे को डायबिटीज़ है, तो एक बहुत मुश्किल तरीके से वो कोप करते हैं. So हमें उन्हें सिर्फ बेसिक चीज़ें बतानी होती हैं, then we go into the details. So let's talk of insulin therapy. Insulin is life-saving hormone. It's a prandial hormone, and all the regimens and ways of giving insulin are basically designed to match the physiological events. But unfortunately, nothing matches the physiological secretion of insulin in response to the food and the 24-hour requirements of insulin. So, but there are three main types of insulin therapies that we use in children. One is multiple daily injections, other insulin pumps, or we call it continuous subcutaneous insulin infusion, and third is simplified injection therapy, where many a times we are compelled to do that because of our health system and affordability of the patient. So the short-acting insulins, ultra-short-acting insulin like Lispro, and glulisine, they have been the insulin has been changed by substituting the amino acids so that their absorption is rapid. Similarly, the basal insulin have a slow absorption and a almost 24 hours duration of action. So, although the requirement of insulin varies with the age of the patient, with the duration of diabetes, the lifestyle of the child, the diet, the exercise, and the choices of the child and the family. So we have to design according to that. But initially, we start with 0.5 to 1 unit per kg. A lower dose is given in the younger children. 25 to 50% of this is the basal insulin, which can be datamir, glargine, or degludec. And rest of it is divided into pre-meal boluses. And sometimes we have to add the correction dose. Adjustments of insulin, they are very challenging, but when we are using the basal bolus regime, multiple daily injections, and for basal insulin correction, we have to look at the overnight and fasting BGL, and for meal dose adjustment to our postprandial BGL has to be looked into. So, a pattern based, we ask the parents to bring their home record and their food diaries. So, a pattern based and proactive adjustments are made. Retrospective adjustment, like it was done in sliding scale, they have no role now. So, even with the very tight control, even then unexplained variations in insulin in the BGL, they can occur. So we can then, as the disease progresses, we can teach these rule of thumbs to the parents, like how you have to calculate the insulin carb ratio and how you have to calculate the insulin sensitivity factor. Pre-mixed insulin, I would like to emphasize that they are not recommended for diabetic care of children, as some adults are using it, because they eliminate the flexibility offered by separate insulins in children with variable food intake. तो adults में we can give the insulin और वो उस insulin के हिसाब से खा सकते हैं, but in a child उसका हो सकता है दिल करे 2 घंटे बाद खाने को, या उसका जो है वो दिल ना ही करे खाने को. So we cannot offer them pre-mixed insulin. In various studies, higher rates of decay and hypoglycemia has been reported in adolescents on pre-mixed insulins. So the sites are very important because the preferred site is abdomen, especially for the prandial insulin. Other sites used in children can be the anterolateral aspect of thigh, lateral aspect of the buttock, and rarely the upper arm. Because of the very less subcutaneous fat in a child, young child, we do not use this upper lateral aspect of the arm. So these are the sites. So in abdomen, it is faster absorption. So prandial insulins, they are given on the abdomen, and when you need a slower absorption, you give basal insulin on the thigh or the buttock. Some children are very afraid of getting their injections on the thigh, so they can be offered a buttock injection. So insulin storage is a problem in such a hot environment of Faisalabad, and many parents, they say we don't have a refrigerator, how to store? They store their insulin in neighbor's house, and sometimes the neighbors, they are away and they miss their insulin doses. So this is the recommendation by ISPAD for International Society of Pediatric and Adolescent Diabetes, that in low resource setting you can use this technique to store the insulin. So now recently the physicians and the patients with diabetes, they have got an array of monitoring, array of techniques for monitoring glycemic control and to follow their glycemic targets, because a good metabolic control cannot be achieved without monitoring of the BGL. So these are the glycemic targets. They must look different to you, because previously we were talking about the age-related targets. For this age, this target, for this age, this target. But now, according to the latest ISPAD guidelines, a unified fingerstick capillary glucose target of 70 to 180 milligram per deciliter is irrespective of the age has to be followed, and HbA1c of less than 7%. Because the idea behind is that the younger the child, the more years of a productive life are lying ahead. So we have to prevent these children from micro and macrovascular complication. Dr. Niyamat is sitting here. When we were residents, तो हमें यही सिखाया जाता था कोई बात नहीं, हाइपोग्लाइसीमिया नहीं होना चाहिए, हाइपरग्लाइसीमिया थोड़ा सा बर्दाश्त कर लेते हैं. But now these things have changed, because various studies have shown that lower HbA1c targets were not shown to increase the rates of severe hypoglycemia. But still, सारे लोगों को एक ही लाठी से हाँका नहीं जा सकता. In our low resource settings, if we feel that the monitoring is not proper and the parents are passing and child is passing through psychological distress, we can, for the time being, agree on the less stringent targets to avoid hypoglycemia. So the SMG is the main tool for self-monitoring of blood glucose is the main tool. ISPAD क्या recommend करता है 6 से 10 दफ़ा करो. But you can imagine a toddler of 3 years of age or 2.5 years of age, how can he have such pricks? It will be, parents will weep with every prick. So in a resource poor settings, you can manage with pre-meal and pre-bed levels. But ये भी हमारी population में acceptable नहीं है. So if even this is not acceptable, then you have to train the parents कि बजाय इसके कि रोज़ एक ही टाइम पे, आमतौर पे पेरेंट्स क्या करते हैं, सिर्फ फास्टिंग कर लेते हैं. वो कहते हैं हम फास्टिंग रोज़ करते हैं, क्योंकि दे आर वेरी अफ्रेड ऑफ हाइपोग्लाइसीमिया ड्यूरिंग फास्टिंग. सो ISPAD recommends instead of doing the same single reading a day, you can, for example, do 3 or 4 readings 3 or 4 times or 2 times a week. So HbA1c has to be done every 3 months. This is a study showing the relation of HbA1c with the frequency and even the hypos with the frequency of SMBG. CGM, this is a great ray of hope for the patient. CGM, this is 2 types, real-time CGM and intermittently viewed CGM. हम patients के अंदर who can afford, हम उनको ये intermittently view CGM जो है, we offer that. और as the cost is high, so you can just tailor it कि अगर वो ये CGM intermittently viewed जो कि Libre Freestyle के नाम से आती है, अगर वो use करें, so they can have a sensor for 15 days. They may not apply the sensor for another 15-20 days and then they purchase another sensor. So they will have a fairly good idea. These are the glycemic targets जो कि ये courtesy to ISPAD के हम जो अगर CGM की बात करें तो time in target range children के अंदर 70 to 180 है, अगर हम SMG की बात करें तो 70 to 180 milligram per deciliter is the target. And if we talk about the CGM, continuous glucose monitoring, then 70% of the time should be in the target, जिसको हम time in range कहते हैं, और less than 5% should below target, TBR, time below range, and almost 30%, और उसमें भी 250 से ऊपर कोई reading नहीं है. But this is again very challenging, or very few patients they are able to achieve it. So there are further challenges contributing to achieving good glycemic control. इसमें से कुछ पे हम बात कर लेते हैं. So hypoglycemia is very important acute complication. नुकसान ये है कि ना सिर्फ it causes anxiety और पेरेंट्स बहुत डर जाते हैं, but it is also a limiting factor for optimal glycemic control. But special बात क्या है बच्चों के अंदर less than 5 years, that it is associated with decreased cognitive functioning. Even mild to moderate hypoglycemia may affect cognitive function with an impact on academic achievements and social well-being. आजकल हमारे पेरेंट्स बच्चों के स्कूल के लिए इस कदर जो आप समझें कि दे आर सो मच कंसर्न्ड कि वो उनकी लाइफस्टाइल की भी परवाह नहीं करते. जो डॉक्टर आसिमा ने बताया कि हेल्दी लाइफस्टाइल फॉलो नहीं करते. सुबह वो स्कूल जाते हैं, फिर ट्यूशन जाते हैं, फिर से पारा पढ़ने जाते हैं, फिर मोबाइल पे बैठ जाते हैं. So they don't have any time. So, but we have to explain that hypoglycemic seizures, for example, results in significant decline in verbal abilities, memory skills, and ability to organize and recall information. The studies have shown that early onset diabetes is associated with lower cognitive scores. So, our main key aim in managing diabetes in childhood and adolescence is to allow optimal growth and development. So, the dietary strategies, they are similar to those of any healthy child, and they are the proper proportion of carbohydrate, protein, fats, water, vitamins and minerals have to offer the patient. क्योंकि सबसे पहले माँ बाप का सवाल ये होता है हम क्या खाएं और हमने क्या ना खाएं, छोड़ने पे बात करते हैं. सो विद इतनी फ्लेक्सिबिलिटी जो MDI है, मल्टीपल डेली इंजेक्शंस, बेसल बोलस रेजिमेंट्स में दे हैव एडेड टू द फ्लेक्सिबिलिटी ऑफ मील्स. तो ऑलमोस्ट हेल्दी जो बच्चों की वही डाइट है हमारे टाइप 1 डायबिटीज़ की. उनको चूँकि ये चीज़ें समझानी है कि बैड कार्ब्स क्या होते हैं स्कूल्स में, वैसे भी समझाने की ज़रूरत है गुड कार्ब्स क्या होते हैं. सो हम वी आर डीलिंग विद चिल्ड्रन, सो उनको इस तरीके से समझाना पड़ता है. और आई शुड बी क्विक. कार्ब्स इंसुलिन रिलेशन हमारे पेशेंट्स को कई दफ़ा समझ नहीं आता. मैंने कई दफ़ा देखा है इंसुलिन किसी और वक्त लगा रहे होते हैं और मेन मील किसी और वक्त दे रहे होते हैं बच्चों को. तो ये उनको समझाना है. कार्ब्स काउंटिंग, उसके मैं आगे आती हूँ. मेथड्स ऑफ कार्ब्स काउंटिंग, एक तो डेवलप्ड वर्ल्ड के लिए कि आप फूड को वे कर लें, लेबल पढ़ लें, बट दिस इज़ नॉट फॉर आवर पॉपुलेशन. सो हमें क्या करना पड़ता है, हमें गैस्टिमेशन पे चलना पड़ता है. हमें उनको समझाना पड़ता है कि हर तरह के कार्बोहाइड्रेट्स में 15 ग्राम कार्बोहाइड्रेट हो सकती है, बट पोर्शन साइज़ के ऊपर देखना है. तो ये डिफरेंट पिक्चर्स हम उनको देते हैं कि इस पोर्शन में इतना. आई एम सॉरी, बस इसको हम जल्दी से समेटते हैं, इसको स्किप करना है. कैन आई हैव 2-3 मोर मिनट्स? इसको मैं गुजार रही हूँ. ठीक है. प्रोटीन डाइट्स को पहले फ्री फूड्स कहते थे और शुगर फ्री से बचना, बिकॉज फ़ौरन उनका ख्याल शुगर फ्री की तरफ आ जाता है कि जो बिल्कुल शुगर फ्री नहीं है. लाइक इसमें देखें कि आप कितने कार्बोहाइड्रेट्स हैं. सो हेल्दी प्लेट, फाइबर रिकमेंडेशंस दे आर ऑल्सो इम्पॉर्टेंट. फिज़िकल एक्सरसाइज पे मैं बात करूँगी कि ग्लोबली लेस दैन 10% ऑफ यूथ जो है दे आर कंप्लाइंग विद द इंटरनेशनल मूवमेंट गाइडलाइंस. सो इसके लिए 60 मिनट्स पर डे ऑफ मॉडरेट टू विग्रस इंटेंसिटी एक्सरसाइज, मेनली एरोबिक. और एक्सरसाइज हम क्यों नहीं करते ये आप देख सकते हैं. हम कैसे करें, बच्चे बाहर ही नहीं ले जा सकते, ज़माना है डॉक्टर साहब बच्चों को बाहर भेजने का. तो एक्सरसाइज पे हमें ये करना है कि सस्टेन्ड और एरोबिक जो एक्सरसाइजेस हैं वो BGL को लो करती हैं, तो आपने उसको कार्बोहाइड्रेट देकर भेजना है. और जो एनारोबिक एक्सरसाइजेज हैं जो एडोलेसेंट्स करते हैं जिम वगैरह, उससे आपकी BGL हाई हो सकती है. So type 1 diabetes is a multidisciplinary team approach. Everyone has to speak one voice. कि कोई कह रहा है नहीं कोई बात नहीं 10% भी HbA1c है, ठीक है, कोई कुछ कह रहा है, कोई कुछ कह रहा है. सो पेशेंट कंफ्यूज हो जाता है. ग्रुप एजुकेशन हम कर लेते हैं बच्चों की. इस तरह OPD में सारों को इकट्ठा बुला के हम उनको कहते हैं, बच्चों से सवाल पूछते हैं और देखें वो हाथ खड़ा करके जवाब देते हैं और दे आर मोटिवेटेड. और एजुकेशनल मटेरियल की बहुत कमी थी. So I wrote a book in Urdu for type 1 diabetes, me and my team. Psychological issues, they are, you can well understand कि anxiety, eating disorders और adolescents के अंदर rebellion behavior and खुद ही मिस कर देना डोज, मैं पतली हो जाऊँ. So these are all very common. Family, unfortunately हमारे यहाँ combined family system है, लेकिन जो हमारी observation है उसके अंदर सपोर्ट कम है और कॉन्फ्लिक्ट ज़्यादा है. हमारे लाइक दिस यंग गर्ल, इसको इतना सोशल स्टिग्मा फील होता कि शी डेवलप रेटिनोपैथी बिकॉज उसको अपनी भाभी के सामने इंजेक्शन लगाने से शर्म आती थी, वो छुप के बाथरूम में लगाती थी, अभी भी ऐसे ही कर रही है. सो बाज़ माएँ इतनी जो है अनएजुकेटेड होते हैं, हम छोटे छोटे बच्चों को खुद सिखा रहे होते हैं. इसी तरह ये बच्चा चाइल्ड लेबर करता है बेचारा, क्या करे, और अनफॉर्चुनेटली ही लॉस्ट हिज लाइफ. सिमिलरली poorly controlled diabetes की वजह से malnutrition और associated diseases like celiac disease, they are often unrecognized. These complications are all seen in our patients. ये बड़ा एक frequent scene है जो बच्चा कुछ देर के बाद आए कि एक ही जगह पे इंजेक्शन लगाने, क्योंकि कुछ देर के बाद ना माँ बाप बिल्कुल लापरवाह हो जाते हैं, ख़ासतौर पर अपनी ब्रेड विनिंग के अंदर पड़े होते हैं, तो एक ही जगह लगा लगा के ये लिपो हाइपरट्रोफी हमें देखने में मिलती है. पोअर डाइटरी हैबिट्स, कॉम्प्लिकेशंस को हमने देखना है इसमें, और ख़ास तौर पे जो ऑटो इम्यून. सो हर एज के डिफरेंट चैलेंजेस हैं और हमने उसको हर एज के मुताबिक डील करना है. समरी इज़ टू समराइज, इट इज़ टाइप 1 डायबिटीज़ इज़ एन इंक्रीजिंग प्रॉब्लम इन चिल्ड्रन वर्ल्ड वाइड. हमारे पास डेटा नहीं है क्योंकि जो पुअर लिखा हुआ है कि पाकिस्तान में बहुत थोड़ी टाइप 1 डायबिटीज़ है. इट्स प्रॉबेबली बिकॉज ऑफ द हाई मोर्टेलिटी एंड ऑल्सो बिकॉज ऑफ द पुअर केस असर्टेनमेंट. सो मैनेजमेंट प्रायोरिटीज़ एंड सेल्फ मैनेजमेंट इश्यूज चेंज ओवर टाइम. जैसे कि अब हमारी जो HbA1c है वो 6.7% से कम कहते हैं. साइकोलॉजिकल और इमोशनल डिस्ट्रेस इज़ हाई एट द टाइम ऑफ डायग्नोसिस फॉर बोथ पेरेंट एंड चाइल्ड, एंड देर आर वेरियस फिजिशियन रिलेटेड चैलेंजेस एंड पेशेंट रिलेटेड चैलेंजेस. क्योंकि कई दफ़ा पेशेंट आके पूछता है ये फिर भी शुगर कम क्यों होगी और फिर भी शुगर ज़्यादा क्यों होगी. सो दिस इज़ द एनुअल डायबिटिक मेला. वी यूज टू have an annual diabetic mela which was an awareness and entertainment activity. क्योंकि बच्चों को ऐसे सिखाना बहुत मुश्किल है, उनको हम खेल खेल के अंदर एक मेला करके उनको बुला के तो हम उनको टाइप 1 डायबिटीज़ की अवेयरनेस देते थे, टू मेक देम हैप्पी, टू मेक देम मोटिवेटेड एंड टू हैव अ बेटर मेटाबॉलिक कंट्रोल. थैंक यू वेरी मच.
Thank you, madam, for such a super talk about the management of type 1 diabetes and addressing the challenges. Of course, the diagnosis of type 1 diabetes in time and proper management, particularly starting the insulin with a good regime and perfect diet advice, is key to the success. And there is not an option of pre-mix insulin, please remember this. As a moderator, basically there is a huge knowledge on the stage which is for you, तो sometimes it is difficult to absorb, या बाज़-औक़ात बैठे बैठे कुछ लोग सो जाते हैं या सोने के करीब पहुंच जाते हैं, तो इसके लिए एक छोटी सी नज़म है, just to enlighten you people. Enlighten means to make you people light. मीठा नापैद हो गया है अब ज़माने में, मीठा नापैद हो गया है अब ज़माने में, एक चम्मच भी मयस्सर नहीं है खाने में. सारी शीरीनियाँ मना हैं यहाँ, सारी शीरीनियाँ मना हैं यहाँ, बंद हो गया हूँ एक कैद खाने में. वो जलेबी को देखकर ना रुकना. प्रोफेसर तारिक साहब, बल्कि मैं खुद, आई हैव गॉट अ वेरी मच स्वीट टूथ. वो जलेबी को देखकर ना रुकना, जिक्र अब रह गया फसाने में. चाय पूछें कोक या काफ़ी, दोस्त सब लगे हैं सताने में. तालियां बजा दें, आप सब लोग इतने महव हो गए हैं. Our next speaker is Professor Dr. Shahid Mahmood. He is from Lahore. He is retired professor of medicine. He has been the fellow of Royal Colleges of Physicians of London, Glasgow and Edinburgh. He has got vast experience in postgraduate and as well as undergraduate training. He has got a vast experience in the management of diabetes, cardiometabolic diseases. He had been a great speaker. It is always a treat to listen to him. Please welcome Professor Dr. Shahid Mahmood. And his talk is about evolving pathophysiology of diabetes mellitus. Thank you.
Thank you, sir. Shukriya, boss. Thank you, sir. Assalamu alaikum rahmatullahi wa barakatuh. Just give me less than 30 seconds because I had to get the password from my wife. So I just called her and I said, what is the password? She said, oh, this is the password. So I'm just going to put it and I hope it works. कैसा फिर तारिक साहब मैं और आप एक ही बोट में हैं. So okay, before I get on to the topic, I think I feel very strongly that I'm actually going to be presenting a summary of the past two speakers because itna boring subject ke pathophysiology, what I'm going to do with the pathophysiology, it's going to be the same as always you've been listening. But I'm trying to give a different spin. But before I get on to my talk, the clock is ticking. Before I get on to the talk, let me just ask you one question, very important, to the panelists and to all my friends. What is the normal upper limit of the HbA1c? 5.7? You kick off from 5.7 to 6.5, 6.4, you fall into the category of pre-diabetes. The ADA tells you keep it below 7. Would you like to be 7 if, God forbid, you become diabetic, or 5.7? I would like to be 5.7. So there is something terribly wrong with type 2 diabetes. Bear that in mind. Because I think the strategies which we are going through at this point in time are not really targeting to the outcome. With the same context, one compliment to the organizing committee. But I was just thinking when the first speaker, Dr. Asma, gave the talk, that instead of this primary care diabetes association, it should be primary care pre-diabetes association. Kaisa? Theek nahi hai? I think this should, because the bottom line is once you are diabetic, it's there. So we should really be having a pre-diabetes association. So I'll be the president. So ek aur bana lo. Okay. हाँ मैं रिवर्सल पे आ जाता हूँ. That's good. और दूसरी चीज़ ये है कि glycemic control is one thing. One of the slides was shown by the first speaker, the glycemic control is 50% achieved. Fine if it is achieved 50%, but that is not the point. The point is what is the outcome data? What is the vascular outcome of the thing? How many people, in spite of the fact they have actually achieved the HbA1c, but still dribble off the court, they still die. It's not smoke in the mirror, it's a reality. So I think there is something wrong. Look, okay, right, without wasting any further time, with the name of the Allah Ta'ala, you must know where the speaker comes from. I am actually born and brought up in Lahore, और जेड़ा जिन्हें लाहौर नहीं देखा जम्मिया नहीं, तो जेड़ा जम्मिया नहीं उदा हिसाब ही कोई नहीं. So जन्नत वाले दिन you are okay. Okay, evolving pathophysiology of type 2 diabetes. This is a little token of my introduction. I've actually trained in UK. I'm still partly between UK and here, and I'm actually holding an office in one of the private hospital in Lahore. Okay. You must be watching these days the Al Jazeera war on Gaza. This is as bad as that, or maybe even worse. This is war on diabetes. Quickly, the statistical data at this point in time is 40 million people in the world, and as the time passes by, it will be somewhere about 783, 2045. And it basically tells you that the 46% of the person will become diabetic. Why? We have so many associations here. I mean, and Pakistan is still getting on the top number. Tariq Saab, I think we need to roll up our sleeve and put our nose in there. I think we should be doing better than what we are doing with all these organizations and meetings. I think the public awareness is still really down to level 0. I would say so. Because if the Pakistan is going to come onto the first stage, there's something terribly wrong with us. We are the one who to be blamed, including myself, because I think we are not delivering what we should be delivering to our population, general population. This is extremely important, and I will request the panelists to pass a notion on that one, that the public sector awareness is the most important. Our knowledge, I would say, fine, it's okay, but this is my point of contention here. So it is always a learning brain, and thank you for the organization. We always learn. It's a two-way track. It's not just that I'm delivering the talk and you're listening. It's actually the both ways. This is what it shows, the genetic predisposition of the pathophysiology. So I always say one dialogue, which has actually been said by one of my Gora colleagues as well. If you are born with a poor father, that's your bad luck, because you can't change your father. But if you have a poor father-in-law, you're very stupid. So I think you need to choose a wealthy father-in-law. Okay. Diabetes, first ever paper published. Taking back you to 1920, this was the first paper published. Again, saying that eating fat is perhaps one thing which could perhaps help you. But as the time passes by, there is something about fat. But this is not as true as it says here. So 460 BC, diabetes, it's been ages, and we know, और आजकल तो बूफे शुरू हो गया, eat as much as you can. उसके नीचे लिखना चाहिए कि eat as much as you can, and would you like to have a, what you call, subsidized bypass, coronary bypass as well. So this is what it is. This is the bottom line of the pathophysiology starting off. Prolonged positive caloric balance. It's a balance between energy and the output. It's a disorder, prolonged positive calorie balance leading to fatty liver and fatty pancreas. I think we have some topic on the fatty liver as well on this meeting. I'm not sure, but we do need that one, because that is the primary factor in the pathophysiology coming up. I'll take you along. Breaking news way back 1947. I think it's readable. 1947, it was basically come down that yes, there is something about the obesity and the upper obesity. When we say the upper body obesity, basically we are pinning down to the central obesity. Who is this guy? Anybody? Okay, anybody who has visited Boston? It is the Massachusetts Diabetes Center, the Jocelyn. This is the Elliot Jocelyn, and he says, from an excess of fat, diabetes begins, and from an excess of fat, the diabetic patient dies. Absolutely true. And as we go along, we'll tell you. I'll have to keep looking at the clock as well. So, how the world has changed, we'll race through what has been already said. This picture was actually just got the glimpse of by Dr. Hina, and this is true. But what it is, sitting disease. The common pathophysiological changes is coming up from the sitting. It's a recipe to avoid obesity in teens. So you need to lessen the screen time and more steps. That's the message you should be taking. And again, with all of us, we should do something about television advertisement. For heaven's sake, this is what it is. There are a lot to be talked about it. TV के ऊपर ऐसी advertisement आती हैं which basically support people to become diabetic. So Coca-Cola, and I love the tune of this background which says Alma Coca-Cola pila de. I think you must have this is something worrying, which was basically shown by Dr. Hina, the type 1 diabetes. But now the concern is, I see a lot of patients with the type 2 children in the age of something like 14, 15, and they basically are type 2. So emerging concepts beyond the beginning, inside story. What is the inside story? This is basically the inside story. If you remain slim, thin, this is basically the, but once you start to get obesity, that's what it. My presentation generally are self-explanatory. I don't need to really give a word is more than 1,000 words. So that's what it is. BMI, body mass index, and this is the emerging pillar for the cardiovascular prevention. At this point in time, the strategies for hypoglycemic approaches are not just pinning down to HbA1c control, it is basically the cardiovascular prevention, and that is where your GLP-1 and SGLT2 and all those blah 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 comes up. BMI Asian cutoff points is different. That's the take-home message. Is Asian type 2 diabetes is different from West? I'm not saying is Lahori diabetes is different from Karachi. So I think Dr. Zahid will perhaps throw light on it, but I think it is perhaps different from Lahore and Karachi as well. क्योंकि आप लोग बहुत बड़े मेहमान नवाज हैं, अमा और खाओ तो इस करके. So, okay, this is important. This is important for all of us to know, because of the fact that the cutoff point for the Asian diabetics when we talk about the overweight in the West is 27. In Asian, it's 23. And the obesity is 30 for the West, and for Asians, it is 27. So don't put your money onto your BMI of the West. And it basically also tells, so all you need is for pathophysiology to know, you basically need a theta, you know. So if you measure your waist circumstance, you would know where. Obesity, mother of all diseases. And once you get the central obesity, I think these are the metabolic disturbances you start to get on, and you know, we all know that. Now, why Asian is different, and I personally think it is different, because we are small structures, और जब आप बहुत ज़्यादा खा लेते हो, more than you are actually exercising, then what happens is your fat starts collecting subcutaneously. और हम छोटे बंदे हैं as opposed to goras, so we have a smaller space for subcutaneous deposit of the extra food we take. So that is आपकी तौन निकलनी शुरू होती है. तो चौधरी साहब को कहेंगे जनाब, you know, get rid of this तौन, तो कहना फिर मैं चौधरी किस बात कर रहा. So you know, there is a concept of the culture as well. But then all this fat basically gets down to your liver and to your arteries, and the liver gets a fatty liver. And once you start to get the fat, this is very important. Adipocytes, and where this is actually, so it gets into the muscle, gives you the insulin resistance, into the liver, and it gives you the hepatic glucose production, into the pancreas, and it decreases insulin, and then artery, this is the death point, this is the culprit. So it's a wrong fat in the wrong place, adiposity. So this is the lipotoxicity versus glucose toxicity, everything, whatever you want to call it. Okay. So insulin resistance, beta cell dysfunction. 8 minutes more left. I'm trying to bang on if I could. It's basically is a dual thing. Do we have a pointer here, please? Quick, Cheti. Okay, there we are. Okay, this is where we start. Once you start to get obese, your insulin basically gets increased. You get insulin resistance. The insulin is not working. And the pancreas starts to get a push. So the pancreas is working more and more. And then eventually what happens is the pancreas basically stops secreting, compensating the insulin, and the patient becomes diabetic. So what happens is, like the Dr. Hina was saying, that people basically come in the decay, they actually travel that distance. So they get from the IGT to the pre-diabetes to the diabetes and all that. So anyway, so I'll get to the main things, what is important. So type 2 diabetes, is a chronic disorder, progressive disease characterized by hyperglycemia, insulin resistance. By showing this, there is also one message. One modality treatment does not matter. Generally, Pakistan में क्या होता है, वो कहता है जी मैंने से metformin लेनी शुरू की, everybody takes metformin. One modality does not affect everybody, and within the same individual, one modality does not remain as such. It's a moving target. And actually, these are the summary of the pathophysiology. It actually affects the muscles, it decreased glucose uptake, it's the liver, increased hepatic glucose production, brain, there is a neurotransmitter dysfunction. So it's not just the pancreas, the beta cells, it's all these systems are also involved. I'm sorry because, you know, this bothers me because I don't really want to take the more time for the other people. So I'll race to these ones because we all know that. Pancreas, you have alpha glucagon, production is increased, beta cells, the insulin is decreased and all, and adipose tissues. Okay, so from tributate to it's an octopathophysiology. And once you have the insulin resistance resulting in the multifactorial syndrome, you start to have from obesity, you start to have a high blood glucose level, you have a high blood pressure, so this is basically is all there. One important point is the urine protein. Please make sure all diabetic patients of yours basically start to get at least a microalbumin urea done. Once you have a proteinuria, you are as bad as having a coronary vascular disease setting, and the eyes examination. That's just a take-home message. Then quickly taking you along, the first day when I think you all have known that one, the first day when the people become diabetic or known to be diabetic, at least 50% of the beta cells have gone, and every 1 year, 4% of the beta cells go down in a diabetic patient. In generally, 1%. So 4% in a diabetic patient. So you can imagine, sit down the line around 10 years, all of the patients would need with or without insulin and with the hypoglycemic agents. UKPDS showed 50% had on the first day at the recruitment, okay, they're already sitting on the macrovascular and microvascular disease, okay. So this was a wake-up call around the world. This basically was, this was way back December 1977. I was a child then. Question, after age 60, this is important. I think the next 4 minutes, 15 seconds, I'll finish up. At age 55, 60, there's a hike of the diabetes number, type 2 diabetic patients in the world, all over. Why? Why this happens? Why there is a sudden increase in diabetes? Has anybody heard this, the sarcopenic obesity? No. Okay. Elderly patients, aging. You know what happens? Interesting. Once you age, your muscle mass goes down. आप देखोगे बाजू लटकने शुरू होते हैं, body लटकने शुरू. So you have a disparity or the reversal of muscle mass goes down and the fat mass comes up. So your body fat mass is relatively 70% to almost 30. आप जाके अपने दादा दादी को देखिएगा, this is what you see. And once you have this one, then you have all the factors which basically affect the people when they were youngish type 2 diabetics. So बूढ़ों में, this is what it is. And this is what exactly, I don't know how many of you read Quran through Tarjma, but go back, take my word for that. Go back, read Surah Ar-Rum, Para 21, Ayat 54. मैंने तुम्हें ज़ोफ़ से पैदा किया है, all the word, throughout. बादन ज़ोफ़ कुवा, फिर तुम्हें मैंने जवानी दे दी, कुवा. बादन कुवा, सुम्मा ज़ोफ़ व शीबा, और उसके बाद तुम्हें दोबारा कमज़ोर कर दिया और बढ़ापा दे दिया. And this is the way Allah Ta'ala says, this is the way I work. Go home, read Surah Rum. This will tell you what is sarcopenic obesity is. This will tell you why people at the age of 60 actually start to get a hike of type 2 diabetes. I thought this was my most important message to you, that follow Quran, it will tell. And then there is another one thing, Surah Bani Israel, ayat number 23, 24 and 25. माँ बाप बूढ़े हो जाएं, उनको उफ तक ना कहें. Why? कौलन करीमा, उनसे बड़ी मोहब्बत से बात करें. रब्बे रहमहुमा कमा रब्बयानी सगीरा. So all these things basically, but what makes them to die, dribble off the code, is cardiovascular matter. So the culprit is through the pathophysiology of the obesity, with the inflammatory markers, with the fat, with the food, all the risk factors, which Dr. Asma also told you, is the atherosclerosis. Microvascular, macrovascular, and it is often underestimated. And the culprit lesion is it different from the diabetic? Or do we have a cardiologist sitting here? If not, this is the question you should ask. Is the diabetic coronary artery disease different from the people who are diabetic? And I tell you, surely it is. So, catch-22. How many of you understand catch-22? Anybody who knows catch-22? पहले अंडा आया था या पहले मुर्गी आई थी? This is catch-22. Okay, so what comes first? Obesity comes first, or this is food for thought? Once you go home, you can actually look into this. 52 seconds. Message is time to wake up. I think you're already up anyway. So, can we predict the... I will just take maybe 1 or 2 minutes more with the permission of you, sir. Can we predict the chances of getting type 2 diabetes? Can we predict it? One, we know, if you're obese and all that. But the point is, यहाँ बैठ के can you tell how many people you could be getting? This is the answer. Okay, age, family history, BMI, and waist circumstances. 76% of the patient, without doing a blood test, I could tell you that there is a chances of becoming diabetic. Age, family history, BMI, and waist circumstance. Then on the top, if you have a fatty liver, ultrasound, lots and lots of people will tell you that you have a fatty liver disease. We're done with the 100 rupees. Okay, 2 minutes more. Okay, so once you have a fatty liver, look into the AST, making sure that they don't have any hepatic thing like hepatitis C or B or whatever. But if they have a rising AST, check the fasting blood sugar level. As the AST goes up, as the fasting liver goes up, as the fatty liver goes up, you will get the know that the people are getting diabetic. And this is a sign for insulin resistance. Very simple. So we really have to nip the evil in the bud. Okay. Does time matter? Early versus late diagnosis. Once you miss the boat, go, just one thing, Surah Tahreem, Ya ayyuhalladhina amanu tubu ilallahi wa tawbatan nasu. ऐ लोगों मरने से पहले तौबा करो, सच्ची तौबा करो, तो अल्लाह ताला बख्श देगा. But this damn disease, you do it late, there is a legacy effect, there is a bad metabolic memory. So the duration matters. I am very precious, so don't miss the boat. It's a silent killer. Make sure that you are basically get the things done. Poor socioeconomic countries, Dr. Asma said, and cost consideration, absolutely true. And one of my friend doctor was saying today that nobody runs in the family. That's true. And physical workout is the cheapest medicine. You know, the West is bringing so expensive medicines for type 2 and knowingly that out of 4 diabetic in the world, 3 are in the poor socioeconomic disease. So take home message is just one. पर इसका ये मतलब नहीं कि लड़की मोटी हो तो लड़का शादी ना करे, प्लीज़, क्योंकि हमारी क्लिनिक पे तो ये बड़े मसले आते हैं कि डॉक्टर साहब इसको पतला करें, शादी नहीं हो रही. So that's not my job. So anyway, with the best thing is the prevention of the diabetes, and this is the time. It starts from the intrauterine to the. Go back and read Surah 3. लक़द ख़लक़नल इंसान फ़ी अहसन तक़वीम. मैंने तुम्हें बेहतरीन मोड में पैदा किया है. But if you let go, your slip out of your hands the time, and you make yourself out of figure, that's what it happens. So one using that clock, and the other using this clock. So this is the last slide to say, dance before the music is over, live before life is over. I think this is very important. And this is Surah Munafiqun, by the way. Go and read Surah Munafiqun. लोगों खर्च कर लो जो भी है इससे पहले कि तुम्हें मौत आ जाए और फिर तुम कहो कि मैं सदका खैरात करूं और स्वालिहीन में से हो जाऊं. But it is only once. So your life is once. Your diabetes is, if you're diagnosed, please make sure that you actually clamp blood pressure, glucose, weight and all that. So with this, thank you to the organizing committee and thank you so much. It's been utmost pleasure. Thank you so much, thank you. So I think the question answers are going to be, oh, it's now or never. Kaisa? Would you like the other speakers to be here? उनको बुलाना, आप आए ना?
Question answer का session अब I would definitely start now. I would like to say thanks to Professor Shahid for such a nice presentation. If anybody has got any question, you can please ask. My other two colleagues, can you please come to the stage? The previous speakers, if the people have got any question, you may answer that.
Hello. Sir, I'm Dr. Kaisar. I have a question. Wonderful presentation, all of three. Dr. Shahid and Dr. Saba, what is the role of vitamin D in reducing insulin resistance and to avoid type 1 diabetes? Both of you, please.
जी थैंक यू वेरी मच। वो जैसे मैंने आपको उसमें स्लाइड में बताया था कि नाउ स्टेजेस ऑफ डायबिटीज़ दे हैव बीन कैरेक्टराइज्ड, और कुछ प्राइमरी प्रिवेंशन स्ट्रेटजीज़ जो हैं वो मेनली डाइट के बारे में हैं। तो पहले जो स्ट्रेटजीज़ प्राइमरी प्रिवेंशन के लिए ऑफ टाइप 1 डायबिटीज़ के लिए यूज़ हुई हैं, जिस पे स्टडीज़ हुई हैं, दे वर फॉर एग्जांपल लेट इंट्रोडक्शन ऑफ काउज मिल्क, लेट इंट्रोडक्शन ऑफ व्हीट एंड मैनी अदर। ब्रेस्ट फीडिंग ऑफ कोर्स हैज़ अ रोल इन रिड्यूसिंग टाइप 1 डायबिटीज़। फिर इसी तरह बोवाइन मिल्क में इंसुलिन का कंटेंट उसको रिड्यूस किया गया और उसका इफ़ेक्ट देखा गया। नाउ दिस विटामिन डी स्टडी इज़ ऑन गोइंग, ये स्टडी चल रही है और जब रिज़ल्ट आएंगे तो फिर हम शेयर कर सकेंगे। एंड उसके अंदर दो चीज़ें हैं, वन इज़ डेली सप्लीमेंटेशन एंड सेकंड इज़ मैथ सप्लीमेंटेशन। उसके ऊपर भी अभी ऑन गोइंग स्टडीज़ है। डॉक्टर शाहिद अगर इस पर कुछ लाइट डालना है।
Very tricky and very difficult question to answer. There is the backup data coming up on that one. But what exactly is the pathophysiology and how it gets corrected? I don't think so. We actually, even in the word at the moment, we know. But the bottom line is, yes, you treat vitamin D. You know why? Once you cross 50, 55, the sarcopenic obesity basically have more predisposition for people to get the fractures. So for fractures, any of the orthopedic people, anybody would tell you, look into your bone study. And the bone study when you do is basically is calcium, vitamin D and alkaline phosphatase. So I think it is extremely important for even for diabetes as well, both for type 1 and type 2. But I'm sorry, we do not, if you ask me the next, I know you would going to ask, how does it work? I don't think so. We know the pathway through which once you correct it and then how it actually corrects the insulin resistance. Maybe Dr. Zahid would be able to tell that. I don't know. Yeah, this is what I'm saying. But how? This is what I'm saying. I've already said that definitely it will decrease the insulin resistance. But how does it? That I don't know. Unless somebody from the panel, somebody said. Dr. Tufail is sitting here, so. Yeah, maybe preservation. I mean, it's all, you know, tukka. Okay.
Shahid, I'm here. Right.
Itna bada banda chota nahi la raha.
Wonderful presentation. Obesity, sarcopenia, and aging. They've added one more factor to arthritis.
Is
because
what?
Arthritis.
Yes.
Right. 60 plus diabetes, one of the component because arthritis also initiates so much of pro-inflammatory and inflammatory things, and the incidence, the rate of death in diabetic who have arthritis is 4 times higher as compared to those, and with this it includes osteoarthritis as well. So you have to look after your liver, your fat, and your bones as well.
Oh, absolutely.
And joints.
Yeah. Because the problem is the clock on my head. Clock. This was the issue. We could have gone on for hours on the sarcopenic obesity, because that is basically is the current latest concerning point for the people above the age of 50. How come they actually die? And the other thing I would really like to say here is, you have to, you know, one of the, I think, pata nahi aap mein se kisne kaha, duration of diabetes. This is so important. If somebody walks into your office and he tells you, I have a diabetes of 20 years and a smoker, no chest pain, nothing of the sort, ECG, echo clear, you get the angiography done, more than 50% people will have the coronary artery disease. Take it from me. So the duration, hyperglycemia into time is equal to complications. Thank you, Tariq, for bringing up. That's absolutely true. I fully agree with you.
Thank you very much. This is the last question, please, sir. Mic de den, sir.
Sir, question hai mera. Sir, Dr. Ramesh, family physician.
In diabetes mellitus, can you highlight, please? Is there any role of fear, apprehension, tension, and depression in the diabetes mellitus, sir?
Okay. Very common problem and very important thing as well. It's not the cause, make sure, but it can actually make it worse. There is no studies at the moment which say कि जी depression ऐसा तो पूरे पाकिस्तान में तो मेरा हाल 90% को शुगर हो जाएगी अगर depression. It could actually make the diabetes worse, the control, but I don't think so. It is basically is the cause. But the people are at a much higher rate of getting coronary artery disease, particularly macrovascular disease, the strokes and the coronary arteries and the amputation, the macrovascular. The micro with the depression is perhaps not that much common. So,
सर कार्टिसोल का तो इसमें है, अगर एंजाइटी डिप्रेशन में होता है बंदा तो उसका कार्टिसोल बढ़ जाता है, कार्टिसोल बढ़ने से तो
diabetic patient is candidate for, yeah, obviously. I mean, you know, these are the pathways through which your diabetes, cortisol basically is not the cause as such, but it can make your diabetes get worse. There are a lot of people who get the cortisons and their diabetes is absolutely perfect. But yes, cortisol will make you temporarily diabetic. जैसे कई लोग यहाँ पे हकीमों के पास जाते हैं, arthritis, ये वो, asthma. You stop there and their diabetes gets reversed. किसी ने यहाँ पे सवाल किया था.
The chair will arbitrate.
सुनाओ जी, थोड़ी देर सुनना है.
एडवांटेज भी होता है. इशू तो इतना इंटरेस्टिंग है, मेरे ख्याल में अगर 4 घंटे ना और लगे रहे ना तो और सवाल पूछते जाएंगे. टाइम की भी कंस्ट्रेंट्स होती हैं इन कॉन्फ्रेंस के लिए. मेरे ख्याल में डॉक्टर अहमद शौकत आखिरी सवाल करेंगे और मुझे पता है बड़ा ब्रीफ होगा.
थैंक यू जी.
और जवाब भी ब्रीफ होगा.
Thank you very much, sir. Thank you for giving me this opportunity.
आनंद शुक्रिया अदा करिए. थैंक यू जी.
It's very nice to listen to you, Dr. Shahid, always. Thank you very much for sparing time for coming over. I've got one comment and one question. You very rightly said it's about time to focus more on pre-diabetes than the diabetes part 1. So I would completely endorse this point, and I think all the organizations will be focusing in future more on pre-diabetes rather than the diabetes part 1. So thank you very much for raising this point. I want to know your experience, Madam and Dr. Shahid, on the role of SGLT2 inhibitors in type 1 diabetes mellitus. Now this question has been missed. We know शुरू से सवाल ये पूछा जाता है कोई दवाई देनी है कि नहीं देनी. हमने टाइप 1 में जवाब ये होता है कि इंसुलिन के अलावा there is no treatment. What about your comments, experience, expertise on the role of SGLT2 inhibitors in type 1 diabetes mellitus? Sir.
1.5 minutes. देखें कर सकते कि नहीं.
Okay, quick and short answer.
जी.
Stick to insulin if all your target organs are fine and the patient is not getting weight gain on that, and particularly when we say the target organ is the kidneys. If your kidneys are fine and there is no issue with that, then you could carry on with it. But yes, if type 1 diabetics start to get coronary or they get the renal involvement, that is a very important time to look into if that can be helped. The only SGLT2 which has at the moment data which is FDA is going to be improved is the dapagliflozin.
Thank you very much.
इसका मतलब ये हुआ कि आइंदा से जब ये सवाल आएगा तो the answer or an MCQ if it is put in the CPSP question कि is there any drug which has got a role in type 1 diabetes, should the answer be yes or no?
Not yet.
Broadly, nahi na.
Not yet.
I am an advocate. Why I raise this point is because I think it's about time that we broaden our horizon and start thinking about this drug, because this drug has potentially got a good role in type 1 diabetes.
जी डॉक्टर आमिर generalized we cannot make a generalized statement. सिर्फ स्पेशल केसेस में कुछ ड्रग्स का रोल है, जैसे मेटफॉर्मिन अगर कोई इंसुलिन रेजिस्टेंस के साइन हो टाइप 1 डायबिटीज़ के अंदर. सो अभी तक जो स्टडीज़ इसको प्रूव नहीं कर रही कि इसमें कोई और रोल है.
Any question for Dr. Asma?
Thank you very much. I'm very much pleased to see such a enthusiasm from the audience. I would like that our panel of experts, if you have some opinions, just brief opinions, please. Thank you.
Any brief comment, please.
अस्सलाम वालेकुम एवरीबॉडी. सबसे पहले इतने खूबसूरत फंक्शन को ऑर्गेनाइज़ करने के लिए मैं शुक्रिया अदा करता हूँ फैसलाबाद चैप्टर का. इट वाज रियली वेरी गुड गैदरिंग. और इसमें इस गैदरिंग का फ़ायदा उठाते हुए आई जस्ट वांट टू मेक अ कमेंट एंड अ सजेशन। जितने अच्छे तरीके से ये ऑर्गेनाइजेशन काम कर रही है, अगर इसमें हम अवेयरनेस के हवाले से सोशल मीडिया प्लेटफॉर्म्स को यूज़ करने के लिए कोई सोशल मीडिया प्लेटफॉर्म डेवलप करें और उस पर एक्टिवली काम करें, तो बहुत सारी जो मिथ्स हैं, जैसे डॉक्टर आसमा ने कहा था, हमारे पास जो पेशेंट्स आते हैं रिगार्डिंग द डाइट एंड फिजिकल एक्टिविटी एंड डेफिनेटली दैट टेकिंग मेडिसिन और नॉट टेकिंग मेडिसिन, तो उसके हवाले से काफ़ी बेहतरी आ सकती है हमारी जनरल पॉपुलेशन के अंडरस्टैंडिंग में। तो मेरी सजेशन यही है कि एक एक्टिव सोशल मीडिया प्लेटफॉर्म डेवलप करके उसको प्रॉपर विजिबल किया जाए ऑन द सोशल मीडिया प्लेटफॉर्म्स, सो दैट आवर जनरल पब्लिक में हैव
नहायत मुख्तसर, वेरी गुड इनिशिएटिव, वेरी गुड सेशन एंड ग्रेट टॉक्स। सब बात प्रिवेंशन और पैथोफिजियोलॉजी की है, एंड आई थिंक वी शुड मूव ऑन फ्रॉम ट्रीटिंग डिजीज टू प्रिवेंटिव डिजीज टू प्राइमोडियल प्रिवेंशन। पाकिस्तान में ये पॉपुलेशन प्रॉब्लम है, कम्युनिटी प्रॉब्लम है, एंड एज समबडी सेड इट्स द पब्लिक हेल्थ एडवोकेसी विच इज गोइंग टू ब्रिंग द चेंज। हम डॉक्टर इलाज करके इसको ख़त्म नहीं कर सकते। दिस ऑर्गेनाइजेशन मस्ट जॉइन हैंड्स टू force the government and the society to change the policies and lifestyle habits so that we can prevent the disease. Primordial prevention is the key. Thank you.
As my colleagues have already said, primary prevention has the main role to play over here, because we don't have the resources to treat such a huge population which is being predicted who will have diabetes if we don't do anything for this primary prevention today. We have to use all our tools which are available to us: social media, walks, these events, public awareness sessions, and everyone has done an excellent job over here. And the audience, it was a very interactive session, and I believe people have a lot of questions which they can ask later on.
Bismillah ar-Rahman ar-Rahim. First of all, I feel honored and privileged to be here in this mini symposium, and for this I am grateful to the organizers for inviting me and taking care of us. This was a very nice presentations, all the three, and we have this epidemic of diabetes because we have 33 million people. Lot of people who have impaired glucose tolerance and lot of the people who are undiagnosed. On the other side, people who are diagnosed, they are not compliant to their therapy, and there is no monitoring. So important is prevention, awareness and education. Thank you.
जब आप किताब पढ़ना शुरू करते हैं तो इम्प्रेशन मिलता है कि जैसे जैसे आप पढ़ते जाएंगे चीज़ें सिंपल होती जाएंगी। ऐसे ही है ना आमतौर पर, स्टोरी टूवर्ड्स एंड चीज़ें क्लियर होनी शुरू हो जाती हैं। 4th ईयर स्टूडेंट 1968, ज़ाहत भी बहुत यंग है मेरे से, काफ़ी देर बाद गए कई में, तो डेविडसन आपने सबरी पढ़ी होगी, उसमें फिक्रा अभी तक याद है 1968 का मैंने पढ़ा हुआ। एक तो कैलोरीज डोंट कम फ्रॉम एयर, ओबेसिटी के हवाले से, और दूसरा डायबिटीज़ की अंडरस्टैंडिंग बहुत आसान थी, टू लिटल टू लेट, इंसुलिन सिक्रीशन। तो ये बड़ा आसान है कि इंसुलिन देते जाओ तो सारा मामला वो क्लियर आएगा। लेकिन एज वी हैव गॉन अलोंग, आप समझ आ रही है कि कितनी चीज़ें अब कॉम्प्लिकेट हो गई, और मुझे लगता है ये मुझे समझ नहीं आएगी। और दूसरा, कोलेस्ट्रॉल को भी कंट्रोल करें, ग्लूकोज को कंट्रोल करें, ब्लड प्रेशर करें, आर्थराइटिस ना होने दें, यू रीच 90, 100, 110। ये मैं ये नहीं कह रहा ये नहीं करना चाहिए, और नहीं करना तो हम क्या करेंगे? डॉक्टरों का क्या काम है, रिसर्चर्स का क्या काम है? यही है ना, दैट कीप्स अप द इंटरेस्ट, और फ़ायदा भी है। लेकिन ये कि इसका नेगेटिव पहलू भी ज़रा थोड़ा सा है, वो ज़रा थोड़ा सा जौली है। आप शायद हंसेंगे कि उन मुल्कों में यहाँ एज पॉपुलेशन बहुत ज़्यादा हो गई है, यूनाइटेड स्टेट इज़ वन ऑफ देम, तो उनमें कुछ मसाइल भी आ रहे हैं। जो यंग जनरेशन है वो कह रही है, प्लीज होने बड़ी इंपॉर्टेंट है, ये मेटाफिजिकल है बट वेरी इंपॉर्टेंट। यंग जनरेशन कह रही है वी हैव नो ऑब्लिगेशन, दे हैव दीज पीपल हैव आउटलिव्ड देयर यूटिलिटी, आई थिंक दे शुड गो नाउ इट्स आवर टाइम। तो ये मैं कहता हूँ ज़रा थोड़ा सा इन चीज़ों का भी ख्याल रखें। वो जो डॉक्टर शाहद ने कहा था ना, को मेटा फिजिकल चीज़ों को उसने टच किया है, इनकी बड़ी इंपॉर्टेंस है। अगर हम उनका ख्याल रखेंगे तो शायद हमारी ये फिज़िकल जो बीमारियाँ वो भी ज़रा कम हो जाएँ। और वो जो आखिर में सवाब मिलना वो तो है ही है, अगर गरीबों का हम ख्याल यहाँ रखेंगे तो जो सुकून हमें यहाँ मिलता है ना, शायद तो उस सवाब से भी बहुत ज़्यादा मतलब ये दुनिया में हमारे जल्द हो जाएगी। दूसरा लास्ट, मुझे डॉक्टर साहब आपकी बात बड़ी पसंद आई कि वी शुड फोर्स द गवर्नमेंट। आई एम वेरी ग्लैड टू से कि आजकल कम से कम गवर्नमेंट जो है बड़ी अमेनेबल टू सजेशन, कि जो भी आप कहेंगे वो मान जाएंगे। माशाल्लाह हालात आजकल बड़े कंड्यूसिव हैं। लो जी, विद दैट वी कम टू द एंड।
थैंक यू वेरी मच।
थैंक यू वेरी मच।
एक शेर मैं डेडिकेट करना चाहता हूँ प्राइमरी केयर डायबिटीज़ एसोसिएशन को। ये मसाइब ये दुख ज़माने के, ये मसाइब ये दुख ज़माने के, ये शुगर के बारे में कहा गया है। कुछ भी नहीं है अगर मैसर मुझे साथ तेरा होगा। तो प्राइमरी केयर फिजिशियंस आर द बैकबोन ऑफ द होल हेल्थ सिस्टम। In the end, I would again like to thank you for patience and a wonderful and involved audience, my panelists and my speakers. And I request my panelists and speakers to come on the stage to have a group photo, please.
Very good.
Thank you.
हाँ जी, इधर से जाना पड़ेगा।
अब हम सेकंड सेशन स्टार्ट करते हैं। सेकंड सेशन मॉडरेट करने के लिए मैं इनवाइट करूंगा डॉक्टर यूसुफ इकराम को। डॉक्टर यूसुफ इकराम FRCGP हैं और वो हार्वर्ड यूनिवर्सिटी अमेरिका से मतलब ट्रेंड हैं वहाँ से, तो वो हमें मॉडरेट करेंगे सेकंड सेशन के लिए। डॉक्टर यूसुफ प्लीज़।
Thank you, Dr. Ahmed Shahzad, for a very nice introduction. मैं कॉन्ग्रेचुलेट करूँगा डॉक्टर अहमद शहजाद, डॉक्टर एजाज़ अनवर, उनकी टीम को कि उन्होंने इतना अच्छा ये सारा सिलसिला अरेंज किया है। तो ये हमारा सेशन थोड़ा सा डिफरेंट होगा पहले सेशन की निस्बत। यहाँ पे इनामात हैं। तो CCL स्पॉन्सर्ड हमारे पास लैपटॉप, स्मार्ट वॉच और इसके अलावा एक टैब है। जिन लोगों ने अभी तक अपने कूपन्स नहीं बाहर लकी ड्रॉ के उसमें रखे, वो अपने काइंडली ज़रा कर लें। हम फर्स्ट टॉक के बाद लकी ड्रॉ करेंगे। तो इनामात हैं हमारे पास।
मैं मोनम से रिक्वेस्ट करूंगा, मोनम जो भी डॉक्टर्स रहते हैं उनका लकी ड्रॉ में कूपन डलवा लें बैठे हुए को प्लीज़, ताकि हॉल डिस्टर्ब ना हो, वो डलवा लें। आप शुरू करें सर।
अच्छा, तो एक टॉक्स शुरू करने से पहले मैं एक छोटा सा क्वेश्चन है, और जो सबसे पहले हाथ खड़ा करेगा वो ही जवाब देगा। तो एक शख्स है, उसके पास 30 चॉकलेट्स हैं, उसने 28 खा ली हैं, तो उसके पास क्या बचा? किसी को भी नहीं आता सर? जी, डायबिटीज़ बच गई सर। इसका मैंने सिर्फ जवाब ही लेना था, क्योंकि इसका इनाम नहीं है, मैंने कहा नहीं था इनाम वो लकी ड्रॉ वाला। जी ठीक ठीक। तो मैं अभी अपने जो पैनल एक्सपर्ट्स हैं उनको दावत दूंगा। तो सबसे पहले हमारे जो फर्स्ट पैनलिस्ट हैं, बहुत बड़ा नाम फैसलाबाद का, हेड ऑफ डिपार्टमेंट, रिटायर हुए हैं, प्रिंसिपल रहे हैं पंजाब मेडिकल कॉलेज के, और लिवर फाउंडेशन ट्रस्ट को हेड करते हैं, डॉक्टर जाहिद यासीन हाशमी साहब। जी, दूसरे हमारे पैनलिस्ट हैं बहावलपुर से, हेड ऑफ डिपार्टमेंट ऑफ मेडिसन, कायदा मेडिकल कॉलेज, काजी मसरूर साहब। डॉक्टर अकमल शरीफ साहब, प्रोफेसर ऑफ मेडिसन, मदीना टीचिंग हॉस्पिटल, डॉक्टर अकमल शरीफ साहब। प्रोफेसर डॉक्टर वकार साहब, हेड ऑफ डिपार्टमेंट पिम्स। प्रोफेसर डॉक्टर सलमा तनवीर साहिबा, एंडोक्राइनोलॉजिस्ट at Nishtar Medical College. प्रोफेसर डॉक्टर नरेश कुराना, कार्डियोलॉजिस्ट हैं लाहौर से। जी, निज़ाम साहब, डॉक्टर निज़ाम साहब, ही इज़ FRCP। इसके अलावा हमारे पास जो लास्ट पैनलिस्ट हैं, डॉक्टर सुहेल अंजम साहब हैं, कंसल्टेंट एंडोक्राइनोलॉजिस्ट। तो जो हमारी पहली टॉक है, द स्टैंडर्ड ऑफ केयर एंड यूज़ ऑफ एंटी डायबिटिक मेडिकेशंस इन करंट प्रैक्टिस। तो मैं इनवाइट करूंगा इस टॉक के लिए प्रोफेसर डॉक्टर सोबिया साबिर अली। शी इज़ MRCP, FRCP, FCPS, MHPE, Head of Department of Diabetes and Endocrinology, Peshawar Medical College. She is consultant endocrinologist at Afridi Medical Complex. Dr. Sobia Sabir.
Assalamu alaikum. I'll begin with the typical, scenario. Firstly, I'd like to thank Dr. Ahmed Shahzad for the kind invite, and particularly Monem Sa for extending the logistical care for me. I'm very impressed for your presence this morning. It's really, really very enlightening to see so much of people packed with so much of knowledge and to be here so early in the morning. So that's very impressive. My job for today is that I'm going to briefly talk about how to treat diabetes. I won't say the word management, because then management, it is pretty broad. And I was given this title, Standard of Care. And we all know when we talk about Standard of Care, it's pertaining to the ADA guidelines, that is the American Diabetes Association. However, I thought that this meeting is regarding Primary Care Diabetes Association of Pakistan, so I need to find some guidelines from the primary care doctors elsewhere. And I found very interesting one from Europe. I also tried to look around if I could see any guidelines from the Primary Care Societies or Association of Pakistan. Unfortunately, I could not. And earlier the chairs and some of those people who were asking the question, everybody was emphasizing the need to practice diabetes well, the need to have prevention. So I think for that, at the primary care level, we really need to bring up some position statement, because you see, you guys are at the forefront. These are my disclosures. And as I said, I'll be focusing on, the recommendation or the position statement of primary care of diabetes of Europe. And just I'll briefly go through ADA as well as ACE. And then the second half, I have two halves. First is regarding diabetes treatment, that is whatever is the available medication available. And second would be the kind of non-approved but conventionally tested and tried medicine that we are using for diabetes. So if I share the FDA list of the anti-diabetic drugs that we are using, not just across the globe but also in Pakistan, this whole is the list. I'm sorry, I didn't have time, otherwise I would have kind of written it up for you. It starts with metformin. You all know about metformin. You have been using it through ages. Then the GLPs, the DPP-4, the SGLT2, they have come with a bang in Pakistan, and I mean, I would say that they are very, very successful in our Asian or Pakistani population. Then we have, sulfonylureas, we have the glenides, and most importantly, we have different kind of insulin. The last three, colbicivilam and premalinitide, and I think it's bromocriptin. The last three, they are not yet available in Pakistan, and they are not DRAP registered. The rest of the list I just said, it's DRAP registered. And as I said, they are being used in daily basis. So before I talk more about treating diabetes, I have a question for you, right? Because at the end of session, the 3 lucky persons in this hall would be getting 3 gifts. So have you ever come across this term jugglote, or you know what jugglote is? So it will tell us, the worthy chair, that who are having a most active lifestyle. Anybody? And just to make it simple for you, no, not asthma, that would be a conflict of interest. Sorry? Absolutely, sir. So it is a 14-hour and 14 minutes of drive from Faisalabad. Okay, so our worthy guest, he's telling us the 2 river, they kind of converge there. One is river Indus and one is the river Gilgit. But I think iconically it's very famous that you can appreciate 1, 2, and 3. Now is it easy for you to interpret? Sir, there will be conflict of interest. Yes, absolutely, right? So why am I emphasizing this? Why I'm trying to wake you up? Because you see, this is what happens to us in our clinics every day, that a patient comes and we are at the crossroad. If we prescribe in one direction, we can take him towards Hindu Kush. If we prescribe another thing, we may take our patient to Karakoram range. Otherwise, we can take the patient to Himalayas, right? Otherwise, down there are the 2 rivers, very rightly the Indus, right, and the Gilgit, and top there is the sky. So what I'm trying to emphasize is it's all in your hand, where you want to take or direct your patient. And it's not just a short-term therapy. We are talking about NCDs, a disease which, with no matter how much lifestyle you offer, no matter what, things that you have to offer for the patient, at the end of the day, diabetes is going to be there, controlled or uncontrolled, with complications, without complication. So if you put your patient in the right pathway, perhaps the quality of life and the end of the patient would be very much comfortable for him. Okay, so this is the position statement I was just saying about the primary care diabetes of Europe. And it just came last year. And it is something I think that essentially ADA and ACE, they have kind of mentioned as well. In this position statement, basically the emphasis is that diabetes treatment has become very complex. And I'm sure you all agree on that. Because whenever we are sitting down, the patient is there, 10 patients you may have seen with diabetes, most of them would have overlapping complaints. And then the question would be in your mind, what to prescribe? Because now you have lots of variety. Monotherapy, dual therapy, triple therapy, little dose, bigger dose. Then when to prescribe those drugs in an effective way, that is it the right patient for that prescription, and then how much to prescribe. Because you all know, we have to know, is it cardiac safe? Is it like renal safe? What is the impact in long term, particularly with hypoglycemia, with weight gain tendency? So, I mean, it's kind of like a mental jog for you when you are sitting down with your patient. Then, the thing that has been kind of like emphasized in the recent years, and perhaps it has put us on a very clean or a very clear track, is the cardiovascular risk stratification. So no anti-diabetic prescription should now be prescribed unless and until we know that it is cardiovascular-wise a safe prescription. And for that, rather than the stepwise approach that initially in 2016, if you look at the ADA, guidelines, they have that nice pyramid, and you are trying one thing after the other, and then the other, and then the other. And when 4 or 5 oral drugs fail, then you have another line of injectables. So I think that concept is gone now. You have to prescribe early treatment, even though that means that you have to pick and mix 2-3 different kind of medication for your type 2 patients. Coming to risk stratification, it's not just we at the side of diabetes, right? Even the cardiologist, right? I think I missed. The cardiologists, they are emphasizing time and again. And it is very important that when we are talking about diabetes, we have to know the accurate history pertaining to any cardiovascular disorders. Then we also have to understand the hidden risk factors, which may be kind of a big predisposition for coronary artery disease. That is hypertension, hyperlipidemia, obesity, smoking, physical inactivity, and as Professor Tariq Wasim very rightly said, osteoarthritis. That is another big factor. Depression, dementia, again, those are the risk factors which they are not written in this particular position statement. And then knowing the renal functions, that is another thing that is very important. And it's not just the GFR. You can do a spot urine test for your patient to know the albumin, and you would know how high risk the patient is. Then those who develop diabetes at a lesser or at a younger age, consider them like time bombs, because they have a greater predisposition to get underlying cerebrovascular or coronary artery or renovascular disease. And likewise, those people who have a long duration of diabetes, who are over the age of 65, again, their risk of cardiovascular disease is much more. And this is what essentially the European Society of Cardiology, they are also trying to highlight. So what they have done, they have categorized the diabetics per se into 3 categories. Those who are at very high risk, they have diabetes with established coronary artery disease. That is, they may have an episode of angina or MI, or maybe some intervention, and then there may be some kind of target organ damage, maybe one organ or more, and there would be definitely underlying risk factors which I just enumerated. And then if it is a type 1, obviously a longer duration, that is 20, that would also fall into this category. Now, what is high risk by the ESC? Any patient who has type 2 diabetes for longer than 10 years, that may be without a target organ damage, but at least a few of the risk factors may be there. And lastly, the moderate risk. Now, what is moderate risk? Younger patient, type 1s, less than 35, or type 2, less than 50 years of age, with diabetes of more than 10 years. So the more the diabetes age, the more dangerous it gets, and that requires proper screening and attention to their coronary artery disease. In this particular list, you would note that there's no low risk patient, right? So it's just a moderate, high, and very high risk, right? And this is maybe we have to, whatever the patient's understanding is, we have to explain it to their level and expectations. Perhaps it may be one way of making them adhere to their medications or not. Now, coming to the treatment bit, how do we treat these patients? I think the Primary Care Association, they have made it very straightforward. They say, okay, let's start with metformin and add one of any drugs like the SGLT2, GLP, or the DPP4. And I think this is what we are pretty much doing in Pakistan, right? You all would agree. We don't have any different prescription, right? So whatever second drug that you offer would depend on a lot of factors. Perhaps you want to have more weight loss, or perhaps you need to have more renal safety, or you need to have more cardiac safety. So you are the better judge to decide. What about our conventional, time-tested, and the drugs which our patient really adore? The sulfonylureas, they're still there, right? Even in the ADA slides, I'll show you. So sulfonylureas are pretty much there. They would never go away, I mean, I personally think. So these drugs are very cost effective and very, very efficient. And recently, I mean, in one of the latest article I was seeing that sulfonylurea or insulin, they have been labeled as a rescue therapy for type 2 diabetics. So if the other drugs are working slowly, steadily, like for example, in case of DPP-4, it may take up to 3 weeks for effective glycemic control to be attained. So why not sulfonylurea? And within 3 days, your patient would be much better, symptomatically as well. Pioglitazone, again, it came very in the early half of 2000. Unfortunately, it, I mean, had good results, but because of the fluid overload, because of the heart failure and the other complication, it has to be withdrawn. So for quite a few years, we were on the back footing with regards to pioglitazone prescription. It was very much limited that perhaps people who are already on pio, they need to continue, those who have severe insulin resistance, or maybe in instances when there is polycystic ovarian syndrome. But now the projection is on NAFLD, right, or MAFLD as you call it, where insulin resistance is the underlying pathology. So pioglitazones are back, and which is a good news for us because they are cost effective, they are very much patient friendly, and I think, I mean, we get very nice glycemic control with them. Likewise, insulins, they are always there for type 2, so when the orals or the GLP, that are the injectables, are not working, please feel free to prescribe whatever the recommended or desired insulin is. Then the people who have ASCVD, again, it is more or less the same. It's metformin plus SGLT2 and any of the others, right? So it's essentially the same as with the high-risk coronary artery patients. However, patients with heart failure, again, you know it all. We have been, I mean, learning it in the last 3-4 years that it's SGLT2, right? And this is something more than you guys who do more of the diabetes practice. The cardiologists, they have a free hand. They are prescribing particularly DEPA, although I feel it's more of a class effect. They're prescribing DEPA to those who are even non-diabetic. So there you go, you can prescribe. But I mean, a bit of caution by this statement that you have to be kind of like concerned when there is heart failure. Please do not over enthusiastically prescribe Pio or Sexa, which can actually deteriorate the cardiac failure. What about patients with CKD? So again, if the GFRs, right, the emphasis is the GFR. If the GFR permits, yes, metformin, why not? Otherwise, SGLT2 with a lot of renal protection, you can, I mean, start. And the good news, as shared earlier this year in summers by the ADA, is that the cutoff of SGLT2, that has even come down. Anybody would like to share what is the SGLT2 prescription cutoff for SGLT2? Yes, absolutely. Right? So we started with 45 and then 35 and then 30, and then for a year we were just kind of like in a frenzy that is 30 the limit? No, now it is 25. Let's see next year if you have another meeting, it may have come down to 15 or not, right? Okay, so you can do that, but in case if the SGLT2 are contraindicated, metformin are contraindicated again, then you have to go ahead, prescribe whatever short-acting drugs that would be safer for your patient with renal. When it is diabetes and obesity, I mean, you know, there is a set of obesity guidelines, right? And there is a long list of anti-obesity drugs, but with regards to diabetes, the most favored are GLP and the SGLT2 along with metformin. Although, I mean, the lot of scientific evidence, the FDA data, it emphasizes metformin is weight neutral. But the contrary, we see that it is rather weight reducing, and we see many of our gynae obs colleagues prescribing it as a weight loss medication, particularly in PCOS, and there is quite a bit of weight loss. So I don't know, it's genetics that in Asian it work well or whatever, but still it's something worthwhile to think. Likewise, I mean, when drugs are not working, obviously bariatric surgery, right? this was recently mentioned in one of the guidelines. For elderly, please be gentle. You know your HbA1c cutoffs, your blood glucose cutoffs, they have to be really gentle for the elderly patient, frail patients who may have mobility issues, who may have continence issue, who may even kind of like have problems with their meals, they have poor appetite. I mean, you may give them whatever medicines and then they are unable to eat because of their GI issues or whatever. So you have to have a thorough approach while doing this. And I mean, not just at the back, but at the front of your mind, you have to focus that your elderly patient must not get any hypoglycemia, because I mean, that would subject them to different kind of untoward complications. Okay, just moving on, and I'll be a bit brief in the interest of time because I just have 2.5 minutes left. So ADA is essentially the same, right? You start with lifestyle and then they tell you the different pillars of management, right? And over here, they have again given the cardiovascular and the renal cutoffs and the weight loss plan for you guys, and then the insulin. So the main focus of ADA this year was weight management, along with that emphasis on the coronary artery risk stratification and avoidance of hypoglycemia and considering the cost effectiveness of the drug. ACE, I deliberately put because this is something, it was mentioned by the earlier presenter, that is pre-diabetes. We didn't have a guideline for pre-diabetes, but now, I mean, when we are sitting with the patients, we can clearly tell them that it is the time to treat you. Otherwise, you're going to be an over-diabetic no matter what kind of lifestyle you would like to adhere or not. So if the goal of pre-diabetes is like kind of like losing weight along with good glycemic control, GLP and otherwise surgery. Otherwise, if weight is not an issue, then perhaps you go to the conventional pathway of treating diabetes, right? And I mean, this is more or less. Another thing that is very much highlighted in the ACE guideline is the use of vaccination, right? So I thought while discussing the anti-diabetes treatment, I should share with you COVID vaccination is obviously because this is the time that we have just emerged from COVID. So COVID vaccination is there, flu vaccine, Hep B vaccination, pneumocystis, this is pneumococcal vaccine, and then we have the triple vaccine, that is the diphtheria, pertussis, etc. So they are recommended by the CDC and they are also suggested by the ACE. Okay, so this was when you are sitting and thinking, but what about what's happening in the patient's mind, right? Because there's the other side of the coin as well. So when the patient is sitting, the first thing he's scared of that you're going to tell him that you need insulin, or you tell him that, okay, your diabetes is complicated and you have 1 or 2 or whatever complication, and then parhez, you'll blame him, you'll shame him, and you'll force him to have parhez, right? So that is something he's kind of like, because I could see most of the time the patients are kind of ready to anticipate that, yes, my doctor is going to tell me the same whole story. And then lastly, parhez, because a diabetes consultation is never complete without a mention of parhez. So somebody has to, just 1 more minute, I'll finish if you allow. Right, thank you. Okay, so I mean, parhez I said, and then lastly, every diabetic, even with the HbA1c of 7%, they'll tell you, Dr. Saab, I feel weak. Please prescribe me multivitamins. So it is a convention, or is it something like our people have developed that no matter, I mean, good diet they can have, no matter how much they can exercise, they still need to have a pill. And I thought, let's do some reading with regards to pill. What is happening in the pill? Okay, so it has a lot of multivitamins, and you know multivitamins, they regulate our systems. But beside the multivitamins, most of these newer pills, what are they having? They're having lots of micronutrients, right? And I mean, we know that diabetes is 550 million, I mean, as of today, diabetics are there. And more than diabetes, about 1 billion of the people, they have micronutrient deficiency. So imagine 550 diabetics, so definitely quite a few of them would have underlying micronutrient deficiency. And what may be the reason? I mean, obviously it's a chronic disease. There would be element of like malabsorption, maldigestion, I mean, drug interaction or drug side effect, and not to forget the kind of parhez patient do. Patient would have all the sweets, but they won't have the leafy vegetables, salads, or even the dairy products, right? So beside the dietary restriction, physical activity, I think if we start thinking of maybe boosting the energy by giving some anti-diabetic plant-derived chemicals, that may be an additional help. What is the evidence for that? The evidence is that if we have kind of like deficiency of these micronutrients, that would impair our metabolic kind of system in a way that it would affect the liver, the muscle, the pancreas, or the adipose tissue at a cellular level, right? And what is going to happen? I mean, there would be kind of enzymatic dysfunctions, there would be beta cell dysfunction, maybe apoptosis, loss of beta cell mass, leading to pancreatic dysfunction, I mean, reduce lean body mass, that is like sarcopenia as we just discussed, and then obviously it would have kind of effect on the insulin level, maybe insulin resistance or insulin deficiency, and kind of like different variety of disorders that we can see. Again, when I looked into, I was very impressed to see that there were different benefits that we can actually have with the use of these different trace elements, particularly like copper or magnesium, selenium, boron, etc. And what are they? I mean, the literature supports that they have a direct anti-diabetic action, they can improve insulin tolerance, they can improve the insulin secretion, they can actually help with the mitochondrial enzymatic activity, they increase the glucose uptake, and then they kind of like retain those beta cells from degenerating. And at the end of the day, some of those micronutrients they were found to have improvement in microangiopathies, like the different pathies that we have, right? And if we look at the different kind of like, elements, that is iron, boron, calcium, cobalt, chromium, iodine, magnesium, zinc, selenium. So I think if we look at our standard well-cooked Pakistani diet, how much intake do we get? I was not able to get it on any of those web portals that were there. So do we need to take supplementation, particularly in cases of NCD patients like the diabetics? It's an open house discussion, right? But a lot of evidence suggests that yes, it will improve diabetes. How will it improve diabetes? It will lower blood glucose through pancreatic functions. It will also improve the insulin secretion. It would have anti-inflammatory, antioxidant effect, and anti-aging as well, right? That was also mentioned. Now, I leave it to you, right? Because I think the ball is in now your court, you have more experience, so either we need to prescribe some kind of these magic pills or multivitamins or whatever, so this is something. Beside those trace elements, there's another thing, phytomedicine. Now phytomedicine is something, some of you may have it at your breakfast as well, right? These are basically the plant-based products that we have, and we simply ignore that what is the relevance, right? What do these do? More or less like the multivitamin or the trace elements, they have good effects on liver, on pancreas, intestines, and adipocytes, as well as the skeletal muscles, right? And at the end of the day, when they are helping us with the cellular function in a good way, right, they are reducing the different kind of microvascular complications that may arise, right? One very famous is the alpha-lipoic acid, right? There was a lot of information about alpha-lipoic on the internet. It's something very useful. There was a recent study in 2021. It was a prospective study in which they actually did the nerve conduction test after prescribing alpha-lipoic acid, and you know what nerve conduction study is. There was a particular improvement in the NCS findings. Besides that, yes, there was also, improvement of the A1C, there was improvement in the HDL, LDL level, right? Beta-glucan, right? You know this is in the oats or porridge. So if some of you had porridge, you should be happy that it increases the insulin level, it is benefit for your heart as well as for your liver. Just 2 more slides if you allow, sir, right? And then another thing. I'm so sorry. Right, it's just ending, right? Okay, so this second last, I think, this is like the Gemna sylvestre, pretty difficult name to pronounce, and this is again something very much marketed. So without the pharmaceutical support, it's already there in the market. Does somebody know the name for this? It's a green tea, right? So you see the Lipton ads and the Tapal ads and the different ads, that is the tea brands. And basically the green tea benefits, they go back to China and the prehistoric time. And this was something, I could find it for you, that they are actually decreasing gluconeogenesis. They are actually reducing the intestinal absorption. But mind you, you should not be taking sugar in your green tea. Turmeric, again, you all know it, that it has been tried. In US, I mean, there is, if you have been to US supermarket, there's a thing called, golden milk. So that golden milk is nothing, just doodh and haldi, right? And some of the Asian people are very happy to see the revival of turmeric over there. Otherwise, chia seed are also there in the US market. And I think our discussion would never be complete without the mentioning of our old friend, right? Karela. Karela is there, lots of benefits, right? Although I was surprised to see in one of the article, they said it has to be 2 grams. So I was not sure how much of it is 2 grams, right? Then again, we see patients very, most of the time they come and they very nicely tell me that they have been taking different brands, imported brands, right? But I think it's about time, if our patients are happy, it gives them some kind of like, I'm not sure it's placebo or is it true. This is something, I mean, it's a big area for research and I'm not kind of like in support, but still I think it's time that we need to consider these things while we are talking about prevention and treatment, right? So I'll stop there. And with that, I mean, I think Monem Saab is kind of expectantly looking at us that they have recently marketed, I think, a medicine with all these properties, and I think it is marketed by the name of Diavit. So you may have used it or not, but it's for you to see what happens. Thank you very much.
Thank you, Dr. Sobia. As we are running short of time, I will quickly invite our next speaker. The topic is Standardized Food Care Fast Track Program from Concept to Implementation in Pakistan. I will request Dr. Tariq Mia, Zahid Mia Saab, Zahid Mia Saab. He is professor, he is consultant physician and diabetologist at Bakai Institute of Diabetes and Endocrinology. Sorry, ये डॉक्टर अहमद शहजाद ने बहुत जल्दी डाली हुई है, जल्दी करें उसमें जल्दी करें.
जी अस्सलाम वालेकुम. वो कहते हैं कि कुछ इश्क था और कुछ मजबूरी थी, तो सारा मजबूरी पे डाल दिया, इश्क पे तो कुछ नहीं डाला. तो थैंक यू वेरी मच इंडीड. वो बात नहीं कहना चाहता जो हर आदमी आके यहाँ कह चुका है, लेकिन अहमद शहजाद वी लव यू. थैंक यू for this beautiful meeting, arranging of this beautiful meeting. And let's start my time. So in next 20 minutes, or if Sobia allow me, then in next 27 minutes, I will discuss this diabetic foot problem. So, and we know that सुबह से बातें हो रही हैं, डायबिटीज़ बढ़े जा रही है, पूरी दुनिया में बढ़ रही है. And we know this fact for ages. But what we don't know is the demand for diabetic foot services is also increases, my dear friends and colleagues. ये भी तो सोचो जरा, कोई पाँव का तो सोच ले, हैं? दिल की बातें करे जा रहे हो, दिमाग की बातें करे जा रहे हो, जोड़ों की बातें करे जा रहे हैं, क्या क्या बातें किए जा रहे हैं, लेकिन कुछ तो सोचो. मगर यहां तक जाए कौन? कितने लोगों ने पाँव धोए आज आप सब में से? अरे ओ माय गॉड, सबने धो लिए. मरीजों के पांव कितने लोगों ने देखे? That it should be like कि जैसे अपने पांव धो रहे हैं, हाथ यूं खड़े कर दिए, उसी तरह मरीजों के पांव देखे। हम सब खुश हों इस बात पे कि सब हाथ उठाएं, हाँ हमने देखे, हाँ हमने अपनी प्रैक्टिसेस में देखे। जब वो आता है हर दफा देखते हैं। ये है बात। सो बात निकलेगी तो बहुत दूर तक जाएगी। लोग बेवजह टाइम का मुझे ताना देंगे। तो बहरहाल, बट माय डियर फ्रेंड्स, there are 3 million people. This is, of course, an extrapolation of the data. 3 million people who are having a diabetic foot problem in Pakistan. And why we are so obsessed about this problem? ये क्या दीवानगी है? ये क्या पागलपन है तेरा? क्यों जाता है गली गली, कूचे कूचे? क्यों? वजह यह है मेरे दोस्तों, वजह यह है कि कॉस्ट, एक डायबिटिक फुट को ट्रीट करने के लिए पहले बात होती थी हजारों में, और अब बात होती है लाखों में। एक डायबिटिक फुट की एम्पुटेशन, माइनर एम्पुटेशन, जिसको आप कुछ भी नहीं समझते, मरीज से पूछें जरा जब उसकी उंगली कटती है, फिर पूछें कॉस्ट देखें जरा कहां पहुंच गई है कॉस्ट। इसलिए फिरता हूं मैं कूचे कूचे, गली गली, तेरे नाम के खातिर। फिर जब टांग कट जाए तो वो कहां जाए? जब टांग कट जाए तो वो कहां जाए? आप तो निकालेंगे, पहले आप ही होंगे जो उससे कहेंगे जाओ भाई, मैं तो तुम्हें ड्राइवर नहीं रख सकता, जाओ मैं चौकीदार नहीं रख सकता, जाओ मैं तुम्हें अपने काम पे नहीं रख सकता। तो फिर वो क्यों ना डिप्रेस हो, वो क्यों मेंटल प्रॉब्लम में ना जाए? Why not? He has got every reason to go into this. और फिर अगर बात करें टांग कटने की, टांग कटने की अगर बात करें, this is the data which we started from our amputation rate from 27%. The amputation rate, I know the amputation rate is different in different parts of the Pakistan. And on average, 40% of the people having diabetic foot lost their feet. 40%. And we started with 27% in our center. And with this 24 years of time, alhamdulillah, with a team approach, with a multidisciplinary team approach, we have cut down this amputation rate in our center to about 3%. This is only 3%. That is what we are looking for everywhere in Pakistan. That is what we are trying for standard of care management in every part of the Pakistan. Not only in the Faisalabad, but also in Dihari. और जो अभी सूबिया दिखा के गई हैं, जंगलोट, क्या जंगलोट ही था शायद वहां पर भी। Why not? This is मेरा पाकिस्तान, मेरा मुल्क, मेरे लोग, कैसे छोड़ दूं उनको? So this is what we are talking of. Every 22nd year lower limb is lost somewhere around the world. हर 20 सेकंड बाद एक ना एक कुछ ना कुछ कट रहा है। So क्या करें? Why this is happening? Why this is happening? Not in only Pakistan but all around the world. So last night I was in the, luckily I am the chair of the MENA region as well, which covers the 21 countries. I had a meeting over there last night, finished at 1:30 midnight. So we are talking about what to do in the MENA region. So just cut down the rate of amputations. So, but my dear friends, there are many gaps in the knowledge, skill and the practices. बहुत देर कर देता हूं मैं, और ज़रा मेरी शायरी पे न जाइएगा, उल्टा सीधा बोल देता हूं, तो अगर कोई शेर है तो पकड़ ना लीजिएगा मैं अगर वो गलत बोल दूं तो बहुत देर कर देता हूं मैं। बहुत मसला है, गाइडलाइन बनी हुई है, कौन अमल करता है? मैं कह रहा हूं, मैं कौन हूं? मैं जाहिद मियां हूं। क्योंकि मैं जाहिद मियां हूं, मैं कह रहा हूं इसलिए यही सही है। नो माय डियर फ्रेंड्स, मी इज नथिंग, जाहिद मियां इज नथिंग, अब्दुल बासित इज नथिंग, एंड हाशमी साहब इज नथिंग, एंड प्रोफेसर सलमा तनवीर इज नथिंग। जो गाइडलाइंस हैं वो क्या कह रही हैं? व्हाट इज द एविडेंस प्रैक्टिस? पर्सनल एक्सपीरियंस होगा अपना, मेरा कोई पर्सनल एक्सपीरियंस नहीं है, मैं पर्सनल एक्सपीरियंस नहीं मानता, कोई भी नहीं मानता। जो कुछ है एविडेंस लेके आओ, बात करो। व्हाट इज द एविडेंस बिहाइंड यू आर टॉकिंग अबाउट? देयर इज नो पर्सनल एक्सपीरियंसेस। If you have such a good personal experience, please publish a paper, come out and tell us. We will learn from you people. We learn from this aspect. So these are, and you know, there are only 19 countries around the world who has got the podiatry services. सिर्फ 19 countries हैं सर हाशिम साहब, 19 countries पूरी दुनिया में जहां पोडियाट्रिस्ट, किसका मतलब है 4 साल की उसने प्रैक्टिस की हुई है, सिर्फ 19 कंट्रीज है। पाकिस्तान में ये कॉन्सेप्ट जो लेके आए प्रोफेसर बासित, एंड ही कॉइन्स दिस इन वे बैक इन 2007 के पाकिस्तान में शायद ये नहीं चल पाए, हमने डायबिटिक फुट केयर असिस्टेंट का फिर ये कॉन्सेप्ट दिया। बहुत सारी हैं, करने को तो बहुत दिल चाह रहा है लेकिन टाइम कम है, इसलिए द अदर एस्पेक्ट कि एक तो स्किल, नॉलेज और प्रैक्टिस में गैप है, दूसरा मैं तो नहीं भेजूंगा अपना मरीज किसी के पास। क्यों भेजूं? डिले इन रेफरल leading to a high amputation rate, my dear friends and colleagues. And I am not talking about today's. 30 साल पहले भी यही बात थी, 30 साल पहले ये पेपर पब्लिश हुआ, और ये 2 साल पहले पेपर पब्लिश हुआ, आज भी यही बात है, 2 साल पहले भी बात यही थी, और आज भी मैं यही बात कर रहा हूं। Delay in referral is leading to amputation. And this delay is not only in Pakistan. You can see in Europe published publications. यूरोप में भी यही मसला है, 3 हफ्ते बाद पता चल रहा है डायबिटिक फुट का प्रॉब्लम है, डायग्नोसिस में, ट्रीटमेंट में डिले है। और इन पाकिस्तान, दिस इज आवर पेपर पब्लिश्ड अगेन, फुट प्रैक्टिसेस इन पाकिस्तान। यकीन करें इस पेपर को मैं ही यूज करा था, लेकिन पढ़ने के बाद दिल बड़ा उदास हुआ, और उदास इसलिए हुआ कि कंक्लूजन अगर देखें, द नॉलेज एंड प्रैक्टिसेस ऑफ फुट केयर वर फाउंड टू बी अनसेटिस्फैक्टरी इन द मोस्ट ऑफ द पेशेंट। ये मेरी और आपकी जिम्मेदारी है, जिसमें हम फेल हो रहे हैं, बार बार फेल हो रहे हैं, बार बार फेल हो रहे हैं। एंड this is the fast track program which we have launched in Pakistan. And what is this fast track program is? This is a D-Food International program. I was the vice president of D-Food International and now the chair of this as well. So we bring this program to the Pakistan to launch this program into Pakistan. And this is an easy to use tool to reduce delayed referral and amputation in people with diabetic foot ulcer. And to use to support the primary health care professional and in the prompt referral and treatment of the patient with the diabetic foot ulcer. And this fast track program reflects the recent international working group for the diabetic foot guidelines and direct treatment based on the severity and the comorbidities. Renal failure है नहीं है, heart failure है नहीं है, depression है नहीं है. You need to see a patient as a whole, not a hole in the patient. सिर्फ जख्म देखने की बात नहीं कर रहे. You need to see the patient as a whole. So this is the algorithm. So a holistic approach towards the patient, and then divide the patient into the three categories. One is the people who has got non-complicated diabetic foot ulcer, which shows in it green color. जो signals colors हैं, amber and red. So non-complicated, it means जो सिंबाद स्कोर है, मैं इसकी डिटेल में नहीं बताना चाह रहा अभी, उसका स्कोर 1 to 2 हो, तो सिंबाद स्कोरिंग is a classification scoring system which we are now using, and it's very easy, simple. And 3 to 4 अगर moderate हो और फिर complicated अगर severe हो. अब ये किस तरह इन पेशेंट को, तो अगर आप देखेंगे ग्रीन को कौन, द ग्रीन इज 1, इसको हम पाकिस्तान लेके आए और इसमें हमने चेंज किया अपने सिस्टम के हिसाब से कि हम क्या कर सकते हैं. आप देख रहे हैं इस ग्रीन में कहीं इन्फेक्शन नजर नहीं आ रहा, इसका मतलब है प्राइमरी केयर वाले इन्फेक्शन ट्रीट ना करें. ये यूरोप के लिए है, ये अमेरिका के लिए है. लेकिन पाकिस्तान में हम समझते हैं कि अगर प्राइमरी केयर वाले भाई गले बाद में मिल लेना, बैठ जाओ प्लीज, सिट डाउन. सो अगर प्राइमरी केयर वाले फूड इन्फेक्शन ना ट्रीट करें तो दैट विल गो इनटू मॉडरेट एंड सीवियर इन्फेक्शन. अगर माइल्ड इन्फेक्शन को ट्रीट नहीं करेंगे तो फिर वो लैंड करेगा, रेफरल होगा मॉडरेट या सीवियर इन्फेक्शन के साथ, सेप्सिस के साथ, सर्स के साइंस के साथ, तो फिर ये amputation हो जाएगा. And that is why we put the mild infection to treat by our primary care health physician. And how to refer this? This is uncomplicated diabetic foot ulcer. Then when to refer, मैं इसकी बात नहीं कर रहा. फिर complicated diabetic foot ulcer, and when to refer within the 4 days of initial assessment, and the severely complicated diabetic foot ulcer with a gangrene or an abscess, or if the patient presents with a fever or a sign of sepsis, then it needs an urgent hospitalization in a specialized diabetic foot care center within 24 hours. Within 24 hours. And ये मैं लैला मजनू की बातें नहीं कर रहा, शीरी फराद की बातें नहीं कर रहा, ये कोई किस्से कहानियां नहीं सुना रहा हूं. This is all evidence-based medicine. This actually works, and it works in the many countries where this is implemented. And you can see the healing time decreases, minor amputation decreases, major amputation decreases, hospitalization decreases, and the survival rate is increased by using this program. And so what we aim to reduce the avoidable amputation across the Pakistan, and our objective is to provision of evidence-based standard of diabetic foot care to the people with diabetes within or closer to their vicinity. इसको डालने का मकसद है ताकि वो प्राइमरी हेल्थ केयर तक पहुंचना चाहते हैं हम, ग्रास रूट लेवल पे जाना चाहते हैं हम, जहां मरीज पहले रिपोर्ट करता है वहां उन्हें ट्रेन करना चाहते हैं ताकि प्रॉम्प्ट रेफरल हो जाए. सो दैट्स लुक्स वेरी सिंपल कि आपने एक प्रोग्राम बना हुआ है, उसको ले लें, उसको इंप्लीमेंट कर दें. इज दैट ए सो सिंपल इंप्लीमेंटेशन? नो माय डियर फ्रेंड्स, मैं बहुत जल्दी इसको बता रहा हूं. सो हमने ये प्रोजेक्ट लिया, वो कॉन्सेप्ट लिया, चेंजेस की, जैसे मैंने बताया कि माइल्ड इन्फेक्शन हमने कहा कि ये हमारे जो प्राइमरी केयर फिजिशियन है ये ट्रीट करेंगे. फिर कब रेफर करेंगे, कनेक्शन कैसे बनेगा, ये हमने सारा उसमें प्लान बनाया, फिर लेक्चर लिए, हैंड्स ऑन जो है वो वर्कशॉप्स कराई, ट्रेनिंग ऑफ द टीम्स किया, फिजिशियन एंड देयर पट्टी वाला, जिसको आप हम कह रहे हैं डायबिटिक फुट केयर असिस्टेंट, एंड अबाउट वन एंड देन वी डेवलप ए मोबाइल ऐप ताकि आप उसमें डेटा डाल लें। अब ये डेटा की जहां बात आती है, पता नहीं क्या हो जाता है हम सबको, मैं भी उसमें शामिल, पता नहीं क्या हो जाता है। क्या हो जाएगा भाई अगर आप उस मोबाइल में डाल देंगे या अपने पेपर पे लिख लेंगे, कुछ ना कुछ तो डेटा कलेक्ट करें। डेटा नहीं कलेक्ट करेंगे दुनिया में पीछे रह जाएंगे। कोई आपके पास रिसर्च नहीं आएगी इंटरनेशनल जब तक कि आप डेटा नहीं देंगे। एंड दिस इज द रिक्वेस्ट वी आर मेकिंग with the primary care physician, especially the people in the primary care association. Please share the data. Please put the data into that mobile app or nahi. So, and then we make a referral system between the primary health care physician, a secondary and tertiary. Primary health care का एक जो जहन में बात है कि यार मेरा मरीज गया डॉक्टर हाशमी के पास, मरीज नहीं आएगा, वो तो उन्हीं को दिखाएगा, नाम है, बड़ा नाम है। हमने ये सिस्टम बिल्कुल चेंज कर दिया। वी मेक श्योर दैट द प्राइमरी हेल्थ केयर से जो पेशेंट सेकेंडरी हेल्थ केयर में आए या टर्शियरी केयर पे जाए, वो पीछे वापस प्राइमरी हेल्थ केयर वाले के पास जाए। दिस इज अ रेफरल बैक सिस्टम, एंड सो दैट्स हाउ वी विल बी एबल टू हैव ए स्टैंडर्डाइज्ड डायबिटिक फुट केयर इन पाकिस्तान, एंड दिस इज व्हाट वी हैव अचीव अल्हम्दुलिल्लाह। और सारी बड़ाइयाँ अल्लाह के लिए हैं। एंड दिस इज़ व्हाट वी हैव डन। वी हैव डन 113 क्लिनिक्स जो हैं वो डेवलप कर ली हैं। सिंध में 81 क्लिनिक्स हैं प्राइमरी, और पंजाब 48 क्लिनिक्स हैं, पंजाब में 25 हैं, KPK डॉक्टर सूबिया पीछे रह गया, 5 हैं क्लिनिक, बलोचिस्तान में वो मेरे दोस्त आए नहीं हैं, वो भी पीछे रह गया, 3 क्लिनिक्स हैं प्राइमरी हेल्थ केयर पे। एंड देन सेकेंडरी हेल्थ केयर पे वी हैव 24 क्लिनिक्स, एंड टर्शियरी केयर पे जो है वो 8 क्लिनिक्स हैं इन ऑल ओवर द पाकिस्तान। एंड व्हाट वी ट्राइंग टू मेक द कनेक्शन। प्राइमरी केयर वाले को पता तो हो कि आप जो है वो यहां पर काम कर रहे हैं, आपको जानता ही नहीं प्राइमरी केयर वाला, तो कैसे कनेक्शन बनेगा? कैसे पता चलेगा कि किसके पास भेजना है? भावलपुर में किसके पास भेजना है? काजी साहब हैं भाई, पता है, भेजना है, पता है। जब पता होगा तो बात बनेगी, तो आपके पास प्राइमरी केयर वाला रेफर करेगा। इसमें मेरे ऑर्थोपेडिक कोलीग्स भी शामिल हैं, इसमें वैस्कुलर कोलीग भी शामिल हैं, इसमें जनरल सर्जन भी शामिल हैं, इसमें प्लास्टिक सर्जन भी शामिल हैं। मेक ए कनेक्शन, ताल्लुकात बनाएं। अपने खातिर तो बनाते ही हैं, मरीजों के खातिर भी बना लें यार, इसमें क्या है, बनाएं, कनेक्शन बनाएं ताकि मरीज आपसे बेहतर सर्विसेज ले सकें। और दिस इज द आउटकम। 524 पेशेंट्स का डेटा ये है जो कि इनरोल हुए इस 6-8 महीने में। एंड देन जस्ट लुक एट दिस डेटा, अमेजिंग डेटा। 42% completely healed, only 14% have got minor amputation, and major amputation only 1.8% have a major amputation. And you can see the red and the green, or the green and the yellow, these are the people who are lama or lost to follow. कहीं ना कहीं चला जाता है मरीज, and it's a big chunk of these sort of patient जो आपको हर जगह मिल जाएंगे। कोई बात नहीं, जा रहा है तो कहीं तो जा रहा है ना, उन लोगों को भी लूप में लें जिनके पास ये जा रहा है। So this is what, and you can see the healing rate, the healing time, and जितना जल्दी ग्रीन सिंधबाद क्लासिफिकेशन 3 तक, जितना जल्दी सिंधबाद क्लासिफिकेशन पे आपने रेफर कर दिया, उतना ही अच्छा हीलिंग टाइम है, उतना ही कम हीलिंग टाइम है। एंड this is the statistical significant healing time. प्रॉब्लम हर जगह आती हैं। प्रॉब्लम सिर्फ पाकिस्तान में नहीं, पूरी दुनिया में प्रॉब्लम्स हैं। तो इस प्रोजेक्ट में प्रॉब्लम आए, और एक कॉमन प्रॉब्लम कि जाहिर है कि हर जगह इंटरनेट नहीं चल सकता, मोबाइल ऐप यूज नहीं हो सकती, कोई बात नहीं, हमने ये परफॉर्मा दे दिया, बहुत शॉर्ट सा परफॉर्मा दे दिया कि ये परफॉर्मा आप फिल आउट कर लें और इसको भेज दें। लेकिन प्लीज़ डू इट अपने खातिर, अपने मरीज़ के खातिर। जब तक कि आपको सही स्टैटिस्टिक्स पाकिस्तान की नहीं पता चलेंगी, हाउ कैन यू मेक ए प्लान? तो इसको परफॉर्मा को या मोबाइल ऐप को यूज़ करने की ज़रूरत करें। एंड देयर आर मैनी बैरियर्स। सो आई स्टिल थिंक्स माय डियर फ्रेंड्स, दिस इज़ द लास्ट 2 slides. माय वर्क इज़ नॉट येट डन। और मेरे काम का मतलब है हमारा काम अभी ख़त्म नहीं हुआ है, क्योंकि ये ना ख़त्म होने वाला काम है, ये काम हमेशा जारी रहेगा। द फास्ट ट्रैक प्रोग्राम, व्हाट वी कैन मूव अहेड is support the family care clinician who should provide the first intervention, and the primary care professional plan an early referral to the specialist care in accordance with the severity of the individual. And this is in this regard. Very recently, जो हमारी अभी मीटिंग हुई कराची में अगस्त में, we have signed this, ये इसमें आपको प्रेसिडेंट इलेक्ट नज़र आ रहे हैं रियासत, और सेक्रेटरी ऑफ स्लिप नज़र आ रहे हैं डॉक्टर सैफ। सो एक एग्रीमेंट डी फुट इंटरनेशनल का जो फास्ट ट्रैक प्रोग्राम जो मैंने आपको बताया कि प्राइमरी केयर फिजिशियन नाउ टेक द लीड, दिस एसोसिएशन विल लीड टू कम्बैट दिस प्रॉब्लम इन पाकिस्तान। एंड very recently we have developed this group in the PCDA. Anyone who is interested in doing foot care can join this. Any one of you wanted to join this, who has some work, who wanted to work, who wanted to learn, can join this group. I am leading this group from the PC. So moving ahead, launching the project, we need your help from the association, from the corporate partner, from the ministry, from the NGOs, from the welfare association and the institute and the university, sir, from you people, and what we are expecting outcome. So we can reduce the healing time, we can improve the quality of life, we can increase the rate of limb salvage, and we can decrease the mortality due to the diabetic foot. My dear friends, time is tissue. Time is the tissue. और ये जो आपको नज़र आ रहे हैं, ये 2 घंटे, 4 घंटे या 4 दिन में ये नहीं हुए ज़ख्म. They have weeks of history of weeks of having these problems. So my dear friends, this is time for action now. It is never too late to do something to reduce the avoidable amputation in Pakistan. Thank you very much indeed for your thank you. This is the can we just मैं इसको this is इसका नहीं this is B vitamins and diabetic neuropathy. The lecture is in the IDF meeting 7 December. You can join by having a link. Thank you.
Thank you, Dr. Zahid Mia, for a great talk. Having diabetes means being a master of balance, constantly finding the equilibrium between food, exercise, and insulin. Due to the shortage of time, we will have a lucky draw at the end of this talk. I will invite my next speaker to talk on the topic metabolic interplay between type 2 diabetes mellitus and obesity. I will invite Dr. Kareem Kamruddin, consultant physician at Bakai Institute, University of Bakai Institute. He is fellow of College of Physicians and Surgeons and consultant physician.
Thank you very much. I think talking after Dr. Zahid Mia, the president, is always tricky. And I was talking to the people who are behind this desk, the crew, saying that do not put my timer at the end of Zahid Mia's talk because they have taken already few seconds of my talk into Zahid Mia's career. So I think the topic that has been given by the esteemed PCDA and the Ahmed Shahzad Sahab was so difficult, in fact, that I thought that I have to admit few declaration. The topic was metabolic interplay. पहले ही देख के जान निकल गई कि यार अब बैठ के क्लिनिशियंस को आपको पाथवेज पढ़ानी है, तो यहाँ पे पहले मैंने अपनी हार मानी. फिर दूसरा उन्होंने दिया जी टाइप 2 डायबिटीज विच इज एन आउटकम, वन ऑफ एन आउटकम ऑफ ओबेसिटी. सो आई रिवर्स एंड स्विच द गियर. सो पार्डन मी डॉक्टर अहमद, अगर मुझसे गलती हो जाए कि मैं ओबेसिटी को पहले ले लूँ और टाइप 2 को बाद में ले लूँ, और यही मैं अपनी ऑडियंस से एट द बिगिनिंग एडमिट करूँगा. So it's always been pleasure of mine for the invitation that has been given to me, and to talk as the last speaker but not the least, and have to stand between tea and you people. So it is always difficult and challenging. So taking all that declaration, I start the topic that obesity, as Dr. Shahid Mahmood has rightly said few things, that you can easily see that there has been a change in the recent concept of diabetes. Taking his discussion of sarcopenic obesity into mind, you can philosophically classify that diabetes itself is an early aging. Would you people agree? At the back, can you hear me? Tasveer bhi aa rahi hai, awaaz bhi aa rahi hai? That's good. So would you agree that it's an early aging? Diabetes? Would you agree that it's a vasculitis? Small, medium, large vessel vasculitis? Is it a metabolic type of vasculitis? Would you agree? So all these things have to be the beginning of the talk that I am going to deliver. So obesity, taking the WHO data of 2016, we see that not only the diabetes is increasing in millions, what we are seeing in billions is more than 1 billion in 2016, up 2023 end kar rahe hain. You can easily see that that 1 billion might be increased, obviously. At least 1.5 billion to ho hi gaya hoga. And the people who are in adult age group having obesity, by this definition of obesity, which is not clearly fitting into our population, which we are going to discuss a bit, that 650 million adults are having obesity, and the adolescent obesity contribute around 340 million. And look at the child, the children, our future obesity is just under 40 million children are obese. So, kahan dekha gaya ji? Asia is actually the place where people are start recognizing that this is really increasing. And these were the newspapers जो बहुत अरसे तक इसको अपनी जो है चीज़ें सजाते रहे और बताते रहे लोगों को. And look at that, this is the recent data. 2018, 2019 onward, published data, look at the people, 50% of our adult Pakistani population, every other individual is either overweight or obese. And look at the children, nearly 40% of our future is obese to start with. What are the world warcraft for these? Not the things that we see in Gaza. This has been, जैसे पहले वाले speakers ने भी कहा कि it has been for years now. And these are the things in 20 years difference of calories that had been added against 333. And these are again the same thing that has been, and look at the thing that has been given in small scripture at the end, कहाँ पे walk करनी है इस सोच के साथ. Look at the genesis and incremental size. हमारे cartoons भी उसमें, including this type of a cartoon, has also been obese or overweight. Look at the slim and look at this. So you can easily see the difference. So God knows where it ends. So this is how actually I start my talk. And the talk is so boring, so dry, that I had to have few things to cheer people up. अच्छा, अब जरा से देखें कि वो मैकेनिज्म क्या है जिसमें ओबेसिटी और कार्डियोमेटाबॉलिक डिजीज लिंक करती हैं. डिक्रीज फिटनेस, नो डाउट, अभी हमने थोड़ी देर पहले ही देखा था वेयर इट एंड्स. क्रोनिक पॉजिटिव एनर्जी बैलेंस, आपने अभी देखा कोको कोला और जो फिजी ड्रिंक्स हैं उसका साइज कैसे इंक्रीमेंट गया. जेनेटिक फैक्टर्स, इसको मैं लीस्ट टच करूंगा, जो लोग Q&A में पूछना चाहेंगे उनके साथ डिबेट हो जाएगी. So what it ends up into? It ends up into increased adipocyte. यहाँ एक कॉन्सेप्ट आएगा हाइपरप्लेजिया वर्सेस हाइपरट्रोफी. तो वो अभी हम अगले वाले स्लाइड्स में देखेंगे कि कैसे इंक्रीज होता है एडिपोसाइट और उसका क्या बॉडी पे इंपैक्ट आता है, क्लिनिकल इंपैक्ट क्या आता है. Then there is an ectopic fat. There is an increased fat in the viscera including liver, जिसकी बड़ी बात हुई सुबह से. And there is a decreased lac fat. ये हिस्सा lac, सोलियस के बैक पे एंड गैस्ट्रोनीमियस के पास, यहाँ पे फैट की डिपोजिशन डिक्रीज होती है. वी विल सी दैट व्हाट इट प्रोड्यूस क्लिनिकल इंपैक्ट. एडिपोज टिश्यू इन्फ्लेमेशन, adverse clinical signs and signals you can say from these inflamed adipose tissue, adipokines, metabolites, immune cells get active, and we end up into clinical realm of type 2 diabetes, Neufeld, hypertension, dyslipidemia, and overall increment in the cardiovascular disease. So this is how the link can easily be read. अब ये ज़रा सा difficult चीज़ है. Just put focus onto this BMI of 31, जो so called by Western data obese beginning है, obesity की beginning है. Just see that and you will find that in metabolically healthy obesity, कोई example है भाई? पीछे वाली audience यार, सामने वाले तो सारे अगस्त गैदरिंग के लोग हैं, इनसे तो कुछ बात ही नहीं हो सकती, बल्कि मैं शर्मिंदा होता हूँ जब इनकी तरफ देखता हूँ. इसीलिए मैंने थोड़ा सा पीछे ही करके रखा है कि भाई इनसे जब भी बोलेंगे भाई टाइम आउट हो गया, टाइम आउट हो जाएगा. अभी तक वैसे टाइमर ऑन नहीं किया, मेरे लिए बड़ा अच्छा काम करके रखा है. थैंक यू वेरी मच फॉर दैट. क्रू सो रहा है अभी. अच्छा, तो कोई मेटाबॉलिकली हेल्दी ओबेसिटी के ऊपर बात कर सकता है? कोई एग्जाम्पल दे सकता है तो जरूर दे दे यार. जब तक टाइमर नहीं लगा, टाइम फ्री है. टाइमर लगा हुआ है, चलिए. या sumo wrestlers. So in metabolically healthy obesity, if you find a BMI of 31 versus a person who is like me having a BMI of 31, what's the difference? The low visceral fat volume of 1.5 liter versus 3.9 liter. This is actually the difference of fat volume in healthy versus unhealthy. So there is a new concept in 2020, इस आर्टिकल से निकला, यही कॉन्सेप्ट यहीं से आया और यही वो राइटर था जिसने दुनिया को ये कॉन्सेप्ट दिया कि भाई मेटाबॉलिक हेल्दी ओबेसिटी हो सकती है. क्या करना होगा मेटाबॉलिकली हेल्दी ओबेसिटी को हासिल करने के लिए? जो ओबीस है वो पहला स्टेप क्या करेंगे? क्या करेंगे वो? एनीवन? भाई दे स्टार्ट डूइंग समथिंग. जो भी जाहिद मियां कह रहे हैं यार कुछ करना पड़ेगा ना भाई. जिस दिन आपने फैसला कर लिया और आपने पहला स्टेप ले लिया, वहां आपकी ओबेसिटी हेल्दी ओबेसिटी में टर्न अप होनी शुरू हो जाएगी. एंड दिस इज हाउ द सोमो रेसलर्स एक्चुअली डज. Once they stop doing exercise, they die. Simply as that. Till the time they does the exercise, they develop thadde and they fight with their forearms and weight to push somebody out of the ring. So this is how people need to do. And then you can easily see in the next slide what actually happens. There is in unhealthy obesity, there is an adipocyte hypertrophy, inadequate vascularization against hypertrophy, increased hypoxia, increased apoptosis, increased adipose tissue stress, immune cell infiltration, necrosis, fibrosis, and ectopic fat storage being deposited. And finally, these atherogenic pro-inflammatory signals, including adipokines, metabolites, immune cell, will yield metabolically unhealthy obesity. This is another slide that we see from our childhood. Clinically क्या important है जी? Apple shape is riskier than the pear shape. तो इसमें से pear और apple कौन है? So जब भी आप obese को देखें, इस point को भी जरूर mind में रखें कि भाई this is important. And how important clinically the obesity is? Look at this. Cardiometabolic diseases, इंटरनेशनल कंसेंसस, NCEP, ATP3, IDF, WHO, सब ने पहला पॉइंट जो है वो वेस्ट सर्कमफ्रेंस को बनाया. सो यू कैन इजीली सी दैट इट इज क्लिनिकली रेलिवेंट. द डिस्कशन इज क्लिनिकली रेलिवेंट. देन लुक एट दिस वाई पैराडॉक्स. बहुत पुरानी स्लाइड है, 2004 की, इनफैक्ट लैंसेट में पब्लिश हुई थी. क्या है इसमें? दो लोग हैं, एक कॉकेशियन है और एक एशियन है. एक की शक्ल जवानी के दौर में शाहिद आफरीदी से मिलती है, Who looks fitter in picture? शाहिद अफरीदी, बिल्कुल फैट कंटेंट ज्यादा आपने देख लिया जी 9.1 वर्सेस 21.2. सो शाहिद अफरीदी टाइप का जो बंदा है, ही लुक्स मच फिटर फिजिकली. चाइनीज, जापानीज, पाकिस्तानीज, इंडियंस, दे लुक मच यंगर, but internally they are having this 1/3 or 1/5 of their body filled up with fat, and that is the reason they look more beautiful as compared to coarse looking, more proteinaceous 9.1% fat in the Caucasian group. Now the adipose tissue acts as an endocrine gland, and I don't want to go through all that. It affects vessels, pressure, thrombosis, glucose, nutrient, reproduction, hormone, and you can see all that metabolic points. On the other hand, the insulin and insulin receptor functions are like this. Insulin जब bind कर जाती है, it produces cell growth proliferation, so it acts as an anabolic hormone. It also produces GLUT4 vesicles transport to cell membrane to uptake glucose in muscles and adipose tissue. It increases the nitric oxide production from the vessels, so it produces vasodilatation. And insulin also produces glycogen, lipid, and protein synthesis. So all these functions are of insulin on the other end. But once the person is obese, there is a word known as adiposopathic inflammatory cycles, in which these chemokines and cytokines released by the adipocytes producing adipose tissue macrophage infiltration, and then the macrophage also release their cytokines and chemokines to produce more infiltration and inflammation into the business. So the functions of adipose tissue get altered. The previous green or a blue dots had become red all, and you can easily see that the adipose tissue act as an endocrine gland, now act as a pathoendocrine gland. And this is what makes things difficult. So the obesity and adiposopathy with genetic predisposition, unhealthy nutrition, lack of physical activity, adipose tissue immunopathy, infiltrative cells, and abnormal endocrine gland will end up into impaired energy storage in peripheral subcutaneous tissue. और डॉक्टर शाहिद की एक बात से मैं एग्री नहीं कर रहा था, मैं फ्रंट पे ही बैठा था. उन्होंने कहा जी पाकिस्तानी जो है या एशियंस जो हैं उनमें फैट डिपॉजिट होता है, उनकी कद छोटे होते हैं. तो हमारा जो एक्चुअल झगड़ा है वो ये नहीं है कि हम कहाँ फैट एक्यूमुलेट करना है, दैट इज एक्चुअली द झगड़ा. ये नहीं है कि फैट एक्यूमुलेट कर रहे हैं, तो थोड़ा सा बारीक लाइन का डिफरेंस है. होता क्या है, देयर इज एन इम्पेयर्ड एनर्जी स्टोरेज इन पेरिफेरल सबक्यूटेनियस टिश्यू. जैसे अभी थोड़ी देर पहले लैक्स की बात हुई थी, एज अगेंस्ट विसरा. So fat collection at an abnormal place is actually the problem that we need to make it easy. And what abnormal collection of fat ultimately will do, यानी एक तो peripheral subcutaneous adipose tissue inadequate हो जाता है, और दूसरी तरफ जो viscera हैं they are overloaded with intra and peri-organ fat deposition, which may lead to the damage of all these viscera and their function. And how it will be producing that? The adipocyte and adipose tissue hypoxia and adipocyte death, lipotoxicity, intracellular ceramide accumulation, intraorganal, particularly the mitochondrial dysfunction do happen, maladaptive mechanotransportation transduction do happens, and release of adiposopathic factors and extracellular vesicles ultimately boils down to local and systemic insulin resistance. So how insulin resistance actually do play a role? It produces beta cell dysfunction. And this is actually what Dr. Shahid already said, sick fat disease is what obesity is. Then these sick fat disease ultimately make crosstalk between the adipose tissue, liver, adipose tissue, muscle, pancreas, brain, and other. Ultimately it ends up into clinical reality of insulin resistance, pre-diabetes and type 2 diabetes. अच्छा, एक सवाल बैक वाली ऑडियंस के लिए, ये बताइए मैक्रोवेस्कुलर डिजीज कम्स अर्लियर और माइक्रोवेस्कुलर डिजीज? वेरी फाइनल ईयर एमबीबीएस वाला सवाल. Which happens first? How many say micro? Raise their hand. Okay. And how many say macro? एक कम है. भाई इट इज द मैक्रो वेसल्स यार, मैक्रो वेसल का मतलब समझ रहे हैं ना, हार्ट डिजीज, ब्रेन डिजीज, पेरिफेरल आर्टेरियल डिजीज यार, दैट कम्स इवन अर्लियर देन द डायबिटीज, इट कम्स इन द प्री डायबिटीज, इनफैक्ट इट कम्स हियर. दिस इज द क्लिनिकल इंसुलिन रेजिस्टेंस. हार्ट क्या है, मसल है या कुछ और है? मसल है ना. तो ये एक्चुअली प्री डायबिटिक स्टेज में भी ज्यादा डैमेज हो चुकता है. और व्हाट वी सी आफ्टर द डायग्नोसिस ऑफ डायबिटीज इज माइक्रोवेस्कुलर डिजीज. ठीक है, सो किसको बचाना है? दोनों को. ठीक है, सो वी हैव टू वर्क हार्ड, जिसके लिए डॉक्टर शाहिद ने बहुत सारी एक ऑब्नोशियस पिक्चर लगा दी कि बहुत सारी प्रेग्नेंट औरतें जो हैं वो अनकवर्ड हैं और उनके पेट में बहुत कुछ चल रहा है. एंड दिस इज एक्चुअली वी नीड टू हिट हार्ड. ठीक, शादी के बाद प्री कंसेप्चुअल काउंसलिंग where things will ultimately ends up. So both obesity and diabetes has got a genetic backup. They got the environmental influence, energy imbalance, nutrient composition, microbiome, maternal obesity and diabetes, childbirth weight, medicine, pollution, sleep insufficiency. Then finally, the adipose tissue expanded. And what does that happens to do? Accelerate beta cell loss, dampens insulin sensitivity, to make hyperglycemia, which require insulin supplementation and also gains weight. So before we advocate insulin, जो 100 साल पहले डायग्नोज हुई कि भाई अब तो सारा मसला ही हल हो गया, डायबिटीज ठीक हो जाएगी, वो मसला क्यों हल नहीं हुआ? क्योंकि इंसुलिन मेक्स लाइफ मोर कॉम्प्लेक्स. ठीक है, वो क्यों? दिस इज द लास्ट पॉइंट. हाइपरग्लाइसीमिया, वी नीड इंसुलिन सप्लीमेंटेशन, इट इंक्रीजेस द वेट. सो वी हैव टू रियली थिंक पॉजिटिवली. अब थोड़ा सा डिफरेंस, ये मैं एक स्लाइड मेरे हाथ लग गई गलती से कि भाई ये जरा देख लें कि हम में और चाइनीज में क्या फर्क है. यानी हम इंडियंस में सो कॉल्ड, लाइन तो बाद में आई ना, हैं तो इंडियंस, और चाइनीज में क्या फर्क है, क्यों थोड़ा सा डिफरेंस हम लोगों में है उनके और हमारे. इंडियन पॉपुलेशन, वी गॉट अ डेफिशिएंसी ऑफ फास्ट फेज और फर्स्ट फेज इंसुलिन सिक्रीशन, and there is an increased resistance at the level of liver which produce type 2 diabetes. Look at now what the Chinese population got. They got first phase as well as second phase deficiency to begin with in pancreas, means pre-form insulin and stimulated insulin. Both have been reduced to start the process, and there is an increased resistance not at the level of liver, they got resistance at the level of skeletal tissue to make diabetes. So हमारी approach और उनकी approach में फर्क होगा management में? Obviously होगा. So we have to hit hard where? Along with insulin. So we have to take care of this and they have to take care of this because of their frame and their genetics. So, make my point, कार्डियोरीनल मेटाबॉलिक डिजीज व्हाट डायबिटीज इज, इस पर ज्यादा टाइम नहीं लगाएंगे, सभी बोल चुके हैं. ये इंपॉर्टेंट कॉन्सेप्ट था. हर एक को एक ही लाठी से हाँक दें क्लिनिकली, तो 5 आपको पता चला कि जी कोहर्ट्स बनाए गए. और वो कोहर्ट्स क्या हैं? सिवियर इंसुलिन डिफिशिएंट डायबिटीज, सेड एंड सिट का कॉन्सेप्ट. सेड क्या है जी? ऑटो इम्यून. सिट क्या है? इंसुलिन डेफिशिएंट. कुछ इत्तफाकिया है, कुछ ऑटो इम्यून है. सो 2 तो ये हो गए ग्रुप, कोहर्ट 2 ये बन गए. फिर एक हो गया सीवियर इंसुलिन रेजिस्टेंट डायबिटीज. इसमें देखिए शक्ल कैसी है, स्लिम. तो यहां क्या देना है? इंसुलिन. यहां देखें शक्ल कैसी बनी हुई है. अच्छा, इसी तरीके से एक माइल्ड ओबेसिटी रिलेटेड डायबिटीज है. इस पे बहुत डिबेट है, मैं डॉक्टर जाहिद से अभी माजरत कर लेता हूं, इस पे Q&A पे बात कर लेंगे. भाई माइल्ड है कोई चीज? देयर इज ओबेसिटी रिलेटेड डायबिटीज. शक्ल देख लें क्या बना हुआ है. एंड देर इज अनदर एज रिलेटेड, जो डॉक्टर शाहिद और मैंने अपनी बिगनिंग में कहा था, एजिंग रिलेटेड डीजनरेशन ऑफ बीटा आइलेट सेल्स. सो अगर हम अप्रोच की बात करें तो ये 5 में से 2 ऐसे हैं जिसमें एक अप्रोच काम किए बिसाइड्स इंसुलिन. वो क्या है? वेट रिडक्शन. ओबेसिटी हिट्स दीज 2 टाइप ऑफ कोहर्ट, नॉट ऑल द 5. सो वी हैव टू हिट वेरी हार्ड, taking the concept of obesity into clinical reality of the cohort. Now, treatment priorities क्या होंगी? Obesity and type 2 diabetes. Without an acute disease, you have to prioritize treatment for obesity along with treatment of diabetes. नाराज हो गया भाई, इतनी जल्दी बंद हो गया, खोलें भाई. अच्छा, without the acute disease, without the acute disease, you treat obesity. With the acute disease, you need to treat what? Diabetes. So you have to prioritize obese diabetic. क्या चीज पहले ट्रीट करनी है और कितनी करनी है. अच्छा, मैग्नीट्यूड ऑफ वेट लॉस कितना चाहिए टू प्रिवेंट कॉम्प्लिकेशन? 5 to 10% ये सभी के लिए. अब देख लें ये तमाम चीजें बचती हैं. बट टू इंक्रीज, अब आप 3 अल्फाज देखें, टाइप 2 डायबिटीज प्रिवेंशन, टाइप 2 डायबिटीज इंप्रूवमेंट, एंड लुक एट दिस, remission. Would you like remission or prevention or improvement? There are all three. So we have to go beyond controlling the sugars. We have to reduce weight, and you will get the promise of this particular reference to have those. Now, basic things kya hai? Nutrition. We should be not containing processed food. We should be simple, and we should prioritize healthy whole food, high in fiber and micronutrients. You need physical activity, इस पे बहुत बात हुई. Resistance exercise भी होनी चाहिए, steps भी होने चाहिए to improve circulation and stamina, particularly the microcirculation in heart and other vital organs. And if you talk about treating obesity and diabetes, you got bariatric procedures besides the healthy fruit, nutrition and exercise, and you got medications. And those medications should be having optimal control of both obesity and type 2 diabetes. So what are those? These are the oral medication approved: Orlistat, phentermine, topiramate, chiasma, bupropion, and the Contrav, bupropion with naltrexone. And then injectable, we can easily see liraglutide, semaglutide, setmelanotide, and tirapazide, जो आजकल काफ़ी hot है आपके इंटरनेट के ऊपर. And if you got the suggestive algorithm for the selection of anti-obesity, you take age, and you take cardiovascular disease, depression, you take into consideration of medullary cell carcinoma, NAFLD, obstructive sleep apnea, other usage of opioid and uncontrolled tachycardia, hypertension into account. And in all, the only thing that has been there which is common to all is the treatment with some drug like liraglutide. Novo वाले पीछे हैं तो बहुत खुश हो रहे होंगे. So I thank my audience for the patient listening. ये वैसे आवाज़ सुनने का मुझे भी शौक था, तो मैंने कहा सुनने के बाद ही thanks करना है. Thank you very much.
Thank you very much, Dr. Kareem Kamruddin. As Health Minister has arrived, we will go quickly to inaugural session. I will request to conclude the session, I will request Dr. Zahid Yasin Hashmi and Dr. Salma to give their comments, please.
Thank you very much. I think it's a privilege to chair a session which is full of information, and I think personally I would like to thank somebody who is not in this meeting right at this point of time. But he is the one who has changed the entire complexion of management of diabetes in this country, and that is Professor Abdul Basit. Hats off to him. I can recall some around 3 decades back, a young enthusiast who would work seriously and very seriously, and look at the team. Professor Zahid Mia and Professor Kareem, all gems. I think Bakai, the contribution of Bakai Institute, and in particular Professor Abdul Basit, we all feel indebted to all of you. A wonderful job. Foot care, I think marvelous job they have done. And I would urge our primary care colleagues to join hands with them so that more and more patients could be benefited. Just two comments. Dr. Sobia talked a lot and wonderfully on the standard of care of management for type 2 diabetes. I think we all are concerned, and rightly so, about the heart, about the kidneys, because they are killers. But for the past several decades, a lot of work has been done, and trust me, patients are being benefited. But very unfortunately, what I have observed during the last 2 decades or so is people are now dying because of MASLD related liver disease, end-stage liver, or hepatoma. I think it was in 2016 that there was a joint meeting by the EASL and EST where it was recommended that, like, monitoring the heart or surveillance for the kidneys and all that, every year a diabetic should be looked for, previously MASLD and currently MASLD. And if they have any evidence of it, I think we should seek advice from the specialist. Another comment is the gut health. It is not just diabetes and obesity, that the gut microbiota, they have a role to play. Gut microbiota, they have a role to play practically in every pathology. You talk about the psychiatric issues, the gut microbiota come in. I think we should also pay attention to the gut health. तो ये जो मट्टी के बर्तनों में जमी हुई दही बचपन में या हमसे प्रीवियस जनरेशन खाती थी, the best form of प्रीबायोटिक है ना, हर मुल्क का अपना अपना प्रीबायोटिक है. हमारे यहाँ दही और लस्सी होती थी. तो I think we should pay some attention to that as well. And I thank once again to the organizers for arranging such a wonderful show, and I'm sure, like myself and my colleagues, the audience have also enjoyed this session. Thank you very much.
Thank you, sir. Thanks a lot. I will request Dr. Salma, please.
So all the talks have been very, very impressive and very informative. As for Dr. Zahid Mia, it was 2009 that I was introduced to the concept of comprehensive foot care by Dr. Abdul Basit in a presentation in Multan. And it really made a difference, and I joined the group, and we have really made a difference in the rate of amputations going down. And we want to join your fast track program as well. I think it's the right thing to do. Dr. Sobia's presentation was extremely good. I have one humble request, that we should have our own algorithms for treatment of patients in our country. And as she rightly said, sulfonylureas are still very important to our population because of the cost benefit. And Dr. Kareem Kamruddin's presentation was also extremely informative and nice. And thank you very much. And I'll take the opportunity to thank Dr. Ahmed Shahzad and his team for an excellent meeting. Thank you.
I will also request Dr. Qazi Masroor Saab, please, your comments.
Bismillahirrahmanirrahim. Assalamu alaikum everybody. First of all, I'm thankful to the organizer and particularly Dr. Ahmed Shahzad for inviting me over here and giving me the honor for the panelists of this session. So time is short, but and after my teacher, Dr. Zahid Yasin, it is not looking nice to have a comment, but the message which I got out of this session is that if you want to prevent diabetes, diabetic foot, and obesity. And if you want to control diabetes in a good manner, we should not be focusing all the family physicians, but we should be working a lot meticulously for educating public in general and the patient in particular. Thank you very much again for inviting me over here.
Thanks a lot, sir. Now I will hand over mic to Dr. Ahmed Shahzad for inaugural session.
Thank you very much for all the panelists who have given their opinion. Due to shortage of time, I excuse the rest of the panelists that we are unable to have an opinion. Anyway, for questions answer session, kindly panelists are here at lunch, till lunch now inshallah. You can ask any question. Health Minister is on the way from the room to conference hall. So I do welcome. पता कर लीजिए, देखिए जरा आमिर साहब चल के आ गए. और मैं शुक्रिया अदा करूँगा कि सबकी पेशेंस का, सबके सब्र का, सब ने बहुत तहम्मुल से सुबह से अब तक जो सेशन माशाल्लाह पैक्ड जा रहा है, इससे शो होता है कि लोग वाकई इंटरेस्ट लेना चाहते हैं और इंटरेस्टेड हैं डायबिटीज़ मैनेजमेंट को. तो उम्मीद है कि इंशाल्लाह हम एक मुतालबा भी अभी रखेंगे सामने और उम्मीद है इंशाल्लाह आइंदा थोड़े अरसे में डिप्लोमा इन डायबिटीज़ स्टार्ट हो जाएगा FMU में इंशाल्लाह, जिससे बहुत सारे जो फैमिली फिजिशियंस हैं उनको अपने आप को अपग्रेड करने में हेल्प होगी. तो अभी इंशाल्लाह करते हैं इस बारे में भी बात. हाँ जी, मैं कॉल की है वो. हाँ इनॉग्रेशन करना. लकी डॉग का सेशन हम मिनिस्टर साहब से करवाएंगे इंशाल्लाह, सारे लोग बैठे रहें। तो जिनका लैपटॉप निकलना है और दूसरा वो स्मार्ट वॉच है प्लस वो टैबलेट है, तो वो इंतज़ार करें, बस ज़्यादा से ज़्यादा 30-35 मिनट बाद कुरानदाजी हो जाएगी इंशाल्लाह। हाँ जी जी, अस्सलाम वालेकुम। थैंक यू वेरी मच डॉक्टर जावेद इकबाल साहब। मैं रिक्वेस्ट करूंगा कि ये एज ए चीफ गेस्ट अपनी चेयर संभालें। डॉक्टर जावेद अकरम साहब से रिक्वेस्ट है स्टेज पे आएँ प्लीज़। इनके बाद मैं रिक्वेस्ट करूंगा प्रोफेसर डॉक्टर ज़फ़र चौधरी वीसी हैं फैसलाबाद मेडिकल यूनिवर्सिटी के, इनसे रिक्वेस्ट करूंगा। प्रोफेसर डॉक्टर आमिर शौकत साहब से रिक्वेस्ट है कि वो भी स्टेज पे आ जाएं। और प्रेसिडेंट पीसीए डॉक्टर जाहिद मियाँ, प्रोफेसर डॉक्टर जाहिद मियाँ कराची से, इनसे रिक्वेस्ट है कि स्टेज पे प्लीज़ आएँ। डॉक्टर रियासत प्लीज़, इलेक्ट प्रेसिडेंट इलेक्ट पीसीडीए पाकिस्तान प्लीज़। डॉक्टर इजाज़ अनवर से रिक्वेस्ट है कि वो भी स्टेज पे प्लीज़ आएँ। सुबह हमारा फॉर्मल सेशन जो है वो तो तिलावत से अल्हम्दुलिल्लाह स्टार्ट हो गया था और अल्लाह का शुक्र है कि अभी तक हम ठीक चल रहे हैं। तो हम स्टेट रिक्वेस्ट मैं अपनी इनॉग्रल स्पीच से करता हूँ। आई स्टैंड बिफोर यू टुडे विद अ प्रोफाउंड सेंस ऑफ पर्पस एंड द ऑप्टिमिज्म एज वी गैदर फॉर दिस प्राइमरी केयर डायबिटीज सिम्पोजियम। आई विश टू एम्फसाइज द इम्पोर्टेंस ऑफ आवर collective efforts in the realm of diabetes management. Diabetes, as we know, is not merely a disease, but it's a challenge. For this, in this symposium, let us pledge to collaborate and innovate and educate together. We can achieve far more than we ever could in isolation. Let us embrace this responsibility with the open hearts and sharp minds. Let us listen intently to our patients' concerns, advocate for their needs, and strive for the personalized patient-centered care. I request Honorable Health Minister and VC and Pro-VC that please start the diploma in diabetes, as we have already given the curriculum to the concerned authorities, and they have promised that they will shortly start with it as syndicate approves it. So it will be very helpful for the family physicians to upgrade their knowledge in diabetes management. I request you to please announce the diploma in diabetes from Faisalabad Medical University, which will be first ever diploma from the government side. Otherwise, Barkai Medical University is doing wonderful job. They are having the two-year diploma. So we request again and again for approval of this diploma, please. Now I request Dr. Riyasat, PCDA President, to have their presentation. It will be very short, 10 to 12 minutes only. Then we have few words from the Professor Dr. Zafar Chaudhry, and then Dr. Javed Akram will be having further opinion.
Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Riyasat Ali Khan, President-elect Primary Care Diabetes Association, and I am very grateful to all of you. Passion के साथ सुबह से सब लोग मौजूद हैं. Thank you very much audience के लिए. और उसके बाद स्पेशल थैंक्स सर जावेद अकरम साहब। सर बहुत शुक्रिया आपका। मैं सिर्फ आपसे एक बात करूंगा कि जब PCDA लॉन्च हुई है 2011 में, जब PCDA 2011 में लॉन्च हुई है तो उसके चीफ गेस्ट प्रोफेसर जावेद अकरम साहब थे और आज भी हमारे साथ हैं हमारे चीफ गेस्ट प्राइमरी केयर डायबिटीज़ असिस्टेंट। थैंक यू वेरी मच सर। साथ में VC साहब, आमिर साहब, जफ़र साहब, आप लोग थैंक यू। डॉक्टर जाहिद प्रेसिडेंट ऑफ PCDA चैप्टर है हमारे जो एजाज साहब हैं उनका, और स्पेशली अहमद शहजाद साहब। मुझे बहुत छोटा सा टाइम दिया गया है और मुझे ये भी कहा गया है कि मैं जो एसोसिएशन के बारे में बताऊं, तो मैंने कोशिश करी है कि थोड़ा दरिया को कूजे में लिपेट लूं। कहानी थी है थोड़ी सी। कुछ लोग थे, उन लोगों ने सोचा कि एक प्रॉब्लम हमें अपने प्रोफेशन में आ रही है। प्रॉब्लम की एक छोटी सी सिर्फ एग्जांपल दूंगा मैं, आप लोग प्रॉब्लम को समझना शुरू हो जाएंगे। पेशेंट आता है डॉक्टर के पास, डॉक्टर साहब मुझे तो बहुत प्यास लग रही है। ओह तुम्हें बहुत प्यास लग रही है, पानी कम हो रहा है, ग्लूकोज की ड्रिप लगा लो। डॉक्टर साहब मुझे बहुत भूख लग रही है, आप ऐसा करो ये वर्मॉक्स की गोली आती है, आप कीड़ों की दवाई ले लो। डॉक्टर साहब मुझे तो पेशाब भी बहुत आ रहा है, कोई नहीं क्रैनमैक्स साथ से पी लो। डॉक्टर साहब मेरे पाँव में जलन होती है, आप नेरोबिन के 10 इंजेक्शन लगवा लो। वेयर इज़ डायबिटीज़, वेयर इज़ स्क्रीनिंग? छोटा सा टेस्ट, मुबलिक 20 रुपये का टेस्ट हर जगह मौजूद होता है। वाई नॉट? जब नहीं हुआ तो कुछ लोगों ने सोचा कि भाई इसके ऊपर भी काम करें कि ये क्यों नहीं हो रहा। लोगों को एटलीस्ट आप प्रिवेंशन की चीज़ें, जो भी हम इतनी लंबी हमने बातें करी हैं, इन तमाम चीज़ों से पहले की भी तो चीज़ थी कि क्या नेरोबियन बनता था तो एम्पुटेशन रेट तो बढ़ेगा। क्या पॉलीपेप्स या पॉलीडिप्सिया सब भूल गए थे? किताबों में तो यही पढ़ा था। 68 की डेविडसन में भी लिखा था, आज की डेविडसन में भी लिखा हुआ है। तो क्या फ़र्क हुआ? हमारा फ़र्क हुआ, हम नहीं देख रहे। प्राइमरी केयर फिजिशियन पे जाएं, प्राइमरी फिजिशियन हर घर के अंदर एक ये कि मेरा डॉक्टर ये है, मेरा डॉक्टर ये है। लेकिन वो मेरा डॉक्टर कौन है? मेरा डॉक्टर तो कोई भी नहीं है, क्योंकि मेरा डॉक्टर डॉक्टर ही नहीं लग रहा। कैसे हल होगा? तो एक ग्रुप क्लिनिक में था, सर्व कर रहा था, उसने कहा नहीं, अब क्लिनिक से कम्युनिटी की तरफ जाना है। लेकिन जब कम्युनिटी की तरफ बढ़े तो हर्डल्स आए। अब कम्युनिटी में कौन लोग हैं? सबसे पहले तो वही प्राइमरी केयर फिजिशियन, सबसे पहले तो वही हेल्थ केयर प्रोवाइडर्स, उसके बाद बारी आती है कम्युनिटी की। तो इन लोगों ने मिलके फिर एक 2008-9 में एक ग्रुप बनाया, 3 साल लगे रजिस्ट्रेशन में और कुछ वो भी हर्डल्स थी। देन पहला प्रोग्राम किया जावेद अकरम साहब के साथ 2011 में कराची में, और अब हमारे जो डिटेल्स आगे प्रोग्राम्स और जो भी कुछ हुआ, मैंने बहुत कोशिश करी है कि इसको मैं बहुत छोटा करके आप लोगों को प्रेजेंट कर दूं। बहुत कम टाइम दिया है, बस टाइमर नहीं चलाइएगा। तो ये कुछ द कोर प्रिंसिपल्स ऑफ PCDA, ब्लूप्रिंट फॉर कंटिन्यूस इम्प्रूवमेंट। शुरू कहाँ से करें? कैपेसिटी स्ट्रेटनिंग किसकी? डेफिनेटली डॉक्टर्स, डेफिनेटली हेल्थ केयर प्रोवाइडर्स। तो क्या कर सकते थे? कुछ आसान सा हल निकालते हैं। क्या करें? लोगों को जमा करना शुरू करा। मैं खुद पर्सनली जिस एरिया में था वहाँ पर इकलौता डॉक्टर था जो इंसुलिन लिखता था, तो डॉक्टर्स कहते थे यार ये तो आखिरी इलाज है, ये क्यों लिख दिया मैंने, और उसको चेंज कर दिया जाता था। तो कहाँ से शुरू करना था? डॉक्टर से शुरू करना था। कैपेसिटी स्ट्रेटनिंग की, CMEs करी, RTTs करी, ला तादाद, मैं गिन नहीं सकता। अगर पूरी रिपोर्ट बनती है हमारी सालाना तो 18 से 20 पेज में आती है, जो अब तो पूरे पाकिस्तान में हो रहा है, लेकिन कराची से यही शुरू हुआ था। उसके बाद ये आप देख लें, लगातार कैंप्स अपनी जगह पर होते हैं, लेकिन CMEs, RTTs ये डॉक्टर्स के लिए कंटिन्यू फेस में चल रही हैं। फिर वर्कशॉप्स, फूड के वर्कशॉप्स हो रहे हैं, SMBG के वर्कशॉप्स हो रहे हैं, आपको न्यूट्रिशन के वर्कशॉप्स हो रहे हैं, ला तादाद वर्कशॉप जो कंटिन्यू थ्रू आउट पाकिस्तान PCDA चला रही है। PCDA के इस वक्त कराची के अलावा जो हेड ऑफिस है, 55 चैप्टर्स पूरे पाकिस्तान में हैं, और छोटे बड़े सब शहरों में 55 चैप्टर्स। और वेरी थैंकफुल कि मेरे चैप्टर्स के जो लोग हैं, हमारे जो लोग हैं वो यहाँ मौजूद हैं। 75% चैप्टर्स के हेड हमारे यहाँ मौजूद हैं कॉन्फ्रेंस में। वर्कशॉप्स, सिम्पोजिया, 8वां सिम्पोजियम 17-18 फरवरी को कराची मोविन पिक में है। मैं आपको यहीं से इनवाइट करता हूं कि आप लोग ज़रूर आइए। 17 और 18 फरवरी 7 सिम्पोजिया हमारे हो चुके हैं। हम लोग एनुअल नहीं करते, लेकिन इसके साथ साथ हमारे मिनी सिम्पोजियम होते हैं। जैसे लास्ट ईयर हमारा सिम्पोजियम ज़ियारत में हुआ था, देन अब ये सिम्पोजियम हमारा फैसलाबाद में हो रहा है, नेक्स्ट ईयर हमारा गुजरांवाला एंड देन सवात के अंदर प्लान है। यस, ये क्या हुआ अचानक से, जो है ना, मैं पढ़ते पढ़ते क्रिकेट खेलने आ गया। सिंध सैंड्स, बलूचिस्तान स्कॉलर्स, गिलगित बिल्तिस्तान। डॉक्टर्स को किसी तरह तो लर्न कराना है, तो थोड़ा सा फन क्यों ना हो जाए। ये हमारी HPL PCL प्राइमरी केयर डायबिटीज़ एसोसिएशन की चैम्पियंस लीग ऑल्टरनेट संडे पे होती है। ये 6 टीमें हैं जो उसमें पार्टिसिपेट कर रही हैं। केस डिस्कशन होती है, ऑनलाइन होता है, 300-400 लोग ऑनलाइन आते हैं, टीमें आपस में फाइटिंग करती हैं, केस पे क्वेश्चन होते हैं और अगर उन्होंने जल्दी से जवाब दे दिया तो उनका छक्का हो जाता है, उन्होंने थोड़ा टाइम लिया तो चौका होता है एंड देन उनको 2 मार्क्स मिलते हैं। तो ये एक चल रहा है हमारा ऑल्टरनेट संडे पे है और इसका अगर आप लोगों को लिंक चाहिए तो आप लोग भी इसके अंदर लर्न भी करेंगे एंड देन फन के साथ। तो वैसे ही आजकल क्रिकेट का बुखार है, पता नहीं आज पाकिस्तान 550 बनाता है कि नहीं बनाता है, अभी तक ये भी फिक्र चल रही है साथ साथ। हाँ जी, सेकंड ये कम्युनिटी इंगेजमेंट। अब असल बात तो ये थी, हम तो अपने तौर पे सोच लेते हैं, एक डॉक्टर दूसरे की बात भी सुन लेता है, गिले शिकवे भी हो जाते हैं, लेकिन कम्युनिटी तक कैसे जाएं? उसके लिए जो छोटी छोटी चीज़ें थी हमने शुरू करा। सबसे पहले स्क्रीनिंग प्रोग्राम, मेडिकल कैंप्स, डिफरेंट एरियाज़ में पाकिस्तान के मेडिकल कैंप्स कंटिन्यू चल रहे हैं। अजीब शहरों के जगहों पे हम गए जहाँ पे हमने कभी ज़िंदगी में तसव्वुर नहीं किया था। ज़मीनों पे चटाइयों पे बैठ के हमने कैंप करे, लेकिन हमने वहाँ पर स्क्रीनिंग करी। और इसके अंदर हम आगे क्या कर रहे हैं मैं आपको बताता हूँ। ये डिफरेंट हमारे स्क्रीनिंग प्रोग्राम्स हैं थोड़ी सी। डॉक्टर साहब कह रहे थे कि प्री डायबिटीज़ पे हम काम नहीं कर रहे। डेफिनेटली हमने सबसे पहला काम प्री डायबिटीज़ पे किया। अगर आप हमारा लोगो देखें, चारों तरफ नज़र आ रहा है, सबसे ऊपर बड़ा बड़ा लिखा है प्रिवेंशन फर्स्ट। सब देख सकते हैं कि प्रिवेंशन फर्स्ट सबसे ऊपर लगे। हम इसी पे काम कर रहे हैं। हम प्री डायबिटीज़ की बात करते हैं, हम प्राइमरी प्रिवेंशन की बात करते हैं, हम प्राइमोडियल प्रिवेंशन की बात करते हैं। सीट आउटरीच क्लिनिक पर 1 मिलियन स्क्रीनिंग सिर्फ ये देखने के लिए पाकिस्तान में कितने लोगों को डायबिटीज़ है। पूरे पाकिस्तान में ये प्रोजेक्ट चल रहा है और हम थाउजेंड्स की स्क्रीनिंग ऑलरेडी डन कर चुके हैं। प्री डायबिटीज़, रखो अपना ख्याल ज़ियाबतीस से पहले, ये हमारा प्रोजेक्ट प्री डायबिटीज़ पे है। डॉक्टर साहब कह रहे थे, मैंने कहा उनको ज़रूर बताऊंगा कि हमारा ये प्रोजेक्ट है, ऑलरेडी है और पिछले 3 साल से चल रहा है कि रखो अपना ख्याल ज़ियाबतीस से पहले। और सोशल मीडिया हर जगह इसकी मार्केटिंग है। और ये एक एक्ट्रेस हैं, मुझे इनका नाम नहीं पता, लेकिन ये कुछ मशहूर एक्ट्रेस हैं जो इस वक्त इसको रन कर रही हैं। डायबिटीज़ डे ड्राइव, मुझे बचपन में किसी ने पूछा कि भाई ये कौन सी बीमारी होती है। मैंने बड़ों से पूछा कि ये ज़ियाबतीस क्या है, किसी को नहीं पता था। कराची शहर में डिफरेंट जगहों पर डायबिटीज़ डे ड्राइव है। शारा फैसल कराची की सारे लोग जानते हैं, उसकी मेन रीजेंट प्लाजा के सामने एक बिल्डिंग है, उसको नवंबर के महीने में ब्लू किया जाता है। वहाँ पर इतना बड़ा सर्किल लगाते हैं ताकि हर छोटे बड़े बच्चों के अंदर अवेयरनेस है, उनको पता चले कि ये ब्लू सर्किल क्या है, यहाँ ये क्यों लगा हुआ है। यहाँ तो किसी अदाकारा की तस्वीर नहीं लगी, यहाँ तो पेप्सी का ऐड भी नहीं है, कुछ नहीं है, तो फिर ये सर्किल क्या है? तो सर्किल डायबिटीज़, यूनाइट फॉर डायबिटीज़, इसलिए वो सर्किल लगाते हैं ताकि लोगों को अवेयरनेस हो। इसके प्रोग्राम हमारे कंटिन्यू डायबिटीज़ डे ड्राइव चल रहा है और इस दफ़ा का डायबिटीज़ डे ड्राइव नेक्स्ट संडे हमारे पास कराची में है। अगला प्रोजेक्ट आपका तबीब, हम मेडिसिन की बात करते हैं, ये मेडिसिन देनी है, वो मेडिसिन देनी है, उससे पहले की बात क्यों नहीं करते? अगर आप लोग एल्गोरिदम देखें जिसमें दिया हुआ होता है कि जी सबसे पहले मेटफॉर्मिन देनी है, देन सल्फोनाइल यूरिया देनी है, सब लोग उसके नीचे का पढ़ रहे हैं, लेकिन उसके ऊपर भी तो लिखा होता है लाइफ स्टाइल मॉडिफिकेशन, उसमें भी तो लिखा होता है डाइट कंट्रोल। आपका तबीब ये प्रोजेक्ट न्यूट्रिशन बेस्ड है कि मरीज़ को क्या न्यूट्रिशन लेनी है, कार्ब काउंटिंग कैसे है, क्या है, ये सारी चीज़ें इसके अंदर हमारे प्रोजेक्ट में ऑलरेडी एग्जिस्ट कर रही हैं। बदलो आज बेहतर कल के लिए, करीम भाई के लिए, क्योंकि ये है डायबिसिटी। पूरे पाकिस्तान में सर डायबिटीज़ के साथ साथ ओबेसिटी पे काम हो रहा है और ये हमारा प्रोजेक्ट चल रहा है बदलो आज बेहतर कल के लिए। फिर एक डॉक्टर साहब मुझे कहने लगे अभी यहाँ पर कि जी उसका पता नहीं है कि हम सोशल मीडिया पे कैसे काम करें। हमारी तो पूरी अपनी एप्लीकेशन मौजूद हैगी। अगर आप देखें प्राइमरी केयर डायबिटीज़ एसोसिएशन के नाम से एप्लीकेशन मौजूद है और सबसे बड़ा प्रॉब्लम ये हुआ कि ये इतनी ओवरलोड हो गई है कि ये ब्लॉक हुई हुई है। इसको हमने अभी दोबारा ओपन कराना है। हमारा सिस्टम जो है वो बैठ गया, इतने ज़्यादा इसके अंदर पेशेंट के बारे में सारी इन्फॉर्मेशन पेशेंट को इस एप्लीकेशन के साथ मिल रही है। फिर डॉक्टर साहब ने कहा कि इसको मीडिया पर लेकर आएँ, कितना लाएँ। 80 प्रोग्राम्स तो मैंने खुद करेंगे ARY पे, डॉक्टर आसमा, डॉक्टर वीरू, डॉक्टर शकील, ये सारे लोग मीडिया पे प्रोग्राम कर रहे हैं, मीडिया के थ्रू भी हम जा रहे हैं। साथ में प्रिंट मीडिया है, डॉक्टर शकील का आर्टिकल हर साल डायबिटीज़ डे के ऊपर आ रहा होता है। सोशल मीडिया पे भी हमें प्राइमरी केयर डायबिटीज़ एसोसिएशन के नाम से फेसबुक पेज है, प्रिवेंशन फर्स्ट के नाम से यूट्यूब चैनल है, PCDA pak.org के नाम से हमारी वेबसाइट है, आप लोग करें। साथ साथ हमारी दूसरी वेबसाइट भी है PCDA championsleague.com.pk, जो चैम्पियंस लीग की अपनी वेबसाइट है। नेक्स्ट चीज़ है स्टेप। ये ऐसा लगा जैसे कि ये हमारा नया स्टेप है, लेकिन ये नया स्टेप नहीं, ये स्टेप पुराना स्टेप है। स्टूडेंट टास्क फोर्स फॉर एजुकेशन एंड पब्लिक हेल्थ, हमारी भी स्टूडेंट विंग है। अगर बड़े वाले लोगों की विंग होते हैं तो हमारी भी स्टूडेंट विंग है। इस स्टेप के अंदर जो बच्चे हैं वो मेडिकल स्टूडेंट हैं। 250 प्लस मेडिकल स्टूडेंट जो हैं वो इस स्टेप में काम कर रहे हैं, क्योंकि वो डॉक्टर्स नहीं हैं तो वो PCD में नहीं आ सकते, लेकिन उनके लिए स्टेप। और इन बच्चों के लिए मैं बहुत अप्रिशिएट करूंगा, स्पेशली इनका तो जो हेड है अभी स्टेप का हेड, वो यहाँ मौजूद हैं इसान साहब। तो ये बच्चे डिफरेंट काम कर रहे हैं। एक तो मेडिकल स्टूडेंट्स को डायबिटीज़ पढ़ा रहे हैं, लेकिन ये स्कूल हेल्थ पे काम कर रहे हैं। बच्चे जो स्कूल में है वहाँ पर जाके उन पे काम करते हैं, वहाँ पे स्क्रीनिंग कर रहे होते हैं। इवन ये कि ऑनलाइन PTM जब इनकी होती हैं तो उसके अंदर भी इन लोगों की डायबिटीज़ अवेयरनेस के प्रोग्राम चल रहा होता है। और साथ साथ एवरी ऑल्टरनेट मंथ पर ये 25 का इन लोगों ने एक ग्रुप बनाते हैं, प्रिसेप्टरशिप प्रोग्राम है, उनको डायबिटीज़ करा रहे हैं। तो ये बच्चे तो हमसे ज़्यादा काम कर रहे हैं। तो आई थिंक ये अप्रिशिएट करना है हमारी नई पहुंच को, और स्पेशल क्लैप्स फॉर स्टेप। बच्चे हैं अभी से, इन्हीं के ज़रिए आगे बढ़ा जाएगा। फिर हमारे दूसरे ग्रुप ड्यू, डायबिटीज़ एंड एजुकेशन विंग, जो डॉक्टर भी नहीं है और जो मेडिकल स्टूडेंट भी नहीं है, तो फिर वो डायबिटीज़ में काम करेगा तो कहाँ जाएगा, हमारे पास ड्यू में आ जाए। और ड्यू के अंदर पोडियाट्रिस्ट भी हैं, न्यूट्रिशनिस्ट भी हैं, पैरामेडिक्स भी हैं, नर्सें भी हैं, सब लोग अंडर द अम्ब्रेला ऑफ ड्यू। ये भी तो डायबिटीज़ में काम कर रहे हैं, ये भी तो प्रिवेंशन की बात करते हैं, ये भी तो सीख रहे हैं और ये भी तो सिखा रहे हैं। उसके बाद दूसरा डॉक्टर जाहिद लीड कर रहे हैं डायबिटिक फुट ग्रुप PCDA का, तो फुट में भी काम कर रहे हैं। फिर वो रोना है मोर्टेलिटी कम हो जाए, एम्पुटेशन कम हो जाए, लेकिन रेफरल भी होगा, ग्रुप भी बनेगा, लोग साथ भी होंगे, एक साथ चलेंगे। डेफिनेटली सब कुछ पॉसिबल है। हमसे बात नहीं चलेगी, मिल के करना पड़ेगा, हमारा इशू है ये। देन 3 टारगेट रखे थे। पहला तो डॉक्टर्स की तरफ चला गया, दूसरा कम्युनिटी की तरफ चला गया, लेकिन उसके बाद तीसरा भी तो था, एविडेंस बेस्ड मेडिसिन। रिसर्च भी तो होनी चाहिए। जब रिसर्च की बात करते हैं तो हमारी टीम के डिफरेंट पेपर्स हैं, और उससे पहले ये एक प्रिवेंशन फर्स्ट आप लोगों के हाथ में भी ये न्यूज़लेटर है, जो ऑनलाइन भी आता है और पेपर पे भी आता है, और ये हमारा प्रिवेंशन फर्स्ट लोगों के लिए। इसमें डिफरेंट टॉपिक्स डिफरेंट, इस वक्त तो ये इस कॉन्फ्रेंस के हवाले से जो आप लोगों के पास डेफिनेटली है। उसके बाद हमारी डिफरेंट रिसर्च हैं। अभी पिछले IDF में भी PCD की तरफ से 7 लोगों ने पेपर प्रेजेंट किए थे। इसके अलावा हम लोगों ने जो सीटाग्लिप्टिन मेटफॉर्मिन क्वालिटी ऑफ लाइफ, वो अभी पिछले वीक हमारा BMC में पब्लिश हुआ है। इसके अलावा डॉक्टर आसमा, उनके ठीक अच्छे खासे पेपर्स जो हैं वो फ्रंटियर में और BMC में पब्लिश हुए। हमारे प्रोफेसर अदनान कानपुर वाला जो देखते हैं रिसर्च को, उनके मोर देन 50 पेपर्स हैं, और उसमें PCD के सारे साथ तो रिसर्च भी साथ हो रही है। काम सिर्फ कम्युनिटी से बात करने का नहीं हो रहा, सारी चीज़ें PCDA कर रही है। क्योंकि मुझे ऐसा लगा कि बहुत सारे लोग यहाँ PCDA को नहीं जानते थे, तो इसलिए मैंने कहा ज़रा थोड़ी बहुत बातें तो हो जाएँ। तो फ्रॉम पास्ट टू फ्यूचर, कैपेसिटी स्ट्रेटनिंग, कम्युनिटी इंगेजमेंट, रिसर्च एंड पब्लिकेशन एंड रिसर्च। अपने हिस्से का चिराग कौन जलाएगा, कौन करेगा? सिर्फ स्टेज पर खड़े होकर नहीं होगा, कुर्सियों पर बैठकर नहीं होगा, बातें बनाने से नहीं होगा। अपने हिस्से का चिराग जलाना है, और अगर अपने हिस्से का चिराग जलाना है तो उसके लिए प्लीज़ जॉइंट हैंड्स विद PCDA। और अगर आप लोग ज्वाइन होना चाहते हैं तो हमारे जो मीडिया वॉल है उसके ऊपर मौजूद है लोगो PCDA का, और उसके साथ तो आपको सिर्फ चार्ज करना होगा, क्या कहते हैं उसको, QR कोड। हाँ, तो वो QR कोड यहाँ पर है मेंबरशिप फॉर्म का। जो लोग ड्यू में स्टडीज हैं, जो इंटरेस्टेड हैं, जो लोग स्टेप में हैं और जो PCDA में हैं, वो आज ही मेंबर बने। लेकिन काम सिर्फ 10 लोगों का नहीं है, काम 20 लोगों का नहीं है। क्लिनिक पर बैठ के काम नहीं होगा, सर्विंग सब कर रहे हैं, सर्व कप सब कर रहे हैं, लेकिन जब तक क्लिनिक से उठ के कम्युनिटी की तरफ नहीं जाएंगे काम नहीं होगा। और यही वो पावर है जिसके लिए लोगों ने समझा, और आज अल्हम्दुलिल्लाह पाकिस्तान भर के अंदर लोग प्राइमरी केयर डायबिटीज़ एसोसिएशन पे काम कर रहे हैं, क्योंकि काम प्राइमरी प्रिवेंशन है, प्राइमोडियल प्रिवेंशन है। मेडिसिन तो सब दे रहे हैं, ट्रीटमेंट तो सब कर रहे हैं, लेकिन मरीज़ को टाइम कोई नहीं दे रहा। गिनती की बातें हैं। मैं लोगों से सवाल करता हूँ कि ये बताओ कि तुम्हें शुगर की बीमारी कितने अरसे से है? डॉक्टर साहब मुझे 10 साल से है। मैं कहता हूँ अच्छा ये बताओ शुगर को उर्दू में क्या कहते हैं? तो शुगर को उर्दू में क्या कहते हैं? जवाब गलत है, सबको नहीं पता। देखें, हम डॉक्टर हैं, हमें नहीं पता। शुगर को तो उर्दू में चीनी कहते हैं। शुगर मिल के अंदर डायबिटिक पेशेंट नहीं बनता। हम मरीज़ को ये तो बताएं कि भाई ये चीनी वाली बीमारी है, बीमारी का नाम तो डायबिटीज़ है, बीमारी का नाम शुगर नहीं है। तो अगर ये बेसिक चीज़ें हम लर्न करें तो डेफिनेटली हम इस जंग को जी सकते हैं। हमारा मोर्टेलिटी, कार्डियोवैस्कुलर, टर्शरी केयर पे लोड, डॉक्टर जाहिद की शिकायत है एम्पुटेशन, ये रेट बढ़ रहे हैं, ये रेट बढ़ रहे हैं, लेकिन बातों से ये नहीं होगा। तो इसके लिए आप लोग सबको मेहनत करना होगी, और सिर्फ चंद लोगों ने नहीं, मेरा ख्याल है कि पूरी कम्युनिटी के अंदर हम डॉक्टर्स और हमारे पेशेंट, हमारे लोग, हमारी फैमिली, हम घर से शुरू करें। अगर हम घर के अंदर लोगों को जो है ओबेसिटी पे काम करें, कि सबसे पहला स्टेप क्या है? ओबेसिटी। हर घर में रोटी खानी है जी, तीजे की रोटी है, फला की रोटी है, रोटी से बात नहीं चल रही है। तो सारे लोग इस बात के गवाह भी हैं। तो आई थिंक आप लोगों को इसके ऊपर ज़रूर सोचना है। हम आपके साथ हैं, आप भी मिल के काम करें, हम भी मिल के काम करते हैं। और वंस अगेन थैंक यू, आप लोगों ने मुझे बर्दाश्त किया, बातें सुनी। और अगर इसके हवाले से आप पीसीडी के बारे में कुछ सुनना चाह रहे हैं और कुछ बात आपके जहन में दिल में है, तो पूरी टीम है, हमारे प्रेसिडेंट साहब वहाँ बैठे हैं, अहमद शहजाद साहब जो लीड कर रहे हैं इस कॉन्फ्रेंस को, और इसके अलावा भी बहुत सारे लोग जिनके ये वाला बैच लगा हुआ है, वो सारे लोग प्योरली पीसीडी के लोग हैं। तो आप सबसे मिल के अपने आप को रजिस्टर्ड करा सकते हैं। तो थैंक यू वेरी मच आप लोगों के पैशन का, थैंक यू।
Thank you, Dr. Riyasat. Now I request Professor Dr. Zafar Saab to... सर डिप्लोमा ज़रूर अनाउंस कीजिएगा। नहीं, सर इज़ वेरी काइंड इनफ कि उन्होंने मुझे खुद कहा था कि मतलब है कि अपना सिलेबस क्यूरिकुलम दो। आमिर शौकत साहब बहुत हमारे साथ मेहरबान रहे हैं। अब इंशाल्लाह उम्मीद है कि अनाउंस कर देंगे सर।
जी औज़ुबिल्लाहि मिनश शैतानिर रजीम, बिस्मिल्लाहिर रहमानिर रहीम। Honorable Minister of Health, Professor Javed Akram Saab, my teacher, my mentor, elder brother, a dear friend, Professor Ahmed Shahzad, Pro Vice Chancellor, Faisalabad Medical University, Dr. Zahid Mia Sahib, Dr. Ejaz Anwar Sahib, Dr. Ahmed Shahzad Sahib, और इससे पहले जो speaker, I am sorry, I am forgetting his name, Riyasat Sahib. And distinguished guests, ladies and gentlemen, Assalamu alaikum. Indeed, it's a great pleasure and pride for me to be here attending this wonderful program on primary care of diabetes. I am really so much inspired and impressed by the arrangements made by this team of Faisalabad. They came to me, I think, about 2 months back, and then they invited me on a breakfast in this particular hotel, and they discussed all the arrangements for this particular program, and they sought some help and support from me, and I was more than happy to know that such an activity is going on in this great city of Faisalabad. Since the inception of Faisalabad Medical University in 2017, I personally have seen that the academic activities in this particular city, and particularly in medical profession, they have really grown up. And before that, when I was in Lahore and Sialkot, had very seldom come to this city, and I did not know that such activities are regularly being held in the city or not. But since I've come, I've seen that there is a revolution in the academic field, especially in the medical profession. And every now and then there is some seminar, symposia going on in this city, especially under the auspices of Faisalabad Medical University. As you all know, that Punjab Medical College is now 50 years old. This year, 2023 and inshallah 2024 will be celebrated as the Golden Jubilee year of Faisalabad Medical University and PMC in particular. And for that, we have already got a stamp issued by the government as a commemorative stamp for this particular event. And every month there is a seminar being organized by one of the departments of Punjab Medical College and Faisalabad Medical University. And this particular program which is in collaboration with the Department of Medicine under the able leadership of Professor Ahmed Shahzad. I am sure that's going to be a landmark event in these celebrations. As far as diabetes is concerned, you all know that since we were medical students, especially myself, I'm quite older than you, what we have seen in last 30-40 years, that number of patients is on rise. And presently it is said that Pakistan is number 3 in the list of number of patients in diabetes, and it's going to grow. After China and India, we are at number 3. And hopefully the way it's going, maybe in 10 years' time, we are at number 1. So this is a very alarming thing, and for that, this Primary Care Diabetic Association, I'm sure they are geared up for this. And the program which I've seen shown by Dr. Yasset, I'm really impressed, the step and the awareness in the public, plus the care of the diabetic foot, and all these activities which are being organized in the different chapters of PCDA are commendable. The other thing which I have seen is that when I was a student, there was a small topic of diabetes in the book of medicine. Then it became a chapter, then it became a book, right? Now I think that diabetes has become a specialty by itself. So we need to have diabetologists as we have cardiologists and physicians, and especially in the family medicine, where we see that most of the family physicians, they are managing all the diseases as far as their general practice is concerned. But diabetes requires a special attention. And for that attention, I think these programs, they are very important. Although our family physicians, they must be managing patients who have diabetes, but there have to be certain qualified physicians who are satisfied in diabetic care, and they should render these services to diabetic patients, because things are very precise, and I don't think that we should take them lightly. The patient has to be managed with precision, not just giving metformin and controlling the blood sugar. Overall management of the patient is very important, because it's not a disease isolated to pancreas only, although the derangement is there, but it is a systemic disease affecting every organ of the body, involving every specialty, whether you are a surgeon, physician, gynecologist, cardiologist, whichever specialty you have to encounter patients who are diabetics and take proper care of them. We need to involve people who are expert in diabetes and taking care of the patients. So I think that this particular program, which is being organized today, will go a long way in training and teaching our general physicians, and also setting a pace for having certain programs and the diploma courses, especially what has been mentioned by Dr. Ahmed Shahzad, that we need to have diploma courses in diabetes. And I announce with great pride that inshallah ta'ala Faisalabad Medical University will take a lead, and we will start a diploma program. And in the next coming syndicate meeting, because our chairperson of that syndicate, the pro-chancellor of syndicate is sitting here, and he's a great physician, and all these things are very close to his heart. And inshallah ta'ala, in coming syndicate meeting, we are going to approve 2 programs. One is a family medicine program, and second is the diploma in family medicine and diploma in diabetes. So I wish all the success to this particular event, and the organizers. They really deserve a lot of appreciation, and I congratulate them on organizing this wonderful symposium. And once again, for all those delegates who have come from all the nooks and corners of the country, I welcome them to the city of Faisalabad. Thank you so much.
इससे पहले कि मैं जावेद अकरम साहब से रिक्वेस्ट करूं कि वो आएँ और अपने इजहार का ख्याल करें, अनाउंसमेंट है कि जो CCL की तरफ से लैपटॉप और दूसरी चीज़ें हैं, उनकी ड्रॉ जावेद अकरम साहब के बाद फ़ौरन हो जाएगी, इसलिए आप बैठें, और डिस्ट्रीब्यूट भी जो इनाम है वो खुद ही करेंगे। इसके बाद एक और ड्रा है, उसके लिए आप लोगों से रिक्वेस्ट है कि उसमें कूपन अपना ज़रूर डालें। 5 स्मार्ट वॉचेस हैं जो कि 3:15 बजे हम इंशाल्लाह उसकी कुरानंदाजी करेंगे। सो आप लोगों से रिक्वेस्ट है कि ये मौका हाथ से ना जाने दीजिएगा। थैंक यू वेरी मच। अब मैं डॉक्टर जावेद अकरम साहब से रिक्वेस्ट करता हूँ कि वो डाइस पे आ जाएँ। डॉक्टर जावेद अकरम साहब प्लीज़। सर थैंक यू, थैंक यू सर। कोई शीट नहीं, ये जैसे ख़त्म हो जाएगा आपका गाड़ी में सर कंप्यूटर मैंने ना सर खुद से तैयार करवाया, वो घर में यूज़ करने
बिस्मिल्लाहिर्रहमानिर्रहीम एंड अस्सलाम वालेकुम। My dear brother, Vice Chancellor, Faisalabad Medical University, Professor Zafar Iqbal Chaudhry. Of course, I think Amir Shaukat is again a younger brother, and he is responsible for bringing me here. He was, along with Ahmed Shahzad Sahab, so much committed to the work. Zahid Yasin Hashmi, another class fellow, my dear brother, Ijaz Anwar Saab, Riyasat Saab, always very keen, Zahid Mian Saab, and so many friends, families, बहनें भाई बैठे हैं। हमारे तारिक वसीम साहब बैठे हैं जो हमारे सीनियर वाइस प्रेसिडेंट हैं पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन के, और एक एक नाम लूँगा तो मेरे ख्याल इसी में टाइम गुजर जाएगा, बट वी ऑल आर वन फैमिली। कॉन्फ्रेंसों का सबसे बड़ा ठीक है एकेडमिक एक्सचेंज, और एक दूसरे से हम बहुत कुछ सीखते हैं अल्हम्दुलिल्लाह, लेकिन मेरा ख्याल है सबसे जो अच्छी एक और चीज़ है वो ये है कि हम जहाँ से रिश्ते छोड़े होते हैं, बिकॉज आई होप इन पाकिस्तान वी डोंट हैव एक्स फ्रेंड्स, वी ओनली हैव ओल्ड फ्रेंड्स। ये बहुत ज़रूरी है कि जब रिश्तों में हम ख़ासकर ऐसी प्रिमिटिव सोसाइटी जो हमारी है कि जहाँ मेरा नहीं ख्याल कि कोई भी जिस बेचारे का कुछ थोड़ा बहुत भी कोई इन्फ्लुएंस होगा, वो चाहे एलाइड हॉस्पिटल हो या मेयो हॉस्पिटल हो, वो ऐसे नहीं चला जाएगा इलाज कराने। वो ज़रूर पूछेगा MS कौन है, चीफ एग्जेक्टिव कौन है, कौन कंसल्टेंट है, फिर ही वो देखेगा कि उनका कौन जानने वाला हो सकता है, वो फिर ढूंढ के फिर करेगा। इसी तरह अगर खुदा न खास्ता में ज़िंदगी है विच इज़, और ये अनसर्टेनिटी है ज़िंदगी की कि हमें पुलिस में जाना पड़े FIR कराने या व्हाटएवर, कुछ भी हो सकता है रोड पे, तो हम भी कम से कम ये ज़रूर पूछेंगे कि कौन DSP है, SP कौन है, SHO कौन है। तो ये सिस्टम हमारा नहीं है, हमारी पर्सनैलिटीज़ आर स्ट्रॉन्गर दैन द सिस्टम अनफॉर्चुनेटली। इट शुड बी द अदर वे अराउंड। मुझे लोग कहते हैं कि ये वीकनेस है, मैं कहता हूँ कि वीकनेस ज़रूर है लेकिन स्ट्रेंथ भी यही है हमारी। दिस मेक्स अस much more dependent on each other, which makes us much more to invest in relationships. और ये relationships की बुनियाद पे आपके मेरे काम तो हो ही जाते हैं अल्लाह का फजल से। बिलीव मी, आपके बच्चों के भी हो जाएंगे। मेरे बहुत सारे काम जब मैं इंग्लैंड से आया था तो इसलिए होते थे कि मेरे वालिद कौन थे, कि उन्होंने किसी पे एहसान किए हुए थे, तो लोग कहते थे जी, उस वक़्त मुझे कोई नहीं था जानता, मैं उनके नाम से जाना जाता था। तो बहुत सारे, तो इसलिए मैं समझता हूँ कि ये कॉन्फ्रेंसेस की ये बहुत बड़ी बात है कि हमारे जहाँ से हम कई दफ़ा मसरूफ़ियत की वजह से कई साल नहीं मिलते, लेकिन फिर कॉन्फ्रेंस से मौका देती हैं कि हम मिलें और अपना रिश्ते आगे लेके जाएं, रिवाइव करें, एंड दैट इज़ एक्सट्रीमली इम्पॉर्टेंट, एज़ इम्पॉर्टेंट एज़ करिकुलम। और फैसलाबाद मैं बड़ा रेगुलर विज़िटर हूँ, चाहे वो हमारी रिपेयर एंड मेंटेनेंस 2.25 अरब रुपए की अलाइड हॉस्पिटल की कर रहे हैं, अभी मैं और ज़फ़र वहीं पे राउंड वगैरह करके आए हैं, काम देख के आए हैं, चाहे चिल्ड्रन हॉस्पिटल मुल्तान को हमने डीन भी दे दिया, उधर भी हम बहुत बड़ी रीवैम्प कर रहे हैं। फैसलाबाद इंस्टीट्यूट ऑफ कार्डियोलॉजी अगेन मेजर रीवैम्प और अपस्केलिंग उसकी बहुत ज़्यादा कर रहे हैं। इसी तरह चिल्ड्रन हॉस्पिटल की जो कंप्लीशन है वो भी बड़ी जल्दी हो जाएगी। तो इस तरह बहुत फैसलाबाद डिज़र्व्स के इतना बड़ा शहर है, लाहौर के बाद दूसरा बड़ा शहर है, और मैं समझता हूँ कि इधर बहुत कमी थी। इंशाल्लाह वी आर ट्राइंग आवर बेस्ट कि जितनी जल्दी हो सके लोगों का तजर्बा एक्सपीरियंस बेहतर हो, ताकि हम लोग बतौर डॉक्टर, मिनिस्टर, चीफ मिनिस्टर हम दुआएं समेटें। तो दैट इज़ द पर्पज़ कि हम कोशिश ये कर रहे हैं कि इन्वेस्टमेंट 100 हॉस्पिटल्स में कर रहे हैं और मोर देन 50 बिलियन रुपीस की हमारी टोटल बिल है, और हम केयर टेकर हैं। शायद हमारा ये मैंडेट नहीं था, बट ज़ाहिर है कि अगर हम कुछ कर सकते हैं, ये वो सेक्टर है जो अल्लाह के भी बहुत करीब है और इंसानों के भी बहुत करीब है, क्योंकि वहाँ से आप दुआएं भी बहुत समेट सकते हैं, और ये दुआएं सिर्फ़ आपको और मेरे को नहीं, हमारे आने वाली जनरेशन्स को संवार सकती हैं। तो शुगर तो ज़ाहिर है बहुत तफसील में बात की रियासत साहब ने, और बहुत ज़बरदस्त बातें की। आई रियली enjoyed his talk as always. और जो प्राइमरी केयर डायबिटीज़ एसोसिएशन ऑफ पाकिस्तान बहुत अच्छी, मैं समझता हूँ कि एक तो इसके बहुत मायने खेज़ ये लफ्ज़ है। मैंने अभी सोचा, मैं आई एम नॉट दैट मच फेमिलियर विद दिस बॉडी, मगर बहुत अच्छा है। और फैसलाबाद का चैप्टर तो मैं समझता हूँ कि आई सल्यूट दिस चैप्टर फॉर डूइंग व्हाट दे आर डूइंग। और लेकिन एक मैं एग्री नहीं कर रहा, मैंने वहाँ बैठ के भी पढ़ा और यहाँ से भी पढ़ रहा हूँ, मिनी सिम्पोजियम। बिलीव मी, लुकिंग एट द क्वालिटी ऑफ द ऑडियंस, मेरे से बहुत ज़्यादा अक्लमंद और समझदार लोग स्टेज के नीचे भी बैठे हैं, स्टेज के ऊपर भी। ट्रस्ट मी, मैं दिल से कह रहा हूँ। और इतनी ज़्यादा क्वालिटी मैंने बहुत कम देखी किसी भी, सिंध से हर जगह से आपने फूल इकट्ठे किए। तो इसका नाम प्लीज़ मिनी नहीं रखें, मेगा रखना चाहिए, क्योंकि इसका इम्पेक्ट भी मेगा होगा इंशाल्लाह। तो इसलिए मेरा गुजारिश है कि ये मिसनोमर, इस यू आर डाउन प्लेइंग योर स्टेटस। प्राइमरी, एक तो इसके भी दो मतलब मैं सोच रहा था वहाँ बैठ के कि प्राइमरी का मीन्स है कि दिस इज़ एन एसोसिएशन विच यू नो आई वॉलंटियर टू बी पार्ट ऑफ फॉर एवर, बिकॉज ये एक जहाद होगा जो आप कर रहे हैं। सिर्फ नीयत बदल रही है। नीयत ये नहीं कि ये सिम्पोजियम करना है, 5 स्टार में हमने रहना है, खाने खा लेने हैं, ये वो। नीयत ये है कि अल्लाह ताला की मखलूक इस मूजी मर्ज से बच जाए किसी तरह। सो इट विल बी प्राइमरी प्रिवेंशन ऑफ डायबिटीज़, दैट इज़ द मेन थिंग, कि इट इज़ दिस एसोसिएशन शुड बी मेंट टू प्रिवेंट डायबिटीज़, दैट मीन्स प्राइमरी। दूसरी, ये बेस ऑफ द पिरामिड ऑफ द डॉक्टर्स, प्राइमरी केयर में या फैमिली मेडिसिन में इसका अमल दखल है। तो दोनों इसके बहुत अच्छे मतलब निकल सकते हैं, क्योंकि मैं कई मुल्कों में अल्लाह ताला ने मुझे काम करने का मौका दिया, और मैं समझता हूँ कि कोई दुनिया का हेल्थ केयर सिस्टम वो खातर खा इम्प्रूवमेंट नहीं ला सकता जब तक आप प्राइमरी फिजिशियंस को, फैमिली फिजिशियंस को उसमें नहीं इन्वॉल्व करेंगे। दे आर द बेस ऑफ द पिरामिड, वी आर एट द टिप ऑफ द पिरामिड। दे आर द पीपल who have an opportunity to intervene when the things are still reversible. When people come to us with diabetes, their kidney function is almost gone, or started microalbuminuria or macroalbuminuria and then creatinine, or they have vascular disease already in different vascular beds, or they have eye disease, they have macrovascular disease in heart or brain. So there is very little we can do then in the tertiary care. They are the people कि जब उनके पास मरीज़ आता है और उसके पाँव अंगूठा नीला हुआ है, कटने वाला है एम्पुटेशन के लिए, तो उनके साथ जो बेटा आ रहा है वो भी बहुत मोटा है, 18-19 साल का, तो दे आर दी वंस जो उसको बहुत कन्विंस कर सकते हैं. यू आर नॉट ओनली फैमिली फिजिशियन, यू बिकम फैमिली मेम्बर. आपका इन्फ्लुएंस इतना ज़्यादा होता है उन फैमिलीज़ पे कि वो आपको ज़्यादा सीरियसली लेते हैं हमसे. बिलीव मी, मैंने बहुत सारे प्राइमरी केयर फिजिशियंस देखे जिन्होंने इलेक्शन लड़े पॉलिटिक्स में, और मुझे कोई एनालिसिस, शायद आपको पता हो, मुझे नहीं पता कि कोई इलेक्शन हारा हो, चाहे वो MPA का था चाहे मैंने का. ये अलग चीज़ है कि वो बाद में फिजिशियन ही नहीं रहे, पॉलिटिशियन ही बन गए. लेकिन हकीकत यह है कि आपकी गुडविल बहुत ज़्यादा है, आप पे कॉन्फिडेंस बहुत ज़्यादा है, आप एक एडवोकेसी जैसे कर सकते हैं, शायद हमें वो अपॉर्चुनिटी नहीं है. तो इसलिए मैं समझता हूँ कि जब हमारे पास लोग आते हैं तो उस वक़्त तो उनको ज़िंदगी बचाने की पड़ी होती है अपने वालिद की. दे आर नॉट इंटरेस्टेड, दे आर मोटिवेटेड. वो थोड़ा सा वक्ती तौर पे होता है, सिगरेट छोड़ देते हैं. आपके पास कांस्टेंट उनका बेटा भी आना है, उनका बाप भी आना है. चीमा साहब बैठे हैं, ये बिल्कुल बहुत ज़्यादा सारे ला रहे हैं क्योंकि ये इनको बहुत समझ लग रही है मेरी बात की. तो इसलिए मैं समझ रहा हूँ कि ये बहुत इम्पोर्टेंट आपका रोल है टू प्रिवेंट डायबिटीज़. 4 करोड़ लोग इस गरीब मुल्क में, एटलीस्ट 33% के करीब प्रेवलेंस भी अगर आप ले लें, जो मेरे ख्याल में अंडर एस्टिमेट है स्टिल. WHO सेज कि आपके 10-12% के करीब ओबीस और ओवरवेट हैं. मेरे ख्याल में हमारे 50% ओवरवेट एंड ओबीस हैं. हम डॉक्टरों का, अभी मैं इधर मेजरमेंट टेक ले लूँ तो अगर आप 36 इंच से ज़्यादा आपकी वेस्ट है तो यू आर ऑलरेडी ओवरवेट, एंड देन यू आर ओबीस. बहनों के लिए उससे भी कम है थ्रेशोल्ड. तो इसलिए हमारी जो है वी एशियंस, इंडो एशियंस बहुत काम किया. मैंने निपजी के साथ बहुत काम किया. अभी रियासत साहब ने बड़ी ज़बरदस्त बात की ओबेसिटी की. ओबेसिटी इज़ द मेन determinant and the risk factor for diabetes in Pakistan, not everywhere but in Pakistan, because our obesity is central obesity, lota obesity या apple obesity, and that is in the portal circulation. तो वो कहाँ लिवर में जाएगी. तो जब लिवर में जाएगी तो ऑल्दो नाम कितने भी बने, मेटाबॉलिकली लिवर डिजीज़ या व्हाटएवर, नैश या व्हाटएवर, रोज़ नाम बदल देते हैं. बट द थिंग इज़ कि इंसुलिन रेजिस्टेंस इज़ द मेन थिंग. मैंने तो बहुत देर पहले जब मैं KE में काम करता था उस वक़्त ये देखा था कि 97% ऑफ पाकिस्तानीज इवन विद नॉर्मल वेट और वट एवर वेट दे आर इंसुलिन रेजिस्टेंट. वी जेनेटिकली, एंड देर आर म्यूटेशंस which determine this insulin resistance. So insulin resistance is part and parcel of you and your children. It's only a matter of time that resistance will ultimately lead to over-exaggeration, over-stimulation of beta cells, and then apoptosis and beta cell death and fibrosis. And then insulin resistance and insulin lack, and then diabetes. So हमारे में तो ज़ाहिर है जो इंटरनेशनल निपजी के साथ जो हमने काम किया, कोशिश की, कुछ हद तक सक्सेसफुल भी हुआ, वो इन्होंने हमें ऐसे करके दिया एडिपोनेक्टिन का. एडिपोकाइन जो फैट का सेल है वो कम से कम 100 से भी ज़्यादा एडिपोकाइंस प्रोड्यूस करता है. Mostly harmful, interleukins 1, 6, 12, 2, TNF alpha, and so many glucokinase inhibitor, so many things. लेकिन एक फैट सेल, वाइट फैट सेल अच्छी चीज़ पैदा करता है, अल्लाह ने नेचुरल रखा हुआ है, वो है एडिपोनेक्टिन। एडिपोनेक्टिन इज़ स्टाइटी सिग्नलिंग आपकी बेहतर करता है, आपकी मोबिलाइज करता है फैट फ्रॉम द ऑर्गन्स टू पेरिफेरी, इंसुलिन रेजिस्टेंस कम करता है, और ऑल्सो इज़ अ वेजोडाइलेटरी पेप्टाइड, सो हाइपरटेंशन को भी रोकता है। लेकिन पाकिस्तानी फैट सेल हमने शो किया था कि वो नहीं प्रोड्यूस करता उतनी जितनी यूरोपियन या बाकी कॉकेशियंस पेश करते हैं। पाकिस्तानी, इंडो पाकिस्तानी, जब आप एशियंस में चाइनीज़ या जापानीज़ लेते हैं तो वो ओरिएंटल्स हैं, उनका नहीं मामला, ये हमारा मामला है, पाकिस्तान, बांग्लादेश, इंडो पाकिस्तान का। तो हमारी जेनेटिक्स ऐसी है कि हमारा डिपोनेक्टिन प्रोड्यूस भी नहीं होता, और अगर प्रोड्यूस होता है तो वी आर नॉट ओनली इंसुलिन रेजिस्टेंट, वी आर ऑल्सो रेजिस्टेंट टू द गुड एक्शंस ऑफ डिपोनेक्टिन। तो दैट इज़ द मेजर थिंग। और मेरा ख्याल है कि DCCT, DPP प्रोग्राम्स 1, 2 और हमारा मैंने ग्लूकोपाक स्टडी की थी डायबिटीज़ प्रिवेंशन पे। अगर मैं किसी तरीके से वॉट एवर हैपन्स, अगर इफ़ वी हैव टू लूज़ ए डियर वन, तो फिर हमें जाग आए और फिर हम करें, ये भी एक होता है कि बंदे की लाइफ चेंजिंग हो जाती है, लाइफस्टाइल बदल जाता है एकदम कि यार ये मेरे से भी हो सकता था, मेरे भाई के साथ हुआ है, मेरे से छोटा था, वॉट एवर अल्लाह ने जब किसी को अकल देनी होती है, हिदायत देनी होती है, तो अगर ज़ाहिर है जेनेटिक्स तो मैं और आप नहीं चूज़ कर सकते, ये फ्यूचर में जीन एडिटिंग हो जाएगी, शायद हमारी ज़िंदगियों में मुश्किल ये है क्योंकि पॉलीजेनिक है। सिंगल जीन की एडिटिंग तो मैं UHS में हम कर रहे थे, थैलेसीमिया की कर रहे थे, हमने शुरू की थी, लेकिन जीन एडिटिंग फॉर नाउ इज़ नॉट एन ऑप्शन। सो व्हाट इज़ एन ऑप्शन कि अल्लाह ताला ने जिस माँ बाप के घर पैदा किया, अल्हम्दुलिल्लाह, अल्लाह ताला ने ये दिमाग में, खोपड़ी में एक अकल दे दी, और अल्लाह ने कहा कि अब अपनी एनवायरमेंटल आप जो मर्ज़ी का, तो ज़ाहिर है उसमें लाइफस्टाइल अगर आपकी मॉडिफिकेशन हो जाए, जिस वजह से भी हुई, वॉट एवर इज़ वॉज दिस लाइफ चेंजिंग इवेंट, तो उसमें फिर अगर आप वर्जिश ज़िंदगी में ले आते हैं, 150 मिनट भी ले आते हैं एक हफ़्ते में, वॉक ही कर लेते हैं, बड़ी ज़बरदस्त जॉगर्स बाहर लगाए हुए थे और हुडीज़ भी लगाई हुई थी, मैं तो बड़ा इम्प्रेस हुआ उन चीज़ों से कि वाकई यू आर प्रमोटिंग समथिंग। और पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन में भी हम ये इंशाल्लाह इसी चीज़ को उजागर करेंगे और करते भी हैं। अभी हमारी बूरबन में हमने हेल्थ वॉक की, तो इसके बाद अगर वॉक करते हैं तो दूसरा, वॉट एवर इज़ योर वेट, अगर आप उसको 10% कम कर लेंगे, और जब आप 10% कम करेंगे तो यू लूज़ अबाउट 30% ऑफ द ऑर्गन ओबेसिटी। आप ऑर्गन ओबेसिटी को ही तो कम करना है, ग्लोबेसिटी तो हार्म नहीं कर रही, तो वो एक बहुत बड़ा इंसेंटिव है हमारा वेट लॉस करने का। और सस्टेन्ड वेट लॉस इज़ इम्पॉर्टेंट। और फिर अगर आप ये कर लेंगे और अपना मे बी एटलीस्ट व्हाट इज़ प्रूवन इज़ मेटफॉर्मिन, बट आई एम श्योर बहुत सारी स्टडीज़ हो रही हैं GLP-1s पे, एंड GLP-1 हैज़ चेंज द पैराडाइम। और अभी SGLT2 भी प्राइमरी प्रिवेंशन के लिए आएंगे, प्राइमरी प्रिवेंशन ऑफ डायबिटीज़। तो ख़ासकर इन हाई रिस्क जेस्टेशनल डायबिटीज़ के बाद, या पीपल हुआ बॉर्डर लाइन 6 के करीब जिनका HbA1c है, पोस्ट पेरेंडियल 160 के करीब हो जाता है, इस किस्म के जो हाई रिस्क और गुड बैड फैमिली हिस्ट्री, तो उनमें जब आप ये कर लेंगे सारा कुछ, तो अबाउट 70% डायबिटीज़ कैन बी प्रिवेंटेड, विच इज़ ए ह्यूज आस्क। मेरी गुजारिश आखिर में ये होगी कि हम बात तो बहुत कर लेते हैं, वी कैन टॉक अबाउट इट फॉर वट एवर टाइम वी कैन, बट इम्पॉर्टेंट थिंग इज़ एक्शन। मेरा मशवरा होगा रियासत साहब से, इनके साथियों से, कि एक स्टडी प्लान करें। पंजाब गवर्नमेंट विल हेल्प यू, वी विल बी मोर देन कीन। फैसलाबाद मेडिकल यूनिवर्सिटी, of which I am very lucky to be pro-chancellor, will be the focal point वी विल गिव यू दी बायोस्टैटिस्टिशियन। मैं पर्सनली आपको उसमें जितना इनपुट दे सकता हूँ, मस्जिद को लें सेंट्रल पॉइंट, हर मस्जिद को 5वें घर में जाएं और फैक्टर्स देखें, रिस्क फैक्टर्स है कि नहीं है, शुगर होने वाली है नहीं है, क्या है। वील डेवलप ए क्वेश्चनियर, मेडिकल स्टूडेंट्स हम देंगे फाइनल ईयर के आपको, 4th ईयर के। एक मोहल्ला, एक एरिया सेलेक्ट कर लें लोअर सोशल बैकग्राउंड का, आपको पता है स्लम्स का या वट, और एक हाई सोशल बैकग्राउंड का आपको पता है, एंड डू ए पायलट स्टडी एंड देन हैव दैट इंटेंसिव लाइफस्टाइल मॉडिफिकेशन एक्सरसाइज। आधा घंटा पौना घंटा साइकोलॉजिस्ट भी दे देंगे सब कुछ, एंड देन लेट्स सी what has happened to the group that we gave counseling and they changed the lifestyle actively. Every 3 months we see वजन भी lose हुआ and how much diabetes we prevented, and then you can do it all over Faisalabad. So that will be the one of the global studies जो IDF में भी आप present कर सकेंगे, और वो because that will be I think फिर उसको आप लीड करेंगे, बाकी आपको फॉलो करेंगे बाकी शहर। तो लेट्स डू दैट। आई एम अवेलेबल फॉर दिस थिंग बिकॉज रिसर्च इज़ सम हाउ माई पैशन ऑलवेज। मुझे आप 3 बजे भी रात को कहेंगे तो मैं रिसर्च के लिए टाइम दे देता हूँ। तो इसलिए ये बहुत, और सबसे ज़्यादा तारिक वसीम बैठे हैं जो हमारी रिसर्च को हेड कर रहे हैं। पाकिस्तान सोसाइटी ऑफ इंटरनल मेडिसिन आपके साथ साथ चलेगी बिल्कुल, जितने टेस्ट कहेंगे वो तारिक विल रिप्रेजेंट अस इंशाल्लाह। और हम परसों 14th of November डेडिकेटेड टू बेंटिंग एंड बेस्ट एंड ऑफ कोर्स मोर टू लियोनार्ड टॉम्सन, जो बच्चे इन्हें मर जाना था अगर इंसुलिन उसको ना लगती 14 नवंबर 1922 में। तो वो बच्चे मर जाते थे क्योंकि कैंसर की तरह थी। तो ही माशाल्लाह लिव्ड वेरी लॉन्ग एंड वेरी हेल्दी। सो वी डेडिकेट दिस डेज टू 14th of November द वर्ल्ड डायबिटीज़ डे। उस दिन मैं शुक्रगुजार हूँ गवर्नर साहब का कि गवर्नर हाउस हम तमाम पब्लिक के लिए खोल रहे हैं, तमाम डॉक्टर्स के लिए खोल रहे हैं 14 नवंबर को। मेरी रिक्वेस्ट होगी कि हम भी आए हैं आपके पास, 2 घंटे का सफ़र करके आप भी आइए। हमारे प्रेसिडेंट बैठे हैं PSIM फैसलाबाद चैप्टर आमिर शौकत, ये पूरा एक डेलीगेशन लेके आ रहे हैं, बी पार्ट ऑफ इट। गवर्नर हाउस का मकसद ये है कि वेरी ओल्ड बिल्डिंग, वेरी सीनिक, उसमें लेक भी है, उसमें बोट्स भी हैं, उसमें वॉक्स भी हैं, यू विल एंजॉय इट। मकसद ये है कि लोगों को एक इंफोटेनमेंट इंफॉर्मेशन भी दी जाए और एंटरटेन भी किया जाए, और एक मेमोरी ऐसी क्रिएट की जाए जो वो घर जाएं और उधर स्टॉल्स लगेंगे मुख्तलिफ, कोई लाइफस्टाइल का होगा, कोई ओरल ड्रग्स का, कोई इंसुलिन का, इस किस्म के। मेरा अभी जो हमारी एक मीटिंग इंटरनेशनल होती है दुबई में हुई थी, और मेरा वो टॉपिक दुबई में ही था कि इज़ इट टाइम टू से गुड बाय टू इंसुलिन। यस, I think in another 10 years we will not be using insulin at all in type 2 diabetes. इसलिए कि there are much better drugs now जो आपकी शुगर भी कंट्रोल कर रही हैं, चाहे वो SGLT2 की फॉर्म में हैं, चाहे DPP4 हैं, चाहे GLP1s हैं। इंटेंसिफिकेशन आपकी उस पे होगी, एंड दी लाइफस्टाइल का भी बहुत एविडेंस आ गया है। इसलिए मेरा ख्याल है कि इंसुलिन वी आर नाउ दिस इन November 14th 2023 it will be the onset of insulin vanishing from type 2 diabetes and being replaced by better things जो कि वेट लॉस करती हैं, इंसुलिन की तरह वेट गेन नहीं करती। आई थिंक वी आर सीइंग दैट नाउ। आई डोंट नो जब ये होगा वील बी देयर और नॉट। हजूर सल्लल्लाहु अलैहि वसल्लम ने कहा है अपनी हर नमाज आखिरी नमाज समझा करो, और उनसे बड़ी चीज़ कोई क्या कह सकता है वो नबी से। हम तो जितना शुक्र करें कि अल्लाह ने हमें इंसान बनाया, मुसलमान बनाया और उसका उम्मती बनाया, उस नबी का जिसकी हम जिसकी शान में हम पूरा दिन भी लगे रहें तो शायद 1% भी जस्टिफाई ना कर सकें, क्योंकि उनका लाइफस्टाइल देखें, उनकी ज़िंदगी देख लें, कैसी ज़िंदगी थी। गुर्बत, भूख, अफलास। वो नबी था जिसके पास दोनों जहानों की कुंजी है। उनसे ज़्यादा इन्फ्लुएंशियल बंदा ना कोई पैदा हुआ, ना कोई नबी पैदा हुआ, ना पैगंबर, ना होगा। He was a most ever blessed person, और उनको अल्लाह मियाँ ने दोनों जहानों की चाबी दे दी। He was the only person जहाँ हज़रत इज़राइल इस्लाम को मौत के फरिश्ते को कहा गया था, जब जाओगे उसकी जान लेने पूछना, इजाज़त मांगना, अगर वो कहेगा नहीं आ जाना वापस। और हुआ क्या, जब फरिश्ता गया तो हुजूर ने क्या कहा, उन्होंने कहा मैं तो इंतज़ार कर रहा हूँ अपने मालिक से मिलने का, लेकिन जाओ मेरी भी कुछ शर्तें हैं। तो फरिश्ता वापस गया अल्लाह के पास कि वो जो आपका महबूब है वो तो शर्तें लगा रहा है 3। तो अल्लाह ने कहा जाओ, ग्रांटेड। और वो शर्तें क्या थीं? ये नहीं थी कि मेरे महीना 5 साल उम्र बढ़ा दें, वो थी कि मेरी उम्मती को बख्शोगे, मैं पुल सरात पे खड़ा हूँ। हमारे अमाल इस काबिल नहीं है कम अज़ कम मेरे कि मैं सोचूं कि मैं बख्शा जाऊँगा। सिर्फ वो सिफारिश इतनी पावरफुल है कि मुझे उम्मीद है आपके लिए, मेरे लिए। और जब वो फौत हो रहे थे तो क्या हुआ, हज़रत बीबी आयशा रज़ी अल्लाह ताला अन्हा, हमारी अम्मा आयशा, उनके पास थी। तहज्जुद का वक्त था, दिया जल रहा था, दिया बुझ गया, तेल ख़त्म हो गया। दीवाना वार बाहर निकली घर के, दरवाज़े खड़खड़ाने शुरू कर दिए, तेल मिल जाए कहीं से। एक यहूदन ने दरवाज़ा खोला, उसने कहा खैरियत है, इस वक्त तुम तहज्जुद के? उन्होंने कहा मेरा मियाँ रुखसत हो रहा है अल्लाह के पास, मर रहा है, तेल नहीं है, तेल दे दो थोड़ा। तो उसने कहा कि इतना बड़ा नबी कहते हो उसको, तो उसके पास तेल भी नहीं है। तो उन्होंने कहा कि अगर तेल होता तो हम रात का खाना खा लेते, बना लेते। यानी ये एसेट्स थे उसके बंदे के, लेकिन चाबियाँ दोनों जहान की थी, जिसको जन्नत में ले जाएं, जिसको दोनों में ले जाएं, जिसको यहाँ जो मर्जी दिला दें। लेकिन फिर उसने तेल दिया और फिर ही ब्रीथ हिज लास्ट। मैं सोचता होता हूँ कि वो हुदा शायद नाम था उसका, कि वो भी बख्शी जाएगी। देखें ये एसेट्स थे, ये लाइफस्टाइल था उसका, क्या इकट्ठा कर रहे हैं। बट जो अल्लाह ने, ही वॉज द रिचेस्ट एवर पर्सन वन कैन थिंक ऑफ। मगर अल्लाह ताला हमें उनकी ज़िंदगी, उनके कहों पे अमल करने की तौफीक दे और अपनी ज़िंदगी उसी सुन्नत के मुताबिक गुजारें। अगर उनकी सुन्नतों पे आ जाएं, भूख रख के खाना है और जो जो उन्होंने किया है मुशक्क़त और मेहनत, तो फिर PCDA और हम सब PSIM मिल के कामयाब होंगे। थैंक यू।
सर 2 मिनट रुकिएगा सर यहीं पे कुछ अनाउंसमेंट्स हैं। एक तो हम कुरानदाजी अभी करने जा रहे हैं, उसके बाद ये कि टी ब्रेक होगी, तो टी ब्रेक के बाद फ़ौरन 15 मिनट आपके पास हैं। टीबी है और फार्मास्यूटिकल के स्टॉल्स भी अगर आप विज़िट करना चाहते हैं तो 15 से 20 मिनट के अंदर अंदर हम तीसरा सेशन शुरू कर देंगे। अभी हम कुरानदाजी करने जा रहे हैं, 3 प्राइजेज़ हैं। जावेद अकरम साहब से रिक्वेस्ट है कि वो कुरानदाजी करेंगे, हाशमी साहब से रिक्वेस्ट है, आमिर शौकत साहब से रिक्वेस्ट है और एजाज़ अनवर साहब से रिक्वेस्ट है कि आके वो प्राइज़ डिस्ट्रीब्यूट करेंगे प्लीज़। सर वो अच्छे इनाम हैं तो इसलिए मैंने कहा, मतलब जो हमारे पास बहुत अच्छे मतलब कि एसेट्स हैं उनको हम बुला लें ज़रा। अच्छा, इसके बाद वो जहन में रखिएगा कि दूसरी कुरानदाजी 3:15 बजे इंशाल्लाह होगी और 3:30 पौने 4 बजे हम लंच इंशाल्लाह डिलीवर कर देंगे। ठीक है सर। रिजवान साहब को बुलाइए। रिजवान साहब से रिक्वेस्ट है CCL से कि वो प्लीज़ स्टेज पे आइएगा ज़रा। पहला इनाम है एक स्मार्ट वॉच, उसके लिए कुरानदाजी होगी और डॉक्टर एजाज़ अनवर साहब से रिक्वेस्ट है कि वो जो भी विनर होगा उसको अपने हाथों से देंगे स्मार्ट वॉच। अब देखें, अच्छा इनाम सिर्फ उसी को मिलेगा जो इस हाल में मौजूद है, अदरवाइज़ अगला यानी कुरान निकलेगा सर। यार डॉक्टर फरीदुद्दीन प्लीज़, कराची से सर, ग्रेट, स्मार्ट वॉच। और डॉक्टर एजाज अनवर साहब से रिक्वेस्ट है कि वो अपने हाथों से इनको दें। हाँ जी, अच्छा,
मैं ही हूँ कराची।
ये कराची वाले हैं, ज़रा पढ़ लें, वो ऊपर लिखा होगा सर, ऊपर पढ़ लें सर। जावेद अकरम साहब से, हाँ जी, रिक्वेस्ट है कि वो ज़रा पढ़ लें। सेकंड प्राइज है, एक टैब है सैमसंग की। डॉक्टर मोहम्मद अकरम तांदलियावाला से जनाब। डॉक्टर अकरम साहब हैं? मंडी बहाउद्दीन से डॉक्टर अकरम, वाह, ये इत्तेफाक से मेरे क्लास फेलो हैं और स्पेशली आज मंडी बहाउद्दीन से ट्रैवल करके आए हैं। और दूसरा मैं शुक्रिया अदा करूंगा प्रोफेसर डॉक्टर वकार का, पिम्स के, ये हेड ऑफ डिपार्टमेंट है सर्जरी के, ये भी मेरी खातिर बहुत, आज हम कोई 30-32 साल बाद मुलाकात हुई हमारी इत्तेफाक से। डॉक्टर अकरम प्लीज़, उधर सर। डॉक्टर आमिर शौकत साहब से रिक्वेस्ट है कि इनको अपने हाथों से इनाम दीजिए। तीसरा इनाम लैपटॉप है। प्रोफेसर डॉक्टर जाहिर यासीन हाशमी साहब से रिक्वेस्ट है कि वो जिस भी कुछ, ये कौन से हैं? ये तीसरा इनाम, वो नहीं सर, अभी लैपटॉप तो है सर हमारे पास। अच्छा, ये लैपटॉप डॉक्टर सरफराज चिश्ती साहब हैं सर, क्रीम टाउन से, PC2 से प्लीज़, डॉक्टर सरफराज चिश्ती। वह प्रोफेसर डॉक्टर जाहिर यासीन हाशमी साहब से रिक्वेस्ट है कि इनको, ओह माशाल्लाह ये सर 7 बजे आए हुए हैं सर। सर हमारे पास अल्हम्दुलिल्लाह मेरे सारे जितने ऑडियंस हैं ये सुबह 9 बजे से ऐसे पैक चल रहा है सर। उधर सुन सर, थैंक यू वेरी मच सर। सबको सर हम एडिडास की हुडीज दे रहे हैं सर। अब मैं डॉक्टर जाहिद मियाँ से रिक्वेस्ट करूंगा कि वो वोट ऑफ थैंक्स के लिए ज़रा स्टेज पे आएँ और डॉक्टर जावेद अकरम साहब का शुक्रिया अदा कर दें, PCDA की तरफ से शुक्रिया अदा कर दें सर। और इसके बाद चाय की ब्रेक है, टी ब्रेक है सर। और जो लोग फार्मास्यूटिकल पे जाना चाहते हैं वो विज़िट कर लें, जो चाय पीना चाहते हैं। 15 मिनट में प्लीज़ आप वापस आइएगा ताकि हम जल्द से जल्द 2 सेशन कंप्लीट करके उसके बाद लंच है, फिर अपनी ट्रैवलिंग है सर। जाहिद मियाँ साहब प्लीज़, जाहिद मियाँ साहब प्लीज़ आइएगा सर। 2 मिनट ज़रा वोट ऑफ थैंक्स के लिए 2 मिनट ज़रा रुकिएगा सर, 1-2 मिनट प्लीज़।
Thank you very much. Thank you. Thank you very much, Janab Honorable Minister Saab, Javed Akram Saab. Thank you, Vice Chancellor Zafar Iqbal Chaudhry Saab, and शुक्रिया आमिर शौकत साहब, और शुक्रिया आप सबका जो आप लोग आए और इस महफिल को, जिसको कहते हैं रौनक लगाई और 4 चांद लगाए। और बिलाल भाई आ गए हैं तो उनका भी शुक्रिया, और बाकी लोगों का हम सुबह से शुक्रिया अदा कर रहे हैं। लेकिन एक दफ़ा जो सर ने जो 2 बातें कही हैं, सर हमेशा एडमायर करते हैं लर्नड लोगों को, एकेडमिशियन ख़ुद हैं तो एकेडमिक्स की बातें करते हैं, रिसर्च ख़ुद इतनी की हुई है तो हमें भी पीछे लगा दिया रिसर्च के। तो अब ये जो नई थॉट्स दी हैं आपने सर, इंशाल्लाह इसको ज़रूर इसको करेंगे। और जो बात आपने की है कि ये जो रिसर्च प्राइमरी प्रिवेंशन में, और सुबह भी हम यही बातें कर रहे हैं कि विदाउट डूइंग ए रिसर्च आप अपने आप को मनवा नहीं सकते पूरी दुनिया में, और सिर्फ वैल्यू इसी बात की है। तो थैंक यू वेरी मच सर, आपने हमें इस काबिल समझा कि आपने साथ शामिल किया। और जो आखिर में जो बात है वो एक दफ़ा फिर मैं कहना चाहता हूँ कि अहमद शहजाद, वी लव यू, थैंक यू वेरी मच फॉर दैट। और तमाम फार्मास्यूटिकल्स का भी शुक्रिया जो कि यहाँ पर आए, थैंक यू वेरी मच, थैंक यू।
Sain did away this.
Are you leaving?
जी सर मुझे जाना है अभी
चलो
जी सिंह जी इंशाल्लाह मुलाकात होती है 17 फरवरी को करा
जी जी जरूर
अस्सलाम वालेकुम। तमाम दोस्तों से रिक्वेस्ट है कि वो ज़रा अपनी सीट्स पे आ जाएं ताकि हम सेशन शुरू करा के जल्दी से जल्दी लंच की तरफ चल सकें। सर, फार्मास्यूटिकल से गुजारिश है कि डॉक्टर्स को अंदर प्लीज़ ले आइएगा, हम सेशन शुरू करा दें। फार्मास्यूटिकल वालों से रिक्वेस्ट है कि डॉक्टर्स को प्लीज़ अंदर ले आइएगा। बिस्मिल्लाहिर्रहमानिर्रहीम। हम अपना तीसरा सेशन स्टार्ट करते हैं, तो इसके लिए मैं पैनल ऑफ एक्सपर्ट्स के लिए रिक्वेस्ट करूंगा डॉक्टर हफीज़ चौधरी साहब से कि वो पैनल ऑफ एक्सपर्ट्स के एज ए चेयरमैन आएँ स्टेज पे प्लीज़। प्रोफेसर डॉक्टर अकमल शरीफ साहब से रिक्वेस्ट है कि वो भी स्टेज पे आ जाएं। डॉक्टर हनीफ नागरा साहब, वो शायद अभी 2 मिनट के लिए आ गए हैं। थैंक यू वेरी मच सर। डॉक्टर लुबना मिराज प्लीज़। डॉक्टर लुबना मिराज एसोसिएट प्रोफेसर हैं रावलपिंडी से, उनसे रिक्वेस्ट है। डॉक्टर उस्मान मुशर्रफ से रिक्वेस्ट है कि वो भी प्लीज़ आ जाएं। डॉक्टर उस्मान मुशर्रफ प्लीज़। डॉक्टर लुबना मिराज का पता कीजिएगा बाहर से। सुफियान, डॉक्टर लुबना मिराज का पता कीजिएगा। डॉक्टर अदरीस शानी साहब अगर हैं तो वो भी स्टेज पे आ जाएं प्लीज़। डॉक्टर आरिफ साहब अगर हैं वो भी प्लीज़ स्टेज पे आ जाएं। सर पैनल ऑफ एक्सपर्ट्स आते रहेंगे। हम पहली प्रेजेंटेशन शुरू करते हैं। प्रोफेसर डॉक्टर बिलाल बिन यूनुस हैं, लाहौर से हैं। उनसे रिक्वेस्ट है कि मैनेजमेंट ऑफ डायबिटीज़ विद इंसुलिन, इस पे उनको
एनालाइजिंग,
ये वो नई वाली है ना?
जी जी।
बस ठीक है, इधर इसको यहाँ इधर
जी।
कोई पॉइंटर वगैरह है, चेंजर एंड पॉइंटर।
चेंज इधर से होगी,
पॉइंटर और उसी के साथ चेंजर नहीं।
ये पॉइंटर, ये चेंजर, इसमें चेंज, ये पॉइंटर है लेकिन वो इस पे चलेगा।
Bismillahirrahmanirrahim. Thank you very much, all the organizers, for giving me this opportunity to talk to this august house. And as I understand, this organization started about 10 to 15 years back, and we were also invited in Karachi for so many programs which this organization had there. Happiness and sadness and tragedies, they all go together. And while on the rostrum, my heart bleeds for the Palestinian, and I also think that at least some contribution we should make for them, and the least we can do is to pray for them, and so Allah Almighty alleviate all the atrocities and the hardships which they are facing. But we also have to look for our country as well. So this is my presentation, and my topic is analyzing patients' journey and integrating insulin in diabetes management. The Honorable Health Minister, while talking a little while ago, had an opinion that insulin might not be there in 10 years' time. However, I slightly disagree, because as the role of sulfonylureas is still very important, so looking at the cost, I think insulin will remain for a very long time a part of diabetes management. So at the moment I'm working as the Chief Strategy Officer and Head of the Medical Department in a Medical College, Amna Anayat Medical College. So just a little bit of introduction of insulins. You all know that it was the Banting who first injected this thing intramuscularly to a boy, and the picture is very clear there. This is before and this is after, and this is where the journey of insulin started. So why is insulin treatment needed? We all know once the pancreas get damaged and once there is a problem in the pancreatic cells, so then it's a need for insulin. However, even before that, with the glucose toxicity, you do need insulin to bring down the blood sugar levels and later on to start with other oral anti-diabetic drugs. Again, as everybody know, it's a very progressive disease, and over time it is said that in 5 years time of diabetes, while people take oral hypoglycemics, 50% of the people do require insulin in one form or the other, and it is a progressive disease. So the objective is that when there is we call a secondary failure, only then we do need to start insulin, and that comes in 5 years' time almost, that there is some sort of insulin deficiency in patients with diabetes. So to maintain the sugar levels at a normal level or near normal level, I think that is what is required, whatever treatment you use. This is a slide which I always keep in my presentations, and it is about the treatment of a stepwise approach in treating diabetes. And you know, this is diet and exercise. You start at 9, it goes down, then it comes up, you add a monotherapy, up titration, and then a combination, then basal insulin, and then multiple insulin injections. So this is also called a stepwise approach. So you start at a low level with diet, exercise, and then you keep on going, and this is known as stepwise approach. Now, how many of us are using the stepwise approach? My colleagues from the primary practice. So how many of us are using this stepwise approach? Any idea, or if you can raise your hands? Okay. And what are the other people doing? Nothing. Okay. But this stepwise approach, I'm afraid, is a treatment to failure. Yeah. So this is again a stepwise approach, means that you at one time end up with a complication, and this is the inertia which most of us they exhibit in their practices, and I will not be astonished if most of us are using this approach. How it should be done? This is the model of proactive management of glycemic control, and if you see, once you start diet, add a monotherapy if it is not controlled, and this is the time duration of diabetes where we went on to develop the complications. Most of the people in 10 years time, they do develop some sort of complications from the onset, or if not onset, from the diagnosis of diabetes. Even if it is not controlled and not on target, which is 7, we need to add a combination of oral hypoglycemics. So the objective is to bring it down to around 7. Once it goes down and you are at the target of 6.5, again you need to, and it comes just above that, just above the level, again you have to titrate the dose. So to keep it not going up to more than 7.5 and try to bring it up, bring it down to 7, that should be the proactive approach, no matter what type of treatment you are using for that. And somehow insulin is a part of the treatment if you want to keep the A1C at a level which is recommended. So this is a summary of my talk. We will discuss it in detail, but I will try to skip over, in the interest of time, a few slides. So this is the options for insulin initiation and intensification. Now, what we have in our treatment choices is basal insulin, and if you look at the basal insulin, it's very good for the fasting plasma glucose, and as we all know, the fasting plasma glucose is something which need to be addressed initially at the high levels of A1C, and it contributes to 70% in the level of HbA1c. And as you bring down the A1C, the postprandial glucose has a major role. So at around 8 or 8.5, it's about 50% of fasting plasma glucose and 50% of the random glucose. So the advantage is easy to intensify with addition on the meal time, and the challenge is that there is a mealtime excursion. So it may bring down the fasting level, but mealtime excursions at the level where the A1C is around 6.5 or 7 is extremely important. And using the basal insulin only, probably to some extent, to sometimes it could be very beneficial, but later on you do need to intensify it. And then the premix insulins, and it covers the both fasting and postprandial. You can use it in oral, in a OD doses, which is as a basal insulin. You can use it in a BD doses and a TID doses as well, where people take 3 or 4 meals. And as in our country, I think the BD dosage might not cover the lunchtime excursions. So that is where we need to seek for some other option. So variability of the basal component, which leads to shoulder effect. We will be discussing that shoulder effect in a while, where you need to check your blood glucose to avoid hypoglycemia. Then are the insulin co-formulations, and the co-formulations, again, as we see, is both basal and mealtime coverage. So that might need, if you do 2 injections, that might need 1 in the morning, 1 in the afternoon, lunchtime, and then a basal component in the evening. So OD or BD dosage, variability is less, and there is no shoulder effect. Clinical benefits, which you get with the co-formulation, is good overall glycemic control, once or twice daily administration, and low risk of hypoglycemia, especially with the analogs, and the possibility of flexibility of the doses, and no resuspension. So these are the advantage of co-formulations. No need to go into the detail. We all know the short-acting, intermediate, and premix, what are available as a human insulins and still are being used very widely. Then are the analogs and the new generations, the aspart insulin, the Apidra, and all those. Initially, there were other insulin available by the Lilly company, which is rarely available now. And for long-acting, the glargine, which again is analog U100 and U300, and an ultra-long-acting analog, which is degludec, and most of you are now familiar with it. Then there are premix co-formulations. One is with the liraglutide and the long-acting insulin, and other is a short-acting insulin along with the ultra-long-acting, which is available by the name of Ryzodeg here. So talking about the basal only, that's a long-acting, 1 per day, intermediate acting, again 1 to 2 per day. For the premix, 1, 2, or 3 injections, as we already mentioned, and then is the rapid acting insulin, which is 3 or more per day, and then is the basal bolus. And I think the basal bolus is closer to the physiological secretions of the insulin. Now, talking about the basal insulin, as we know, these are the options, and what you need to do is to start with 0.1 or 0.2 international units per kg body weight. So you can start with that and then keep on increasing. And this is the basal insulin. If you see the NPH insulin, the human insulins, and you can also notice here that it goes up steadily and then it comes down. So there is a peak and a trough in this insulin, and obviously this does not very clearly mimic with the human secretions of insulin. Adding on or long-acting insulin analogues or ultra-long-acting probably is very near to the basal insulin secretions physiologically. So that is the advantage, that there are no peaks and troughs in analogues, the long-acting analogues. So again, there are advantages. So you can start it in the patients who are naive to insulin, and it also addresses the fear of injections, and then you can add on and you can titrate the insulin after you have started the basal insulin. And the limitations we all know is that it does not cover the peaks or excursions during the lunchtime, and the problem is that you have to inject it at the same time, and probably does not give you a lot of flexibility in injecting it. Now this is from different studies. You can see that only 31% of the patients on basal insulin who were clinically eligible for intensification actually had their treatment regime intensified. That means that there is a lot of inertia. So when it comes to 100%, only 30% of the people are intensified generally in a real world experience. And usually the time we take to intensify the insulin and intensification of basal insulin, the mean time is 3.7 years, which is again reflective of clinical inertia. So that should not be the line of action when we start the patient on basal insulin and keep on waiting until the A1C rises to 9, and then that is a stepwise approach, and we should not be doing that. Now there's one very interesting thing about the basal insulins, and it says that it is most effective when it is used at 0.5 international units and per kg body weight, and it does reduce the A1C. However, as you keep on increasing the dose of basal insulin, and as it goes to like more than 0.5, or sometimes it's one unit per body kg weight, then the effects are counterproductive. The potential of reducing A1C is reduced, and the weight gain increases significantly. So what it says is that once you have reached the peak dose, that is 0.5 per kg body weight, and if you keep on increasing the dose of that particular basal insulin, you will come across weight gain, the A1C potential is less, and chances of hypoglycemia are more. So keep that in mind. The rapid-acting insulin, obviously we know the short-acting insulin, it covers the excursions, the mealtime excursions, and you see 3 injections of this, and it does not address the basal insulin. So that is about the bolus insulin. Even if you give 3 injections a day, you could not cover the basal part of insulin. And now this is the shoulder effect. When we talk about this rapid acting, not the human insulin, the short acting insulins, you see it goes up and comes down very slowly, and this is when you inject an injection again. So this is the time when the sugar is going low, because the time between the breakfast and lunch, and there are 2 peaks with the previous insulin, and that is when you get hypoglycemia. And this is the shoulder effect we call usually in this type of insulin excursions. And this analog, it mimics very much about the physiological insulin. It goes up and comes down, and there is no shoulder effect. So that take care of the excursions of the mealtime, and it does not lead to hypoglycemia. So that is an advantage of keeping the or attaining the level of A1C without any hypoglycemia. So slow absorption of short-acting insulin, so you have to take it like 30 minutes before the meal, and then there is a shoulder effect. However, when you use analogs, it has a rapid action and decline within 4 hours, thereby minimizing the hypoglycemic effect. And benefits of and limitations, you can see it controls the mealtime glucose. It is very good in gestational diabetes. Fewer injections than the basal bolus, that is 3 versus 4. And the limitation is that you don't address the fasting plasma glucose, and the basal insulin is lacking here. The premix insulin, as we all know, the problem is that this lunchtime excursion in the blood glucose is left. And if you give 3 injections, then there are more shoulder effects. And this is, again, the lunchtime is missed. This is a problem with the premix insulins. And as if our routine is that do a working lunch or take a very little lunch, then it does work. But if you take heavy lunch, then probably, as in our culture, all our 3 meals are quite heavy. So again, this is probably will not cover the excursion which is at the lunchtime. So this is what I've already explained. Now coming on to the co-formulations, there are 2 co-formulations as I just explained. One is the GLP-1 along with the insulin, and the other is ultra long-acting insulin analog and a short-acting or a rapid-acting insulin co-formulation. It comes by Zoltofy, which is with liraglutide, and it comes by the name of and one is Sequel, from the Sanofi Aventis, Siliqua, yes, thank you, Tariq. So, and the other one is Ryzodeg, which comes in a co-formulation of a very short-acting or a rapid-acting insulin along with the ultra-long-acting insulin analog. So, again, simple regime, fewer injections with the co-formulations and greater flexibility in the dosage time. Again, this is a co-formulation concept. This is near to the physiological excursions of the insulin. And you could see this is what the co-formulation is in the brown and in the... Okay, can I have 5 more minutes? So this is about it. And then is this is I already told. The basal and bolus is like very close to the physiological, and you could see, but still if you use human insulin, there is a lot of areas when you can get the shoulder effects. However, if you use this analogs rapid acting insulin, you could see that there is no shoulder effect, very little chances, and you are also covering the basal. However, having said that, how many of us we start with 4 injections, and how many of the people in the public they accept 4 injections? I think there are very, very few people who accept that. Before altering insulin treatment, do check the patient adherence. Sometimes they are non-compliant and you start on increasing and up titration of the doses, then the technique of the injections, then the storage of the injections, and then the hypoglycemic history. These are the few things which you need to always consider. Just a case history, a very short one if you think it's relevant. So this is a man with the age of 55 years, duration is 5 years, 70 kg or 24, just slightly overweight or normal weight. The blood pressure is erratic, the blood sugar fasting is very high, so is the postprandial, and the A1C is 11. Now he is on metformin 1000 BD and 100 milligram of sitagliptin OD, photographer, and early diabetic retinopathy. So Mr. John, he agrees from 11.1 to bring down the A1C target to 7 and within 6 months. And he is motivated to avoid severe eye disease. Now, 6 months is a very, very little time. You need to see the progress and then you need to achieve the target. So he inquired about initiating basal insulin therapy. He heard that insulins are the last option, as most of us, they do argue that this is the last option. So what was done, a basal insulin was introduced, and it was the 22 units of basal insulin was introduced, the analog of course, and after 6 months his A1C fall down to 9, which is acceptable, but this is after 3 months, 12 weeks. What happened after 6 months, his basal insulin, which was glargine 100, 34 units were given, and the A1C fell down to 8.6% level. And if you increase the dose of glargine, probably that it will not help. So, as I said, 60% of the patients are not at target even after 1 year, and 6 months probably is a very little time. So this is the summary of this gentleman, that this is what he achieved after 6 months. So a very good progress from 11 to 8.6 by introducing a basal insulin. Every patient has different requirements, as we all know, and switching from basal insulin, now just a couple of slides, please bear me, just 1 or 2. So switching from basal insulin to, what would be the option? Anyone? What would be the option? To GLP-1, okay. Anything else? SGLT2 or insulins? Premix. Most of the time we use premix there. However, if you use a co-formulation with the degludec and insulin S part, so which was used in this case, so when you transfer from basal to a combination, a co-formulation, then the ratio should not increase. It should be 1:1. Whatever the basal you are using, the same dose you need to use, which happened in this gentleman. And you see, after a year's time, this is what happened. Same dose, same injection, just a co-formulation, and the things look so much better. And this is a real case scenario. So, any questions in this regard? I don't know what is the format, if you use now, ask questions now or at the end of the session. I don't know, whatever. So, thank you very much. No questions so far? Thank you.
So thank you very much for a nice presentation. Now I invite Dr. Atif Munir, consultant endocrinologist from Lahore, for his presentation.
अस्सलाम वालेकुम जी, आवाज़ आ रही है आप लोगों को? Can you hear me? Good, thank you. ठीक है, thank you. Slide show on करते हैं बस. उधर नहीं आ रहा. Okay ji, so thank you very much PCDA का बहुत शुक्रिया for the invitation. It's a pleasure and honor to be here, and I'm looking at the program, I felt that I'm the junior most speaker among all the seniors that have spoken. So if my presentation is not up to the mark, or if you feel like there are deficiencies, please forgive me. Well, there is a lot of pressure on me because I feel I'm the junior most speaking on this big and august forum. So the topic that I've been given is 360 approach to diabetes management, and I thought how to shape it up would be to signify or highlight the importance of addressing not just the HbA1c, but whatever other cardiovascular risk factors a person with diabetes usually has when they come to our clinic. So it's all about micro and macrovascular complications, and that's the aim we are all after. This is what we want to prevent. It is well known cardiovascular disease occurs 10 to 15 years early in people with diabetes, considering or as compared to those who do not have diabetes, and most people with type 2 diabetes, the mortality is due to cardiovascular disease. The mortality is even higher than cancer in type 2 diabetes, and it's all cardiovascular. Just having diabetes makes them live 6 years lesser than a person without diabetes, and 12 years lesser than a person not having diabetes if they have already had an episode of cardiovascular disease. So it's all cardiovascular disease. Now, the HbA1c is something that we run after, and we keep running after. Oops, slide, okay. So this is what we keep running after. And in this run after, we tend to shy away from other things that we should be running after in parallel with the HbA1c. So I'm going to talk about HbA1c first, but I'm going to go to other things as well, which we should be looking after and aggressively monitoring and controlling along with and in parallel with HbA1c. In the run behind the HbA1c, we tend to overlook that 90% of our people that we look after with type 2 diabetes are overweight or obese. 66% of them have hypertension, and 70% of them have dyslipidemia as well. And that's the diabetes package most of the people that we look after in clinic have. It's just not the diabetes that they have. So these are the 4 pillars of management for a person with type 2 diabetes. Obviously, the cornerstone, the base of these pillars is lifestyle management, goes without saying. Then glycemic management, then blood pressure management, lipids, and offering them the medications or the injectable therapies that are available that can make a significant difference to their cardiovascular risk, mortality, or offer renal protection. And we'll come to that towards the end because that thing has been covered adequately in the previous section, and that is way beyond what I'm going to talk about. So, cardiovascular risk reduction in a person with type 2 diabetes, glycemic control, weight, obesity, hypertension, lipids. Cardiovascular risk goes up for each 1% rise in HbA1c. We are well aware of that. ये वो चीज़ है जो हमें यानी शुरू से हमें बताया गया है कि risk इतना बढ़ता जाएगा as the HbA1c goes up. But what if we bring the HbA1c down? What difference does it make to the mortality? Death. And death is something that we want to avoid along with cardiovascular disease. So a lot of trials, we've all heard of these trials, but look at these results. As far as mortality is concerned and cardiovascular complications are concerned, it's mostly neutral. So you reduce HbA1c, you're not making a huge or a significant impact to the lifespan or to the mortality. Hence the reason that yes, HbA1c should be sought after, but other things to look for and control about. We also know that HbA1c reduction, a 1% reduction, reduces the risk of macro and microvascular complications, but microvascular complications reduce much more than macrovascular when we reduce the HbA1c. And the death is usually macrovascular events, stroke, heart attacks, etc. So, not a huge difference to those episodes or mortality with HbA1c reduction. So what's next? What's beyond HbA1c in a person with type 2 diabetes that we look after? Obesity. Everyone's talked about obesity, overweight. Yes, a big problem, huge problem. Abhi Javed Akram sahab bata ke gaye ke like the estimates in his opinion are about 50% of us, all of us, are either overweight or obese. I think he's right. If we have to do a study, I think his statistics will be absolutely proven right. So, what do we do about obesity in parallel with HbA1c? Yes, we grill, we drill, we counsel the people that we look after about weight loss. We kind of hover around the 5% mark that is guided by most. So this is coming from ADA, American Diabetes Association Standards of Medical Care in Diabetes 2022. Yes, 5%. Where does the 5% come from? We'll have a look. Calorie restriction, whether be it the 5-2 diet or the 800 kilocalorie restriction diet, the aim is to get 5% weight off, at least 5% off. Obviously, the more the better. In this 5% journey, weight loss, obviously if lifestyle is not enough, if we are lucky enough that the people that we are looking after are doing some lifestyle changes and still struggling, then obviously pharmacotherapy comes in forms of GLP-1, SGLT2 maybe, and bariatric surgery as the end of the road. So we need to think about these options as we go along, in addition to lifestyle changes. 5% weight loss, the impact, cardiovascular impact, 5-point increase in HDL, blood pressure reduction by 5 millimeters of mercury, and we know 5 millimeters of mercury translates into cardiovascular risk reduction. HbA1c reduction by 0.5 point, and this is independent of everything else. This is just 5% weight loss. So weight loss and obesity management, important cornerstone in a person with type 2 diabetes, along with HbA1c. Blood pressure. An independent cardiovascular risk factor. Don't get muddled by all these studies. So lots of big studies. Most of these studies have exclusively got people with type 2 diabetes. Most of these studies have got people with and without diabetes. The crux of these studies and most of the results, the intense blood pressure control results in significant mortality, morbidity benefit and reduction in cardiovascular risk. And the crux of these studies we've already known for years, since UKPDS told us that intensive blood pressure control reduces the risk of stroke by 44%, microvascular 37%, deaths 32%, any diabetes related endpoints 24%. So blood pressure reduction, obesity reduction in parallel with HbA1c, that's the sort of holistic approach we need to provide a person with type 2 diabetes who we are following up. Treatment goals for blood pressure, again, these are American Diabetes Association guidelines for people with diabetes. Someone with high risk, up to 130 by 80, someone with low risk, up to 140 by 90, but these are the sort of targets. Again, as I said in the beginning, it's a 10-minute or a 5-7 minute consult that we have in our clinic, and usually those 5-7 minutes hover around HbA1c alone. I know we have to develop our skills and train ourselves. You're all very experienced people, but those are the 5-7 minutes where we have to hit around or talk around the weight, talk around the blood pressure, do something about the blood pressure along with HbA1c. Lipids, cholesterol. As per last year's guideline, as you can see, virtually everyone with type 2 diabetes needs a statin, irrespective of what their cholesterol are. Those who are high risk or above a certain age group would need a high intensity statin. Those who are below a certain age, with or without a risk factor, might need a low intensity statin, but virtually everyone needs a statin. I know it adds to the pill burden, but it is reducing cardiovascular risk, which is the primary aim. So high intensity, low intensity, we're all familiar with that. I won't dwell into details. It's about the dosing and which agent do you choose depending on the age and the risk of that particular individual. So ignore this slide. So I'm coming back to the fact that a 5-minute consult as a general practitioner, as a specialist, with a person with type 2, needs to cover HbA1c, needs to cover high blood pressure, needs to cover cholesterol, needs to cover weight. Hand on heart, show of hands. Do we do all these 4 things in one consult every time a person with type 2 comes in? But it needs to be done. So I think the onus is mostly on us. We need to equip ourselves, train ourselves, tune ourselves to cover, because it's all about cardiovascular risk reduction, and it's not just one thing that we need to focus around. Anyway, so we've got medications, we've got injectables for diabetes which reduce cardiovascular risk and renal outcomes. I won't go into those details. Professor Tariq and others are going to cover these topics. But because it's cardiovascular risk reduction, we need to offer our people with type 2 diabetes any injectable, any oral hypoglycemic agent that not only improves HbA1c but has cardiovascular and renal benefits as a holistic cardiovascular risk reduction. Coming out of the cardiovascular risk reduction, because my topic is 360-degree care in type 2 diabetes, I feel in our part of the world this is a very ignored aspect of diabetes care. They're all prone to influenza, pneumonia, more than anyone else. They're all high risk. They're all immunocompromised, underproven otherwise. And usually, we don't discuss immunizations. Annual flu vaccine, pneumonia vaccine. So that should be on our list as well. It is a 360 approach. So 360 means we have to cover each and everything holistically. And I would add typhoid vaccine to the list as well, with all the resistance that we have with typhoid fever in our part of the world. I think we should add typhoid vaccine to our own national list. Agar to mil jaye. Milna bhi bada, availability is an issue as well. Anyway, I'm coming to the last bit of my presentation. Almost the last bit. Diabetes distress is coming up in literature in really good volumes as we go along. Diabetes distress is now a known entity. So we need to screen the people that we look after with type 2 diabetes for diabetes distress, for anxiety, for depression. Obviously that has a link with the diabetes control itself. So this is our job. It's not just our HbA1c, it's not just the blood pressure, it's just not the weight. We have to look for this as well. And obviously treat or refer if need be, because that's part of holistic 360 care as well. Last bit of my presentation, and that's something very close to my heart. Why I'm mentioning what's the link? I will show you in the next slide. Empowering language. This is not my slide. This slide is again from the American Diabetes Association, Standards of Care 2022. For the first time, they included the use of soft language in everyday consultations. Why is soft language important? I'll show you in the next slide. So use language that is free from stigma, use language that fosters collaboration, use language that is neutral, non-judgmental, based on facts, action, physiology. Soft language comes under the umbrella of empathy. And unfortunately, empathy is माशरे से कहाँ गायब हो रही है? I have no clue whatsoever. But it's a universal phenomenon in our country. Evidence has shown soft language and empathy improves HbA1c, independent of other factors. If you're just soft and polite with the person who's in front of you, you can make a difference to the HbA1c. Just see this study. This is one of the many studies. I thought I'll just show one slide what soft language can do to an HbA1c. सिर्फ मीठा बोलने से HbA1c नीचे जा रहा है. सिर्फ मीठा बोलने से. यहाँ पे एक हजरत अली का कोट जो है उसको मैं आई वुड लाइक टू, उनका जो कॉल है वो कोट करना चाहूँगा. हजरत अली रज़ी अल्लाह ने फरमाया कि इंसानी जिस्म एक दुकान की मानंद है, ज़ुबान उसका ताला है. जब ताला खुलता है तो पता लगता है कि ज़ुबान सोने की है कि लोहे की. And I leave you with the quote on the next slide, just signifying what we've discussed and what's very close to my heart. But the summary is, have a holistic approach. We need to get out of the HbA1c bubble and look after our patients holistically. Thank you very much. Question?
Thank you very much, Dr. Atif. Now I invite Dr. K.M. Jaya for his presentation. टाइम की कमी की वजह से हम कोई क्वेश्चन नहीं ले रहे, एक्सपर्ट ओपिनियन हम एक 30 सेकंड की ज़रूर लेंगे इंशाल्लाह. डॉक्टर K.M. Jaya सर.
Bismillahirrahmanirrahim. Can you hear me? Well, my topic is a bit difficult and I'll request you to be pleased with me. I'll try to be in time. What I have been assigned today is to talk about the diabetic triopathy. Simply, we are talking about the microvascular and macrovascular complication. I tell you honestly that this distinction is going to be blurred. Now, there's going to be no more micro as well as the macro. Both are interrelated. I'll try to prove it. Right. So they are going to be blurred. First of all, let's see what's the definition of triopathy. Simply it means trio means three, pathy means diseases. So three diseases, but they come in sequence. And the first one which comes up in a diabetic patient is basically that we have got neuropathy and then we have got the retinopathy. At the end it comes up so-called nephropathy. So what does it mean? I'm not giving you a definition. This definition is true in case of very nice type 1 diabetic patient, but type 2 diabetic people, when they present to you for the first time, 25 to 30% of them, they are having either one or the two diseases already present over there. So triopathy means if one is there, second is going to be there and you have to search for it. And then this is the definition. I'm not going to dwell on that. For diabetic neuropathy, what you have to do is only to have a microfilament and check it nicely. And what is the management? Try to control the good glycemic control. That's fine, what's going there. Then we have all the supportive medications. You all know pregabalins and duloxetine, etc. I'm not going to dwell on that. As far as the retinopathy is concerned, I as a physician, you as the healthcare professionals, you are not going to do anything. None of us, perhaps in the GP practice, is doing ophthalmoscopy to find out. We have to refer to that. And what next we have to do is, our part is only to control the glycemia, and the rest of that is going to be done by the so-called ophthalmologists, by the monoclonal antibodies or laser photocoagulation. So I'll not dwell on that. So what I'm going to do right now is, my major talk is on diabetic nephropathy. This is the most important thing which I'm going to talk. We have got diabetic nephropathy, and this is then diabetic kidney disease. TKD and CKD are the two terms being used over here. Now the classical teaching is that we have got a hyperfiltration, then there is microalbuminuria, then macroalbuminuria, then GFR declines down, and then the things start happening, so on and so forth. But now what actually is happening is that we are having majority of the people, they do not show us microalbuminuria, rather they present to us only with decline in renal function. And that is why now the term, instead of diabetic nephropathy, has been changed into diabetic kidney disease. Now these few terms we have to find out what is there. What actually is a chronic kidney disease is nothing. It's a structural or a functional disorder of the kidney, and the patient may be symptomatic or asymptomatic. For example, if the patient is having microalbuminuria or macroalbuminuria or active urinary sediment, etc., or there are structural abnormalities on the ultrasound or the other things, or you have done the biopsy, etc., or the GF has gone down, we will label it that this is basically CKD or chronic kidney disease, which may be diabetic or may be non-diabetic. And both of them are going to be equivalent at the end of the day. And then please remember the risk factors for CKD. Why? It's not an academic exercise, because if you want to manage or to prevent the ESRD or end-stage renal disease or transplantation or dialysis, you have to modify all of these things over there. Few are changeable, few are not changeable. We will be talking only of that which we can change in these cases. Now this slide we have to remember over here, because why? When we are going to select a therapy in our patient, we have to remember this classification which is over there. This is the actual albuminuria classification. We have a category of A1, when a person is having a normal urine, there's no microalbuminuria, and this is the value giving of, there are 3 types of values we have got, either 30 milligram per 24 hours or 3 milligram per millimole or less than 30 milligram per gram, one and the same thing. You may be using any unit. A2 is basically microalbuminuria, and A3 is macroalbuminuria. When you can find it out, I'm going to just incorporate later on. Then we have got another classification. Basically, first of all, we had an NKF, National Kidney Foundation classification of stage 1, 2, 3, 4, 5 going on. But now they have just made it much more bit complicated, that you take up the GFR. This is the G1 variety, which is the normal or high, and here we are having the GFR is more than 90. Please dwell with me with one time. The GFR which we are using, eGFR, that is DMRD. This does not apply over here. This is EPI, which we have to do it, because that is more reliable and more, prognostically significant over here. So if a person is having a normal GFR more than 90 milli and his albuminuria is in the A1, he is having a lower risk, or we will coming out of the heat map, this will give us a green color. And if the person is having a normal GFR and there is a microalbuminuria, the risk becomes moderate. And if still the GFR is normal, but there is a macroalbuminuria, then the risk is very high in that particular patient. Then we have type 2 over here. The GFR has fallen down by 30, and then you can again categorize as the albuminuria goes up, as at the same time the GFR goes down, the risk of death by cardiovascular disease or the other mechanisms keeps on increasing. That's why I said that there is the distinction between the micro and macro is going to be blurred off. People with kidney disease not die because of the kidney problem. They die because of the heart attack. That is a macrovascular complication. So we have to change this. Then the 3 group is divided, G3, into 2 types, 15 and 15 over here, and that remains over there. I'll again come on to this. And we have got a G4 when the GFR is only 15 to 29, and then depending upon the degree of albuminuria. So now what we are going to do when we are going to manage the people with diabetic kidney disease, we are going to take into account the 2 things. One, the degree of albuminuria, and secondly, how much is the decline in the GFR. That is going to tell us how we are going to tailor our therapy and how do we expect in that patient in all of these things. I'll request you to be with me over here. We started way back in 1990. This is the cumulative risk of death over there, and now 210. Look at this: acute myocardial infarction, stroke, amputation, etc. From 1990, the graph has come down. We are very successful. But please look at this. End-stage renal disease has not changed over time. Although we have got a calcium channel blockers, we say the doubling of serum creatinine goes down, albuminuria comes down, then why we are not able to change it? Please remember this slide. That will be a game changer as we are proceeding next in this case. This is the classical what we talked about, hyperfiltration, micro, macro, and then we have dialysis and going on. Now what we are classifying the diabetic kidney disease as albuminuric kidney disease and non-albuminuric kidney disease, and the criteria over here is the GFR done by the EPI method in this particular case. Now these are the 2 articles from JAMA and then the Journal of Diabetes Investigation. Look at this. No change in DKD between 1988 to 2014. Albuminuria reduced, although from 25% to 15%, eGFR decline increased from 9.2% to 14%. So what we are doing? Why it is so? And that is the other evidence that also is showing the same phenomena which is over there. This is one of the older slides when we had a calcium channel blockers. We said that when we use them in diabetic people, we have got a 34% reduction of the creatinine doubling time, 30% reduction in the progression to macroalbuminuria, 16% increase in the albuminuria regression. So if it is there, look at this, but there is no difference at all in the prevalence or incidence of ESRD. So where is something wrong? We are getting all the good parameters over here, but why this is not changing? And that was the first slide I told you. Please remember that, what we are doing over here. So look at this. If I summarize and take an average of this, all the macrovascular complications, they have come down over here, but ESRD stays at the same time. Why? The answer over here is use of statins. We reduce the risk of MI, stroke, etc. Fantastic. Why there is reduction in the other thing? We use the ACE inhibitors and the ARBs. All that led to this particular slope, but there is no effect of statin, ACE inhibitor or ARBs on this particular thing of ESRD and dialysis and transplant what we are facing. Ask a person who is suffering from that, then we will know how the things are going over there. Now, if you are having a CKD or ESRD, may that be because of diabetes or may that be because of any other disease, sir, the mortality keeps on rising as the GFR starts falling day by day. And ultimately the patient will succumb to the so-called macrovascular complications in these patients. This is just, the cartoonic sugar over here. If you have got a stage 1 disease, you have got a normal kidney. When the GFR goes down, only 10 to 20% loss has occurred. When we have got the stage 3A, 50% of the kidneys have gone, and you are in 3B stage, more than 50% has gone. And once you are in the stage 4, this is more than perhaps 80 to 90% of the kidney is no more there, and then you are left with the last stage where you have to go for the dialysis or the transplant in these patients. Now this is just a summary which I just told you earlier, that now we are going to correlate over here. On one end we are having the GFR, and here we are having the microalbuminuria. Now we are going to extrapolate both of these two into one. If you are having a normal GFR and there is no albuminuria, the risk of death, the risk of going into ESRD, etc. is very, very low. And although the GFR remains normal, but if the albuminuria occurs over there, micro, then you are in a yellow bar, which is rather a higher risk. And if it becomes a microalbuminuria, then it becomes rather a brownish and the risk becomes higher. And if you come on to this red color, the risk becomes very high, and if you become the brown color over there, it becomes high. Right now, just 1 or 2 years ago, we were only using up to this particular level the drug therapy. This area was prohibited to the general care physicians. And particularly I am talking about the primary care physicians. If they can keep this thing in mind, the so-called KDIGO, heat map, and try to use the drug judiciously, they can delay the progression of the kidney disease or one part of the so-called triopathy. How much shall be the frequency of screening? It depends upon the stage over there. If you are having a very low risk, yearly screening is perfectly fine. If you are in the, this brownish group, then you have a twice yearly, and if you are the reddish group, thrice, and as you are in the more severe group, we have to get 4 times screening going on in these patients. As a hub internist, myself, and the healthcare professional, primary healthcare professional, we must know our boundaries when I have to seek help from my colleague who is a nephrologist. So, sir, we have to remember over here, when the GFR is between 30 to 60, you have to refer your patient. Do not try to manage yourself. This is the kidney failure risk equation. As the GFR keeps on falling, we are having the more risk going on. What are the long-term complications of CKD? We all know that the erythropoietin is no more there. People are not eating, they are not taking anything. We also reduce the protein intake. So what is going to happen? There is anemia, and then we have got the cardiovascular disorders associated. We have got a loss of appetite, and then nausea and vomiting coming up, fluid electrolyte balance, acid-base balance, and then we have got the endocrine problems which come up, all these things. So what does it mean? It means, sir, try to do or try to act as early as possible. Here I would like to very humbly say one thing. As far as I am concerned, I do not have any guidelines. This guideline is only for me. I say always that every Pakistani who is 30 years old or above that must get his blood sugar checked after every 6 months till he or she dies. Earlier you detect, the earlier you act, and earlier you are going to prevent all of these complications in these patients over there. Now look at this, how the thing, this is the hypothetical graph over here, that if we are using the drugs which were available now, and which you as general practitioners will be using, if you are using those drugs, now this slope of fall of GFR by using the SGLT2 inhibitors, which you are all familiar with that, if you use it properly and judiciously, this slope can do in a very nice way. And look at this, approximately, though now you are increasing the, not life, but the time to go for the ESRD by 13 years. And that is a hell of a thing for our patients. So please be on your toes while we are getting all of these things in these patients over there. Right, what are the kidney disease? Please remember it's a continuum. Once it starts, it keeps on going. Although you can retard its progression, but you cannot halt its progression. It is going to go ahead, and that's why we have got a normal function, increased risk, then the damage comes, then decrease in GFR, then failure. Now look at this, how the things are going. These are the complications. Here you were as a primary care physician doing your job. Now you ask for the help of, the endocrinologist and cardiologist, and now this is the job of a nephrologist. So we always involve all our colleagues in the better management of our patient. This is just showing one thing more, that both albuminuria and the creatinine clearance, they are the eGFR, they are interrelated. If you have got only reduced eGFR, then risk is less. If you have got reduced eGFR, along with that there is also albuminuria, the risk becomes more and more, maybe double or tripled in that particular case. So benefits of early screening, we all know, you detect early and you act early, and also you are going to increase the life of your patient. Now this bar has also been shown by Dr. Atif before that. Now look at this. You may be diabetic or may not be diabetic, this thing is going to remain the same. It is a diabetic kidney disease, or is it a hypertensive kidney disease, or is it an ischemic kidney disease? The things will remain same over there. If this is a diabetic kidney disease, what is going to happen? Sorry. Okay. If it's a diabetic kidney disease, the first thing you are going to do is you have to have a good glycemic approach in that particular patient. Manage the blood pressure and also do for the lipid management, and then we have got the agents with cardiovascular and kidney benefit. Because my topic is only to talk about the kidneys, please remember what we have is ACE inhibitors, ARBs, SGLT2 inhibitors, and then we have got a GLP-1 receptor agonist, and then we have the non-steroidal mineralocorticoid receptor antagonist, that is the finerenone. These drugs we all can use in whatsoever we have got the brown or we have got the orange things coming up, and do not forget this slide as we are moving. Now, if the person is not diabetic, the only thing will change is that this thing will go off. Otherwise, if he is hypertensive, we have to have the lifestyle management and going on in this particular thing. So, approach is same, whether you are a diabetic or you are a non-diabetic. If it's a kidney disease, it's a kidney disease. That's all about it. We have to remember over it. And this is how the renal study showed when we had the ACE inhibitors and ARBs. We also had a good reduction in this particular thing, albuminuria and everything, but the time for the ESRD that remained the same over there. Now look at this. By the time the SGLT2 inhibitors have come, we have got ample evidence now. We have the AMPA kidney population over there. This was the eGFR. Now look at this. eGFR was more than 20 and less than 45 over there. We use this drug and we got the benefit. The Cadicil trial, we have the DAPA kidney trials. All that things, once they have come up, they have changed the scenario of the kidney disease management. And you as general care physicians, because the patient is going to come to you first, if you use this drug, be very well aware of this thing, you can do a lot. Not only the nephrologist, this is also your job to go ahead with this. Now here we have got kidney disease progression by diagnosis. Look at this. We have got all the trials over here. Whether this is a diabetic kidney disease, these are the number of name of the trials. Ischemic or hypertensive kidney disease, these are the trials. Glomerular disease or any other type of disease, if you use SGLT2 inhibitors, now look at this side is favoring placebo and this side is favoring the drug. So if you use a drug, what type of a kidney disease it may be, diabetic kidney disease, CKD, any other disease, if you use it at a judicious time, you are going to have a lot of benefit to your patients. That is the first game changer which we have got these days. And then we have got the other trial that is called as fertility trial over there. Here what we use, as I said earlier, the non-steroidal mineralocorticoid antagonist, which is the finerenone. Once this was used in these conditions, again look at the standard. Now you are on the left side of the line, meaning thereby that this drug is also good. I'll give you the summary at the end of this because of the time constraint. So joint ADA and KDIGO consensus report now says, first of all, what you have to do is, you have to do the lifestyle changes over there, healthy diet over there, do the physical activity. I'm standing in front of you. I used to be 85 kg, my waist used to be 42, now right now I'm 36 and my weight is now 73. What it requires is only persistence over there. And then if the patient is having a diabetic kidney disease, you give the person SGLT2. Along with that, please remember, come on to this thing, metformin. Now this can be used till the EGFR goes to 30. This is a game changer now. Don't try to avoid it. This is a well-time tested drug. Yet we are not knowing what is the exact mode of action of this particular drug. Marvelous drug. I still remember one of the senior colleagues saying in Italy, it's a crime not to use metformin in a diabetic patient. And I always practice that. So give these two drugs, and if by giving this drug, you are not reducing your, the complications of the glycemic control, then look at this, what is there? This is the GLP-1. They are also renoprotective now. And if still you are not giving, then you try to use the other types of the things over there. If somebody is having only hypertensive kidney disease, obviously are not using SGLT2 inhibitor, we will use RAS to the maximum tolerated dose, and then now we will come on to the finerenone in these particular things and control the blood pressure by the other drugs if it is not controlled, and then we have got the other things going on of this thing. So diabetic kidney disease is not only a kidney problem, it has got a three main thing with it, causes reduction in the survival time, there are cardiovascular complications, and ultimately this is the end stage renal disease over there. Now just try to look at this particular slide. If somebody gets a myocardial infarction, right, and he is having diabetes and CKD, look at the worst prognosis which we come on this particular point. He is not having diabetes, is having any type of kidney disease, look, mortality is still very high. Diabetes is there, this is this, and if there is neither diabetes, nothing else, he is standing in between. So please remember all of these things. And now what is there? SGLT2 inhibitors reduce the risk of MACE, cardiovascular death, and time for hospitalization for heart failure, myocardial infarction, stroke, and the kidney outcomes. Please remember, master these drugs. GLP-1 receptor antagonists, they are also having, look at this, they also reduce the kidney composite outcomes over there. This is just a systematic review of meta-analysis. Look at the number of patients, more than 90,000. People are using in these cases the SGLT2 inhibitors. Look at the diabetes and non-diabetic cases. We are on the right side of the curve, and patient has been saved a lot of time by going into this particular thing. This is the GLP-1 ones we are using over there. They also reduce the composite kidney, the outcome, that do not worsen the renal outcomes over there. Finerenone, as I told you earlier, we have got two tried, Fidelio as well as the Figaro over here, and if you use them, they do very well. The only thing which you have to remember is the serum potassium level, which I'll come on to this in a thing. I'll just leave this particular slide and not come on to this. Now these are the GLP-1 which we are going to use. So shall we reduce the dose? At which GFR we shall try to use it? Now please see over here. What is available in Pakistan is liraglutide. You do not have to reduce the dosage, and you can use it till the GFR goes down to 15 ml per 173. dulaglutide, and then we have the semaglutide which we are using over here, you can still go ahead and no need for the dosage reduction, and you will get the kidney. This is all the holistic approach over here. So if you are having a patient who has got diabetes, you will go for the lifestyle modification. The first drug of choice is SGLT2 and plus the metformin till the EGFR is 30, and if it is not controlled, then you move on to GLP-1. If not, then you can go ahead. This is the same slide which is coming up over there. So dietary, we all know we have to give the high in vegetable and etc. I'm not going to dwell on that. Adverse effects of GLP-1 is only nausea and vomiting. So how you can do it? Avoid fried foods, give small foods over there, and avoid taking lots of fibrous foods. We can come across with over there. Now once again bring this to mind, and now you can see that how the things are going on as we move on. Now this is a very fantastic, data, meta-analysis of various trials of use of finerenone. Once this was used, again you can see in all of these trials, there is a benefit of using this particular drug in these cases. If we are using the SGLT2 inhibitors, in what dose we shall use it? Cana perhaps is not available in Pakistan. DEPA we start with the full dose of 10 milligram till the EGFR is, look at this, please remember. If it is more than 20, please do use it. It's you who are going to do it, and then refer the patient to whatsoever over there. And EMPA, you start with the 10 milligram. We are well aware of this particular thing. While we are using the finerenone over here, we have to keep only the serum potassium into level. If it is less than 4.8, start with 10 milligram and then increase to the 20 milligram dose and monitor the serum potassium at monthly interval. If it is between 4.9 to 5.5, you can start with the same dosage. If it is more than 5.5, please withhold before you bring it down, and then you can use later on over there. So, my colleagues, my brothers and seniors over here, data from the cardiovascular outcome trials of the novel GLP-1, SGLT2, it reduces the MACE, it reduces the progression to end-stage renal disease. Remember that slide, the slope was coming down, but that was flat. Now you can bring it down by doing all of these. And this is my key message. We are saying DKD prevalence indices are on the rise, and early detection and appropriate management are critical. In addition to urine albumin-creatinine ratio, EGFR should be done by EPI method, and SGLT2 inhibitors, and then GLP-1 and the finerenone are there. I say thank you very much for listening me carefully. Any questions?
Due to shortage of time, हम क्वेश्चंस नहीं ले रहे. थैंक यू वेरी मच याजा साहब. पैनलिस्ट से रिक्वेस्ट है कि एक मिनट की ज़रा अपनी ओपिनियन दे दें. मैं प्रोफेसर डॉक्टर लुबना महराज से शुरू करूँगा कि अपनी ओपिनियन दे दें. इनका पहले तो बहुत शुक्रिया, ये रावलपिंडी से हमारे लिए स्पेशली आई हैं, तो फैसलाबाद ये पहली दफ़ा आई हैं.
Thank you for inviting me. My just opinion is that कि biosocial model is very important. अगर we do not know the social status of the patient, either she or he cannot buy any food for them, तो फिर वो ड्रग क्या ख़रीदेगा. तो इस पे भी फोकस करना बहुत ज़रूरी है, क्योंकि हमें हेल्प करनी चाहिए उन लोगों की जो ड्रग नहीं ख़रीद सकते. तो ड्रग कंपनी से और जो हमारे प्राइमरी और सेकेंडरी और टर्शरी हॉस्पिटल वाले हैं, सबको ये भी देख लेना चाहिए कि घर में उनको क्या वजह है, क्यों नहीं ड्रग ले रहे और उनकी कंप्लाइंस क्यों नहीं कंटिन्यू. तो जो एक शॉर्टेज मैंने इसमें देखी वो ये था कि हम इस पे टाइम नहीं स्पेंड करते कि साइको सोशल मॉडल पर बात करें. थैंक यू.
डॉक्टर उस्मान शरफ प्लीज़.
Bismillahirrahmanirrahim. First of all, thank you very much, Dr. Ahmed Shahzad and Dr. Ijaz Anwar, to get me here and for arranging such a wonderful symposium.
Thank you, sir.
And for inviting such a quality speakers over here. Thank you very much.
Welcome, sir.
Second, it's an honor for me to talk, to be on stage with my teachers and my immediate boss, Professor Dr. Hanif Nagra. Thank you very much. Now, UKPDS, Dr. Atif very well mentioned the UKPDS trial. It was a landmark trial in history of type 2 diabetes. there was one thing that was hidden in UKPDS trial, that the window of opportunity is there in early course of type 2 diabetes. If we control glycemia in early course of type 2 diabetes, if we avail this window of opportunity, we can delay the onset of type 2 diabetes by years. We can reduce the decline in beta cell mass over years with this window of opportunity. So here comes the role of primary care physician in this window of opportunity, because they can use the glucocentric approach, they can use obviously they need to use the cardiocentric and renal centric approach as well as the evidence-based medicine to control the diabetes. Obviously our primary care physicians, they form the base of a healthcare pyramid. Obviously it is the need of time to empower our primary care physician to avail this window of opportunity and to prevent and delay the complications related to diabetes. Thank you very much.
Dr. Adriz Shani sir, please. Sir, आपका बाद में.
Thank you very much for expert opinion. First of all, I congratulate Jaz Sahab and Dr. Ahmed Shahzad Sahab for such a wonderful audience and the excellent speakers. बिलाल साहब ने और याया साहब ने बड़ा एक्सलेंटली प्रेजेंट किया है. इसमें जो इम्पोर्टेंट चीज़ है कि आपने इनिशिएट कब करना है इंसुलिन को, दैट इज़ वेरी इंपॉर्टेंट. हमारे पास पेशेंट आते हैं, वो आमतौर पे वो कहते हैं कि हम पहले साल में ही हमने इंसुलिन शुरू कर ली डायबिटीज़ की ना. कुछ ऐसे पेशेंट हैं वो 15 ईयर्स के बाद भी नहीं यूज़ करते हैं इंसुलिन. सो इनिशिएशन ऑफ द इंसुलिन इज़ वेरी इंपॉर्टेंट. तो वी यूज़ टू से कि अगर पेशेंट आपके पास आ रहा है तो आप उसमें ये देखें कि उसकी डायबिटीज़ की एज क्या है. अगर पेशेंट की डायबिटीज़ की एज 3 ईयर्स से ज़्यादा है तो उसको स्ट्रांगली कंसिडर करें ही में और शी में बी ए कैंडिडेट फॉर इंसुलिन स्टार्टिंग. उसमें ये है कि आपने उसकी डायबिटिक रेटिनोपैथी को, उसकी फंडोस्कोपी मस्ट है वो करवाएं. अगर रेटिनोपैथी है तो इंसुलिन स्टार्ट कर सकते हैं, अगर नहीं है यू कैन डिले इट. सिमिलरली उसका माइक्रोअल्ब्यूमिन लाजमी चेक कराएं. इफ़ इट इज़ मोर देन 3 ईयर्स टाइम तो उसमें अगर माइक्रोअल्ब्यूमिन है तो आप इनिशिएट करें. अगर नहीं है तो यू मे कंटिन्यू विद द ओरल अगर A1C अच्छा कंट्रोल है. सो आई थिंक जो इनिशिएशन ऑफ द इंसुलिन है ये बड़ी इंपॉर्टेंट है. इसमें बड़ा क्लैरिटी चाहिए. अक्सर या तो बहुत अर्ली इंसुलिन स्टार्ट हो जाती है या फिर इतना डिले होता है कि ऑलरेडी पेशेंट MI कॉम्प्लिकेशन स्ट्रोक भी हो चुका है, स्टिल पेशेंट यूजिंग दी ओरल एंटी डायबिटिक्स. तो आई सजेस्ट कि इंसुलिन की इनिशिएशन पे बड़ा फोकस होना चाहिए. एज ए अगर जनरल फिजिशियन है, फैमिली फिजिशियन है, दैट इज़ वेरी इंपॉर्टेंट. तो इसमें एक्सलेंटली प्रेजेंट किया है बिलाल साहब ने इनिशिएशन ऑफ द इंसुलिन. और प्लस इसकी इंटेंसिफिकेशन भी बड़ी इंपॉर्टेंट है. एक दफ़ा स्टार्ट करें तो फिर यू अचीव द टारगेट. बहुत सारे पेशेंट ऐसे हैं जो स्टार्ट कर लेते हैं बट दे डोंट फॉलो द थिंग्स. तो थोड़ा सा इसमें आपकी काउंसलिंग और आपका पेशेंट के साथ लेजोन जो है आतिफ साहब ने बड़ा अच्छा किया है कि आपका जो है पेशेंट के साथ सॉफ्ट स्पोकन, आपकी जो लेजोन है वो आपके सॉफ्ट स्पोकन से ज़्यादा बनेगा. अगर आप थोड़ा हार्ड होंगे, थोड़ा सा आपका लेजोन कम होगा, डेफिनेटली आपकी A1C बहुत सारी चीज़ें इम्पैक्ट करेंगी. विद दिस थैंक यू वेरी मच.
थैंक यू वेरी मच. डॉक्टर हनीफ नागरा साहब प्लीज़.
Lot of things discussed regarding drugs, management, side effects, and the trials. Sugar या diabetes एक disease नहीं है, एक syndrome है. It doesn't spare any organ from head to toe. तो सबसे पहले एक जुमला है कि we cannot prevent the diabetes. We can delay it or we can delay the complication. तो जब हमारे पास पेशेंट आता है तो हमने शुगर ट्रीट नहीं करनी, हमने पेशेंट को ट्रीट करना है कि ये देखना है कि रिस्क फैक्टर क्या है, इसको कौन सी दवाई चाहिए, कौन सी नहीं चाहिए. आपकी फर्स्ट लुक, एक अच्छे डॉक्टर की लुक है, वो पता चल रहा है कि आपका नाम क्या है, एज कितनी है, वालिदैन में से किसी को शुगर है कि नहीं है. तो हमें एक तो डिसीजन हो जाता है कि यार इसमें टाइप 2 है, कि वालिदैन में इसका नहीं है तो टाइप 1 है तो ये फैमिली में चल रही है, ओबीज है, उम्र कितनी है. तो वी शुड हैव कि जी अब हमने जैसे यैया साहब ने कहा कि लाइफस्टाइल से शुरू करके ड्रग्स तक जाना है. अभी पिछले दिनों में कुछ संपोजिया कॉन्फ्रेंस है, उधर एक डिस्कशन पे पूरा सेशन था कि क्विटिंग ऑफ ड्रग्स के दवाई से कैसे बचा जा सकता है, शुगर की दवाई से. वो लोगों ने अपने पेपर प्रेजेंट किए कि मेरे इतने पेशेंट हैं जिन्होंने इतने सालों से दवाई छोड़ दी, ये कंट्रोल हो गया, ये कंट्रोल लिया, विद लाइफस्टाइल मॉडिफिकेशन, विद रिडक्शन ऑफ वेट और विद डाइटरी थिंग्स. वी शुड कीप ऑल दिस थिंग इन माइंड कि यार ये मेरा पेशेंट कैसा है, इसकी लुक कैसी है, इसकी फैमिली हिस्ट्री कैसी है, इसमें रिस्क फैक्टर क्यों, क्योंकि डायबिटीज सिंगल डिजीज नहीं है. आपको 30 ईयर्स में ब्लड प्रेशर मिल रहा है, आपको यंग एज में हाइपरलिपिडीमिया मिल रहा है, आपको दूसरी चीज़ें मिल रही हैं. तो वी शुड कीप इन माइंड फर्स्ट लुक आउट पेशेंट जब हमारे क्लिनिक पे आता है, जब वार्ड में आता है कि हाउ ही इज़ लुकिंग, उसी हिसाब से हमें देखना चाहिए. ड्रग्स तो मैं आते ही लिख दूंगा, आप भी लिख देंगे, सर भी लिख देंगे. तो वी शुड कीप द पेशेंट नॉट द डायबिटीज.
थैंक यू सर. प्रोफेसर डॉक्टर अकमल शरीफ सर.
बिस्मिल्लाहिर्रहमानिर्रहीम. टाइम बहुत ज़्यादा हो गया
जी सर.
और छोटी सी 2 बातें विद दी कॉन्ग्रेचुलेशंस टू दी ऑर्गेनाइजर्स.
सर थैंक यू सर.
कि पहली बात तो ये कि एक हाइपोग्लाइसीमिया का जिक्र किया गया, शोल्डर इफेक्ट, विच इज़ वेरी राइट. अब इससे बचने का तरीका क्या है? वो 2 हैं. या तो आप ह्यूमन लाइक इंसुलिन शुरू कर दें जो कि अल्ट्रा शॉर्ट एक्टिंग है, नंबर 1, कि जिसका इफ़ेक्ट उतनी देर में ख़त्म हो जाए जितनी देर में मील का इफ़ेक्ट ख़त्म होता है. जो बंदा ये अफोर्ड नहीं कर सकता उसका क्या करना है? उसके लिए एक छोटी सी एडवाइस है कि इन बिटवीन दी मील्स जो है एक स्मॉल स्नैक ले ले, वो पोस्ट प्रेंडियल हाइपोग्लाइसीमिया से बच जाएगा. दूसरा कमेंट ये है कि GLP-1 एनालॉग्स आर दी ओनली ड्रग जिन्होंने बीटा सेल मास का इंक्रीज किया बिकॉज ऑफ द रीमेच्योरेशन ऑफ द डीमेच्योर बीटा सेल्स. और इसने रियली डायबिटीज़ रिवर्स करता है इन पेशेंट्स जिनको आप नाइव पेशेंट को वेट रिड्यूस करने के लिए और बाकी मैनेज करने के लिए लाइफस्टाइल मैनेज करके GLP-1 एनालॉग पे डालते हैं. सो मेरे लिए इट इज़ द मोस्ट इम्पॉर्टेंट ग्रुप अमंग ऑल द डायबिटिक्स with the SGLT2 inhibitors. It is very, very effective, particularly in patients who are naive and obese. Thank you.
प्रोफेसर डॉक्टर अब्दुल हफीज़ चौधरी साहब प्लीज़.
शहजाद, पहले अस्सलाम वालेकुम. मेरी तरफ से तो आपको बहुत मुबारक हो फॉर ऑर्गेनाइजिंग सच ए वंडरफुल सिम्पोजियम. और सुबह से लेके अभी तक इतने सब्र के साथ आपके ऑडियंस बैठी हुई है, उनको भी मुबारक हो.
सर वाकई
इनके लिए क्लैपिंग.
और आई थिंक उसकी वजह ये है कि इतना हाई स्टैंडर्ड है जो प्रेजेंटेशन का. आई हैव लर्नड ए लॉट फ्रॉम दिस.
थैंक यू सर.
जो टेक होम मैसेज मेरी तरफ से है कि व्हेन ए टाइप 2 डायबिटिक पेशेंट विजिट्स यू, इट्स आवर ड्यूटी टू टेक ए गुड हिस्ट्री एंड एग्जामिन हिम प्रॉपरली. पर्टिकुलरली एज ए कार्डियोलॉजिस्ट जो मेरे पास पेशेंट आते हैं डिस्पेप्सिया के और वो मेप्राजोल ले रहे होते हैं, एंड मैनी ऑफ देम जो है दे हैव कॉर्निक आर्टरी डिजीज़. सो चलने से अगर ब्रेथलेसनेस हो या डिस्पेप्सिया हो तो यू मस्ट रूल आउट कॉर्निक आर्टरी डिजीज़, मस्ट आस्कल्टेट दी कैरोटिड्स एंड टेक ए हिस्ट्री ऑफ TIA एंड स्ट्रोक. अगर हिस्ट्री ऑफ MI है या स्टेंट्स हैं वो ज़रूर पूछें. कैबेज की हिस्ट्री लें. हार्ट फेलियर, कार्डिक एनलार्जमेंट जो है ना, वो सिर्फ हार्ट फेलियर नहीं है. 50% of the patient with heart failure, they have normal heart size, and that is a heart failure with preserved ejection fraction. तो उनकी एको आप ज़रूर करवाएं for heart failure preserved ejection fraction. और इसी तरह से एक डॉक्टर ने बड़ा अच्छा एम्फोसाइज़ किया कि आपने एज ए होल उसके रिस्क फैक्टर्स देखने हैं, पर्टिकुलरली लो HDL एंड हाई ट्राइग्लिसराइड्स. ये बड़े चैलेंजिंग हैं ये मेटाबॉलिक सिंड्रोम और डायबिटीज़ के अंदर. एंड सिमिलरली CKD. और ये जो हाई रिस्क पेशेंट, आई थिंक यू मस्ट चूज़ SGLT2 इनहिबिटर्स एज ए पार्ट ऑफ योर प्रिस्क्रिप्शंस, क्योंकि GLP एनालॉग जो है वो काफ़ी पेशेंट अफोर्ड नहीं कर सकते. वी आर लकी वी हैव SGLT2 इनहिबिटर्स. और इसका इफ़ेक्ट स्टडीज़ के अंदर जो स्टडीज़ है इम्पेक्ट ऑन कार्डियोवास्कुलर इवेंट्स और रीनल और पेरिफेरल वास्कुलर डिजीज़ उतना है, उससे ज़्यादा भी है. So it should be a part with few exceptions. Cut off point एक स्टडी में 15 था EGFR for kidney disease, लेकिन हम 20 तक भी सेफली यूज़ कर सकते हैं. एंड शुरू में थोड़ा सा EGFR कम होगा, आप वरी ना करें, फिर ये वापस आ जाएगा. एंड सिमिलरली जब एक्यूट मायोकार्डियल इन्फार्क्शन हो तो आपने SGLT2 यूज़ नहीं करना, एक्यूट स्ट्रेस में यूज़ नहीं करना, फास्टिंग में यूज़ नहीं करना, और जब एंड स्टेज किडनी डिजीज़ हो जाए तो फिर SGLT2 इनहिबिटर्स एंटी डायबिटिक एफिकेसी ख़त्म हो जाती है उनकी। तो ये कुछ इम्पॉर्टेंट पॉइंट्स है। एक और इम्पॉर्टेंट है कि ये जो पीक्स आती हैं पोस्ट प्रेंडियल खाने के बाद जो शुगर बढ़ती है, इट्स ए रिस्क फैक्टर फॉर कॉर्नरी इवेंट, तो ये नहीं होनी चाहिए। इसकी वजह से अनस्टेबल एंजाइना, एक्यूट कॉर्नरी सिंड्रोम या MI होने के चांसेस काफ़ी ज़्यादा हैं। थैंक यू वेरी मच।
थैंक यू वेरी मच सर। एक बहुत जल्दी से एक कुरानंदाजी हमें और करनी पड़ गई है, हेल्थ केयर की तरफ से है, क्योर हेल्थ केयर से। इनके कोई गिफ्ट हैम्पर्स हैं तो वो मैं डॉक्टर नरेश कुनहार से रिक्वेस्ट करूंगा, डॉक्टर ताहिर शहजाद से रावलपिंडी से और डॉक्टर इकबाल से कि प्लीज़ स्टेज पे आएँ और कुरानंदाजी कर दें। सर आप लोगों का बहुत शुक्रिया। इसके बाद वेरी क्विकली मैं डॉक्टर इरफान से रिक्वेस्ट करूँगा कि वो आखिरी सेशन मॉडरेट करें और उसके बाद फिर लंच है सर। ये ले, और जो स्मार्ट वॉच वजी है कुरानंदाजी वो डॉक्टर इरफान करेंगे सर बाद में। आ जाए सर, ये 3 निकाल दीजिएगा सर, आ जाए सर।
सबसे पहले तो मैं डॉक्टर अहमद शहजाद को इतने बेहतरीन ऑर्गेनाइज्ड प्रोग्राम पे मुबारकबाद देना चाहूँगा मेरी रावलपिंडी की टीम के साथ। तो इंशाल्लाह ताला हम मकसद है कि हमेशा से इसी तरह से इकट्ठे रहेंगे।
एक नाम आप दे दीजिएगा सर। ये 3 मेरे पास निकल आई हैं सर। सर ये पहला गिफ्ट हैम्पर है डॉक्टर असगर अली फ्रॉम पीर महल सर। सर ये मेरे बड़े भाई हैं डॉक्टर असगर अली सर। ये एक गिफ्ट हैम्पर ले आइए सर। डॉक्टर असगर हैं सर, चले गए? चलें उनका गिफ्ट फिर उनको दे दीजिएगा सर। डॉक्टर अब्दुल नासिर साहब, अब्दुल नासिर साहब दोबारा कर लेते हैं सर, ठीक है। डॉक्टर अहमद रज़ा, अहमद रज़ा फैसलाबाद से। चलें सर ऐसा करें कि 2 और निकाल दें सर। एक और ये डॉक्टर अहमद रज़ा आ जाए प्लीज़। डॉक्टर नरेश साहब सर आ जाए सर। डॉक्टर गुलाम मुस्तफ़ा संदेलियाँ वाली पीर महल से। मुस्तफ़ा साहब बैठे हैं, आ जाए आ जाए आ जाए। हम लोगों का बड़ा पुराना ताल्लुक़ है सर। डॉक्टर शाहिद महमूद फैसलाबाद से सर। शाहिद महमूद नंबर है 033365077754। आ जाए ले सर। हमारी एक कुरानंदाजी रह गई है, वो इंशाल्लाह जो ही ये सेशन ख़त्म होता है उससे पहले हो जाएगी। उसमें 5 स्मार्ट वॉचेज़ हैं सर। अब मैं डॉक्टर इरफान से रिक्वेस्ट करता हूँ कि वो आ जाएं स्टेज पे और जितना जल्दी हो सके वो लंच की तरफ हमें ले जाएं।
Thank you so much, sir. Thank you so much. Thank you so much, sir. I really appreciate Dr. Ahmed Shahzad, Dr. Irfan, Dr. Naeem, Dr. Ijaz Anwar for such a wonderful event. It is no doubt a perfect conference, and in the Faisalabad history, it is one of the best conference ever I see. Congratulations. So, this is the last session. First of all, I request the panel of experts. I request Dr. Ehsan Saab, sir, please take the seat. Dr. Ehsan Saab, Dr. Ikram Saab, sir, please take the seat. Dr. Ijaz Anwar Saab, Dr. Ikram Saab, sir, please, as panel of expert. Dr. Kaisar Mahmood, renowned diabetologist from Gujranwala, and Dr. Ijaz Anwar, sir, please take the seat. Dr. Ijaz Anwar. So, without any delay, because it is the last session and you have to go for the lunch, तो नहीं अब कहूँगा dinner भी आ जाना है. तो I request the first presenter, who is very renowned, who has various presentations nationally and internationally. He remained the Professor of Medicine, King Edward Medical College. He also remained Professor of Medicine, Allama Iqbal Medical College. I request Professor Dr. Tariq Wasim from Lahore for his presentation on cardiovascular outcome trials.
So, pleasantry is already done. I will be just trying to save the time. My job is a bit easy and a bit difficult as well, because what already has been said, I will be repeating it and probably emphasizing it. The आवाज़ आ रही है? चलो ठीक है, वो दे दो मुझे. Right. So उधर स्लाइड नहीं आ रही आपकी. Pointer. Thank you, Ahmed, for inviting. Thank you, Amir, for the kind invitations. Right, disclosure is there. दिखा दो यार. Right. Type 2 diabetes. Type 2 diabetes. सुबह से हम सुन रहे हैं. How we define it? What it is? Right, it's a metabolic disorder with there is hyperglycemia, there is insulin resistance, there is an inefficient insulin secretion, possibly an incretin effect, and then disproportionate glucagon secretion. So there are so many things interwoven into one thing, and in most of the cases, this is almost always accompanied with hyperlipidemia as well. So when you are managing diabetes, we are talking of 360 approach, we are talking of a holistic approach. This is the holistic approach we want to get onto. Talking of the cardiovascular disease, because my topic has been assigned the cardiovascular outcome trials and this role. So it can manifest as so many things. I will just add on to, शायद ज़्यादा stimulate हो जाए लोग, erectile dysfunction भी cardiovascular manifestation of disease है. And angina or all those, they have all been, सुबह से हम बात कर रहे हैं इसके ऊपर. What links diabetes and atherosclerotic cardiovascular disease? There must be something in common, something which is there, which links them that do have it. The common pathophysiological pathway, it includes insulin resistance. Even in non-diabetic patients, to begin, we are talking of insulin resistance now. Inflammation adds to it, hypertension, oxidative and hypercoagulability. So एक और फैक्टर एक और ऐड हो गया, वो जो सारा holistic approach है, जहाँ पे हम फिर आपको भी एस्प्रिन की और उसकी बात भी करेंगे, right? And there remains the leading cause of death. Some people have even coined the term cardio-diabetes. किसको diabetes कहना ही छोड़ दो, तो है ही cardio-diabetes, है ही जो cardiologist अभी हफीसा भी यहीं थे मेरा ख्याल है, तो they would be agree on that. Because the cardiovascular disease is almost 2 to 3 times higher in diabetics. It remains the leading cause of mortality, and someone told that younger it starts, more it is likely to be lethal from a cardiovascular standpoint. And of course, major cause of increased risk of early deaths. अभी किसी ने स्लाइड शो की थी कि 10 साल जिंदगी के आपके कम कर देती है आप डायबिटीज, अगर आपको डायबिटीज हो जाए तो. So if these are the things, the other complications of course, 50% of the diabetics, they die of cardiovascular causes. They don't die of hypoglycemia, they don't die of hyperglycemia, they don't die of it. The main cause of death is cardiovascular. And in those who survive, 30% would have atherosclerotic cardiovascular disease manifested as all those three things we mentioned about. 15% have concurrent heart failure. And Hafisa very rightly pointed out, you need not to have a heart attack to have a heart failure later on. The diabetic cardiomyopathy and diabetic heart failure with preserved ejection fraction, that's there, almost 15% of patients. 8% would have a stroke. And if you raise the bar, age bar a bit higher, 70% would die of heart disease, 70% of the diabetic would die of heart disease, and 16% would die of stroke. And then, Jaya ne bahut mention kiya albuminuric and non-albuminuric kidney disease. Once your patient has heart diabetes and then he has a heart disease, he is almost destined to have a renal disease. And this is what has been called as a cardio-renal syndrome. Right? And of course, renal impairment, which is correlated with hemodynamic dysfunction. This is not albuminuria. This is atherosclerotic disease involving the larger vessels, leading on to renovascular hypertension, and then, of course, going on to the rest of the things. So this is again something. So the question is, does achieving high glycemic control improves cardiovascular outcomes? ये जो हमने सारी बातें बताई हैं जो डायबिटीज से रिलेटेड हैं, तो अगर हम अच्छा A1C अचीव कर लें, अच्छा ब्लड शुगर अचीव कर लें, तो क्या ये सब कुछ कम हो जाता है कि नहीं हो जाता? What's the opinion of the house? Yes, no? The answer is yes. But where is the evidence? The evidence is the landmark study UKPDS. It started probably those studies like Birmingham study from the North America, and this UKPDS probably are the landmark studies. They have changed so much of our insight into disease. What does this tell us? अभी रोस्ट्रम से किसने mention किया था? It was the first study which addressed कि जी अगर हम tightly glycemic control achieve करें तो cardiovascular mortality कम हो जाती है. साथ थोड़ी सी एक छोटी सी लाइन है, newly diagnosed and with diabetes mellitus, right? And we proved that 1% reduction in HbA1c would lead on to 37% reduction in cardiovascular outcomes and all that. But there was not statistically any significant macrovascular disease में कोई significant difference नहीं था. It was all more of a microvascular and all that. And again, this was when it stamped on metformin. The metformin reduced all-cause mortality with 36%, heart attack with 39%, among एक और आगे condition है, overweight and newly diagnosed, right? So जो किसी ने कहा था कि जो पहली दवाई शुरू करनी है वो metformin है, क्यों है? जल्दी शुरू करो, it would work better. And of course, in obese, definitely it's better. So the metformin probably would retain its place in cardiovascular till a long time to come. फिर आया जी कि अच्छा 1% कम करने से इतना बेहतर होता है तो क्या ना और क्यों ना कम कर दिया जाए, इसको हम 7% से 6% और नीचे लेके जाए. तो फिर आगे जी वो बहुत ट्रायल शुरू हो गए कि जी लोअरिंग फर्दर एबीसी टाइट ग्लाइसिन क्या फर्दर आउटकम इंप्रूव करेगा, वो जो 37% कुछ और बेहतर हो जाएगा. सो वहां से बात शुरू जी इंटेंसिव वर्सेस स्टैंडर्ड कंट्रोल के जी बस 7% तक लाना है. वो जो यूकेपीडीएस में तो 1% कम किया था और 8 पॉइंट कुछ तक लेके आए थे, कुछ में 7.5% अचीव हुआ था. तो इसको टाइट ग्लाइसेमिक कंट्रोल के फिर वो धड़ाधड़ ट्रायल आने शुरू हो गए. बट पता ये चला कि देयर वाज नो सिग्निफिकेंट डिफरेंस बिटवीन इंटेंसिवली ट्रीटेड और स्टैंडर्ड ट्रीटमेंट ग्रुप इन पेशेंट मेजर एडवर्स कार्डियोवैस्कुलर इवेंट्स. और ये तीन बड़े बम्बास्टिक किस्म के स्टाइल थे जी. एडवांस था, अकॉर्ड था. इनफैक्ट अकॉर्ड हैड इंक्रीज मोर्टेलिटी और इसको ट्रायल को विड्रॉ अर्ली बंद कर दिया गया था. हमने ग्लाइसेमिक कंट्रोल तो अचीव कर लिया. अभी मैं यहाँ से फिर बात हुई थी हाइपोग्लाइसीमिया बहुत ज़्यादा होने लग गया. अब बहुत अच्छा टाइट ग्लाइसेमिक कंट्रोल, लेकिन अगर उसको हाइपोग्लाइसीमिया हो रहा है तो एक सिंगल एपिसोड ऑफ हाइपोग्लाइसीमिया कैन बी डेट्रीमेंटल एज वेल. और कितना फर्क था? 8.5% in tight control and 3.1% who had a standard control. So कोई फायदा कुछ ना हुआ, right? So the only thing was कि जिनकी 12 साल से कम अरसा है डायबिटीज को शुरू हुए हुए, उनमें कुछ फेवरेबल डिजायर हो सकते हैं. अगेन द रीजन एम्फेसिस के जी जल्दी शुरू कीजिएगा. देन जब होना शुरू हो गया तो हमने शुरू कर दी कि खूब से खूब तर की तलाश, कोई ऐसी दवाइयाँ लेते हैं जो सब कुछ A1C भी काम करे, ये भी काम करे. और उसमें वो कहते हैं ना एक आप बम को लात मार लेते हैं, वो बम था रोज़िग्लूटाजोन, राइट? Rosiglitazone, initially जब आई तो we have very say enthusiastic and very excited कि जी बड़ा कुछ है, but 2007 में उन्होंने रोजीग्लूटाजोन के मेटा एनालिसिस किया तो उन्हें पता लगा जी कि जो जिन लोगों को रोजीग्लूटाजोन यूज़ की गई है उनके हार्ट फेलियर और डेथ और बहुत बढ़ गई हैं। यहाँ पे आके फिर दिस वाज ट्रिगर्ड अ नीड टू कि जी जो भी दवाई हमने डायबिटीज़ वाले को देनी है उसका पहले ट्रायल तो करो कि वो कार्डियोवैस्कुलर सेफ भी है कि नहीं या कार्डियोवैस्कुलर बेनिफिट्स हैं भी कि नहीं है। एंड दिस लेड ऑन टू एफडीए ने 2008 में एक रूलिंग बना दी कि जी जो भी नई दवाई आनी है पहले ये ट्रायल करोगे, हमें साबित करो कि ये कार्डियोवैस्कुलर पॉइंट ऑफ व्यू से सेफ है और इसके नुकसानात नहीं है, और उसकी वजह से जो एक इनकलाब आया है। दिस इज व्हाट माय टॉक इज, कार्डियोवैस्कुलर आउटकम ट्रायल्स एंड फोकसिंग ऑन A1C अलोन, जिसमें हमने कहा था कि A1C पे फोकस ज़्यादा करते हो तो हाइपोग्लाइसीमिया ज़्यादा कर देते हो और कुछ चीज़ों में मॉर्टेलिटी ज़्यादा करते हो, राइट। सो दिस वाज द एरा विच स्टार्टेड फ्रॉम 2008 ऑनवर्ड, आउटकम ट्रायल्स। और आउटकम ट्रायल में हमने क्या कहा जी, द प्राइमरी हमने 3 पॉइंट देखने हैं कि दी कार्डियोवैस्कुलर मॉर्टेलिटी ओवरऑल कितनी कम होती है, हमने ये देखना है कि नॉन फेटल एमआई कितना कम होता है, हमने ये देखना है कि नॉन फेटल स्ट्रोक कितना कम होता है। तो दे वर 3 प्राइमरी ऑब्जेक्टिव्स, बट दे एडेड फ्यू मी थिंग। उन्होंने कहा जी 3 और चीज़ें देख ले, ऑल कॉज मॉर्टेलिटी, कैंसर रिलेटेड और रिलेटेड जितनी बाकी लिवर रिलेटेड मॉर्टेलिटी, ऑल कॉज मॉर्टेलिटी। उन्हें ऐड कर दे दी हॉस्पिटलाइजेशन ड्यू टू हार्ट फेलियर, कि जो हम दवाइयाँ दे रहे हैं उनके साथ उनके देने से हार्ट फेलियर की वजह से एडमिशंस कितने कम होते हैं। एंड देन दे एडेड द रीनल आउटकम एज वेल। So there are 3 primary objectives and then 3 secondary objectives which collectively are called cardiovascular as well cardio-renal outcome of the medications. 2022 तक कोई 17 different trials हो चुके हैं और ये चारों जो उसके बाद इस एरा में जो ड्रग्स आई हैं ग्लिटाजोन के समेत इनके ऊपर ट्रायल हुए हैं, ग्लिटाजोन इंक्लूड नहीं सॉरी DPP-4 इनहिबिटर्स पे, GLP पे, SGLT2 पे और इंसुलिन जो लॉन्गर एक्टिंग ग्लार्जिन और इसके ऊपर। I will just dissect very briefly DPP trial. The DPP related trial inhibitor have been reported to be neutral with regard to cardiovascular. कोई फर्क नहीं पड़ता, ग्लाइसेमिक कंट्रोल बेशक आपने अचीव कर लिया पर कार्डियोवैस्कुलर आउटकम पे कोई फर्क नहीं पड़ता, राइट। However, बल्कि इनफैक्ट वो जो सेक्साग्लिप्टिन एक वन ऑफ दी जो हमारे यहाँ आई नहीं है, इट इंक्रीज हॉस्पिटलाइजेशन फॉर हार्ट फेलियर। सो दिस इज योर DPP-4 inhibitors. Then came the most trumpeted and probably the most the famous one, SGLT2 inhibitors cardiovascular peptides. बहुत सारे आ चुके हैं. We start from canvas with the canagliflozin, AMPA, फिर AMPA heart आया, AMPA Ribzert आया, Declare, Scode, you name it, there are so many. So they were all with various, some of them are with dapagliflozin, some are with Ertuva, some were with Cana, and Cana was the canvas only, and then AMPA. And what is the outcome? Apart from having a good glycemic control, they also have a cardioprotective effect which is achieved through some blockade of SGLT2 receptor in the heart as well. हम gut के और kidney के SGLT2 receptor की बात करते हो, their effect beyond their glycemic control has been attributed to that. That has been further researched. So a meta-analysis of 3 studies showed that SGLT inhibitors reduced major adverse events by 11% in patient with type 2 diabetes mellitus and cardiovascular. तो इनिशियल ट्रायल थे कि जिन लोगों को पहले से हार्ट डिजीज है या उनको कोई अटैक हो चुका है या कॉर्निया डिजीज है, तो उनके अंदर जो इनिशियल ट्रायल आए तो उसके अंदर ये मॉर्टेलिटी को इन्होंने तकरीबन 11% कम कर दिया. रिड्यूस रिस्क स्ट्रोक और भी ज़्यादा 23% रिड्यूस रिस्क ऑफ स्ट्रोक एंड रिस्क ऑफ रीनल डिजीज प्रोग्रेशन भी 45%, ये और भी ज़्यादा है. So they reduce 3 major things. They reduce the cardiovascular events, major cardiovascular events. They reduce hospitalization due to heart failure, and of course the renal disease progression. And they also reduce the risk of cardiac arrhythmias, atrial fibrillation, flutter. So this is again something which is beyond their just hypoglycemic effects. This was the latest one to added, the AMPA kidney. In those with plus the final word is the absolute risk of kidney disease progression of dying from heart cardiovascular disease in AMPA kidney was reduced by 3%, 3.8%. when those who are using empagliflozin as compared to the placebo. And then is the GLP-1. GLP-1, again, 5 cardiovascular trials, namely LEADER, SUSTAIN, REWIND, HARMONY, and your name, there are so many, have consistently shown safety as well as efficacy of GLP-1 agonist in patients with type 2 diabetes, and provide an evidence of a secondary prevention effect of GLP-2 agonist in type 2 diabetes, CKD, CVD, and kidney disease. Their meta-analysis reduced MACE by 14%. They reduced all-cause mortality by 12%. They reduced hospital admission because heart failure by 11%. Even much better than even SGLT2 inhibitor. The only thing is the cost. For our part of the world, the cost remains the main limiting factor. And the composite kidney outcome, need to dialysis or need to progression to end-stage failure, reduced by 21%. And with no increase in hypoglycemia, because बाकियों के साथ हमें साथ फिक्र दीजिए hypoglycemia करते हैं. No increase in retinopathy, no increase in pancreatitis or pancreatic carcinomas. So this is GLP-1, and then enters another one, that not only GLP but GIP agonists combined together. Tirzepatide, आजकल particularly obese patient में weight reduction के लिए it leads on to almost 7 to 9.5 kg of weight loss in dosage ranging from this, and this has been compared with insulin, this has been compared with other semaglutide versus tirzepatide. Right. So the impact of anti-diabetic medicine lead to improved cardiovascular outcome. Some have very detrimental impact, particularly on heart failure. We did talk about pioglitazone. So this is a nutshell summary of what we achieve when you get this. Insulins, very good for a glycemic control, A1C, but the outward come trials, neutral. Sulfonylureas, they remain neutral. Metformin, MACE, yes, but rest of things, no. Pioglitazone, good, but increase the risk of heart failure. Rosiglitazone, जहाँ से खानी शुरू हुई थी, has been already withdrawn or box के साथ है. DPP-4 inhibitor, again neutral for all the cardiovascular. GLP-1, they do have a positive effect on cardiovascular outcome. SGLT2 inhibitors, स्ट्रोक के ऊपर इनके ऊपर थोड़ी सी डाउटफुल है, कोई डाटा अभी क्लियरली नहीं है कि स्ट्रोक का इंसिडेंस कम करते हैं, लेकिन रेस्ट ऑफ द कार्डियोवास्कुलर आउटकम दे डू इम्प्रूव इट. सो कमिंग बैक, वी नीड टू हैव ए पर्सनलाइज्ड अप्रोच, एंड पर्सनलाइज्ड अप्रोच इज कि वो जो हमने कहा कि एक फैक्टर नहीं है, सिर्फ A1C सिर्फ नहीं है, ब्लड शुगर सिर्फ नहीं है, देयर आर सो मेनी थिंग्स इंटरवोवन एंड वी हैव टू वर्क ऑन देम एज वेल. नो योर पेशेंट, patient risk of developing this cardiovascular disease. You can estimate it by a simple calculation that is available on the app. You can calculate and you can know that if your patient is less than 10% of having heart disease in next 10 years, it is 10%, or if it is more than 20, so you can all download that app. You can just, it takes less than 2 minutes to complete it, and you can go know your patient risk. And then there is this ominous quadrant. 80%, 85% diabetic would have obesity, 70% would have hypertension, 60% would have dyslipidemia as well. When you say as well, इसका मतलब है कि उनको भी साथ देखना है, या जो दवाइयाँ हमने देनी है वो उस as well को भी साथ address कर रही हूँ. So who is the elephant in the room? It's obesity. सुबह शाहिद साहब ने बात शुरू की थी कि obesity is the main thing and everything else is around it. And if you are not, आप बाकी सारा कुछ तो देख रहे हो, अब आपको पता नहीं कि वो एलिफेंट जो बैठा हुआ है उसको निकालना है बाहर. So 5% reduction benefits, and you have to get on to by weight management through diet and exercise and everything. You do everything to get your weight reduction at least by 5%, and 5% reduction में वो भी benefit already show कर गए थे. अगेन कंबाइंड ADASD गाइडलाइन जो है वो आपके पेशेंट को पहले से डिफाइन करती हैं कि उसको ऑलरेडी हार्ट डिजीज़ के मैनिफेस्टेशन हैं कि नहीं हैं. तो फर्स्ट चॉइस GLP-1 है और साथ या SGLT2 है। अगर उसको किडनी की डिजीज़ पहले से एल्ब्यूमिन यूरिया, खालिद जैन ने बड़ी तफसील से बताया, तो एल्ब्यूमिन यूरिया है या रीनल डिजीज ऑलरेडी है, तो द फर्स्ट प्रेफरेंस आफ्टर द लाइफस्टाइल एंड मेटफॉर्मिन वुड बी एन SGLT2 inhibitors, right? So holistic diabetes care should be A1C, of course, is there, but you have to change it from there. So blood pressure control, cholesterol, diet, exercise, reduce and maintain weight. This is again, if you just focus on A1C alone, 0.9% reduction of A1C, the effect on stroke is this much, but look at this, the BP reduction has the maximum benefit. LDL reduction has the more benefit. So you have to focus your approach on A1C reduction to the other things as well. The same is with the coronary events, just A1C, the reduction is this much, but if you focus on the LDL reduction by 40 milligram or a blood pressure reduction by 10 by 5 millimeter, so this is the impact on overall. So this is again shifting focus from A1C alone to, so this was our initial approach to the glucosensitive control hyperglycemia. Focus on the word control hyperglycemia. Reduce excess body weight. We used to say reduce excess body weight. Reduce microvascular disease, retinopathy, nephropathy, neuropathy. Reduce macrovascular disease, reduce. Right? The new approach is prevent diabetes progression. Just a minute. Weight management. Instead of control, you have to manage your weight according to the guidelines. Okay? Reduce mortality, cardiovascular and non-cardiovascular. Prevent CKD progression. You have to prevent heart failure. You have to improve. This is an addition to that कि ये सारी obesity और metabolic syndrome और उस सारे के अंदर एक component जिसके ऊपर अभी हम फोकस सुबह किसी ने हाईलाइट किया था कि लिवर जो है उसको भी साथ देखो, ठीक है, वो दर्द दिल के पीछे ना रहो, जिगर को भी पीटो ज़रा, ठीक है, तो improve this metabolically say adverse or the steatotic liver disease जो NAFLD को जो नया नाम कर दिया. Obstructive sleep apnea. कभी स्टडी किया, there is study के 42% of diabetic patients are likely to have obstructive sleep apnea as well, and improving that would improve their glycemic control as well. So this is again an area to be focused. And in सुबह हमने mention किया था arthritis, because arthritis shares a lot of other inflammatory factors with the diabetes. And by the time जब 45-50 साल की बात के आप जब पेशेंट जिनको देखते हैं उनमें ओबेसिटी की वजह से किसी और वजह से साथ आर्थराइटिस है, इन्फ्लेमेटरी कैस्केड एक्टिवेट हुआ है, कार्डियोवैस्कुलर इवेंट बढ़ जाते हैं. सो द कंक्लूजन इज ट्रांजिशन फ्रॉम ग्लूकोसेंट्रिक टू मेटाबॉलिक केयर एंड कार्डियो रीनल मेटाबॉलिक. वो जो ट्रायोपैथी थी टाइप 1 की ट्रायोपैथी रेटिनोपैथी और नेफ्रोपैथी एंड न्यूरोपैथी थी. टाइप 2 की ट्रायोपैथी ये है, obesity and cardiac events and renal. So do we have to prevent that? Obesity and renal should be emphasized at each stage. Every type 2 diabetic person should be assessed for ASCVD risk, established CVD, heart failure and renal status in the beginning and at every next session with him. The selection of glucose-lowering agents should be depend on ASCVD status as well as other complication present like renal complication already present. Metformin should be considered treating patient diabetes. At less than 30, you probably have to review your decision कि continue रखना कि नहीं. SGL2, of course, had proven benefit. GLP-1, again, they have shown the data is there to support that. This slide has already been shared. And this is my last slide. Ahmed Shahzad is here. He is our chapter head for, I represent Pakistan Society of Internal Medicine. लोगो आपको शायद नज़र आ रहा होगा कि we have collaborated with them for this session. So our conference is upcoming in, national conference is in 2nd to 6th of May in Islamabad, 3rd to 5th of May, sorry. And I invite you all to be registered this and join us, and it would be inshallah a good. Thank you very much for your patient listening.
Thank you so much for the mind-blow presentation. Our next speaker is very renowned and you really enjoy his talk. He declared as the best teacher by the UN. He is the Dean Postgraduate Medical Sciences, Faisalabad Medical University, and also Dean Medical and Allied Wards in the Allied Hospital, DHU, and Ghulam Ahmedabad Hospital. He is the Pro Vice Chancellor, Faisalabad Medical University, and I always say he is the Vice Chancellor of Heart, यानी कि दिलों के VC हैं. He is very popular personality. Professor Dr. Ahmed Shahzad for his kind presentation.
Bismillahirrahmanirrahim. Thank you, Dr. Irfan, for your very kind introduction and very nice words. Before I start with my presentation, this is the organization that I represent. I am the Pro Vice Chancellor and Dean of Postgraduate Studies at Faisalabad Medical University, as you all know. आज की इस कॉन्फ्रेंस की जो मुझे टॉपिक अलॉट किया गया उससे 2-3 पहले 2 बातों का मैंने यहाँ जिक्र करना था. I want all of you to give a big hand to Dr. Ijaz Anwar and Dr. Ahmed Shahzad. I think that of late, this is one of the best events that I've attended. Not in the terms of your presenters, but the audience has been wonderful. I have never seen such a wonderful audience, so patient and so learned and so attentive. So big hand to all of you. There's a history behind whatever I'm saying here. Dr. Shahzad and Dr. Ijaz Anwar, they came to me about 4 months ago, and they came up with this idea of collaborating this conference with Pakistan Society of Internal Medicine and Faisalabad Medical University. So Dr. Tariq Wasim Saab, Dr. Azizur Rahman Saab, unfortunately is not here, and our very honorable health minister, they showed a lot of interest. So a big hand also to Professor Dr. Javed Akram. So he was very, very busy and he came here. And the one purpose of his coming here was to attend this conference and get an idea of how eager the primary care physicians are. And I just had a meeting with him at tea and he is really very impressed, and that is why he's promised. उसको शायद हमारे VC साहब गोल कर गए क्योंकि वो सिर्फ VC है, मैं पोस्ट ग्रेजुएट्स को भी देखता हूँ. तो this is not an ordinary thing that the Vice Chancellor said over here. We are now announcing Diploma of Diabetes at the forum of Faisalabad Medical University. And this Diploma of Diabetes credit goes to Dr. Ahmed Shahzad solely. His purpose ke liye, it is all because of his. So Dr. Ahmed Shahzad has created the curriculum, the syllabus. You know, it's a very tedious procedure of getting a diploma recognized by Higher Education Commission. आपको ये जान के भी खुशी होगी कि that in 2018, since its inception, Faisalabad Medical University was offering no diplomas. बल्कि पंजाब की भी जितनी medical universities हैं, उनसे कोई diploma खास offer नहीं किए जा रहे. At this point in time, I take a pride in announcing that we are offering 14 diplomas from Faisalabad Medical University, which is a kind of a record. और उसके अंदर दो नए एडिशन है जिसका हमें सिंडिकेट से अप्रूवल मिली है. They are basically diabetes diploma and diploma in family medicine, which is sort of, they would go hand in hand, and I think it's a big service to the community, number one. इसके अलावा हम BS programs भी offer कर रहे हैं, and we are offering BS programs in 20 various specialities, which is again a sort of a credit to your city. And we have an indigenous program going on of MD and MS training, which is not it is being supervised by HEC and all the international organizations, but it is totally developed by Faisalabad Medical University for the betterment of our postgraduate students. So the topic given to me was to talk about the GLP-1 receptor agonist, particularly in reference to the once weekly preparation of semaglutide. As I've been very meticulously following what's been told and what's been delivered here in all of the presentations, we are narrowing ourselves down to this drug that I am very, very fond of. See, about 10 years ago, we used to say कि शुगर जो है वो कंट्रोल करने वाला मर्ज़ है. शुगर जो है ना वो बीमारी ख़त्म नहीं हो सकती. शुगर जो है ना उसकी मुसीबतें आनी ही आनी हैं. और आपने जब भी शुगर का इलाज शुरू करना है, ये जुर्म है if you don't start with metformin. Things have changed over the past 10 years. अब क्या है कि शुगर को आपने एक प्री डायबिटीज़ का एक लफ्ज़ ईजाद हो गया है. You now need to sort of diagnose diabetes at the pre-diabetes stage. If you have an intention to treat and you do it with a meticulous and a very planned sort of a manner and bring everything on board and have a sort of an understanding of what you want to do, then because of these two landmark drugs which have come up, the SGLT2 inhibitors and the GLP-1 receptor agonists, and GLP-1 receptor agonist is one edge above the SGLT2 inhibitors, you can potentially reverse the process of diabetes, which means a diabetic can be converted into a non-diabetic, to a pre-diabetic one, and a pre-diabetic can go into a stage of remission, which is a big change in the understanding of diabetes mellitus. ये slides करने का बाबर कोई फ़ायदा नहीं है. We know, it's been said before many times, type 2 diabetes has a number of risk factors: overweight, obesity, age, family history, ethnicity. And then we've talked about this ominous octet of type 2 diabetes mellitus, which includes decreased insulin secretion, increased glucagon secretion, then increased hepatic glucose production, the decreased incretin effect that I'll be talking about, increased lipolysis, increased glucose reabsorption, impaired appetite regulation, and decreased glucose uptake. This is the basic action behind the incretin sort of effect that goes along with type 2 diabetes mellitus. Now, incretin, you know, is a combination of these two formulas over here. We know that the incretin is released as soon as we, जैसे हम food चखते हैं, incretin जो है ना body में produce होते हैं. These incretins, they go up to the level of pancreas, and at the level of pancreas, they cause secretion of insulin. The incretin effect in type 2 diabetes, as you can see here, is diminished. This is a normal graphatical representation of what happens in a healthy individual. And if you compare it to the one who's got type 2 diabetes, you can see for yourself what happens when the patient has got a type 2 diabetes going on. The native GLP-1 has got a very, very short half-life of about approximately 2 to 2.5 minutes. इसका मतलब ये है कि जैसे बॉडी में आया है 2.5 मिनट में फारग हो गया है. इसका मतलब ये हुआ कि we needed to come up with the analog, so that is why the GLP-1 receptor analog landscape is over here. And by the coming up of this new reagent, what's happening is all of the processes that I showed you earlier in this ominous octet one are being reversed. As you can see here, that the beta cell mass increases, insulin biosynthesis is improved, then the alpha cell, it does not hamper. The liver के अंदर जो है, there is decreased hepatic glucose production, increased hepatic insulin sensitivity. It acts on the GI tract and has got a very, very beneficial effect. It decreases lipotoxicity and has got a kidney protective effect, as Professor Tariq Wasim Saab has very rightly pointed out, and etc. इसका मतलब ये हुआ कि इस चीज़ को develop करते हुए over the years, there are many incretin-based therapies that have come in the market. It began with the exenatide type salt, and now we are dealing with the semaglutide one, which is recently come up. But whenever now ADA says that when you do this sort of this thing has also come up over the past 5 years. It's been talked about in the previous many slides, because I'm very short of time and I would be jumping on my slides, is that जब भी आपने type 2 diabetes के बारे में एक बनानी है situation and you want to take it up early, now it is not a matter of metformin only. You categorize them, you find out their family history, their obesity, the chances of them having a cardiovascular disease, the chances of them having a kidney disease, the chances of them having major adverse cardiovascular events, और उसके मुताबिक आप कैटेगराइज करके चॉइस ऑफ ड्रग्स को चूज़ करें. और मुझे पता है वट एवर इज़ बिन टोल्ड हियर, अगर मैं आपसे सवाल पूछूंगा अब तो ये जवाब बहुत ही आसान हो जाएगा. इफ़ ही इज़ ओवरवेट and he's got a cardiovascular risk going on, then it's a combination of metformin with the GLP-1 receptor agonist. If he's got a cardiovascular risk going on and he's got a kidney risk going on, and you are not very, very concerned about the obesity part, then it's an SGLT2 inhibitor. But primarily speaking, if you want to reverse the disorder, you want to decrease it and you want to sort of bring the diabetes part into a stage of remission, then the penultimate combination would be a combination of metformin, SGLT2 inhibitor with the GLP-1 receptor agonist, which is a very, very effective combination with an intention to treat and intention to reverse the process. So despite availability of numerous treatment, diabetes still remains a challenge. You know, it's the 9th major cause of death globally. 26.9% of patients with type 2 diabetes have peripheral neuropathy. 11.9% of patients with type 2 diabetes have established cardiovascular disorders. 21.2% of patients with diabetes have kidney diseases. And that is why the most important problem is that the cardiovascular events in diabetes have to be tackled, including heart failure, cardiovascular death, myocardial infarction, and stroke. Now, The latest formula that I'll be talking about is the semaglutide one. You obviously know it's a once weekly preparation, a landmark drug, the best anti-diabetic available as far as our country is concerned, but obviously cost is a factor. Semaglutide is a human GLP-1 analog. This is why it's to be, there's a substitute going on, and they've developed this product to be long-acting, so that is, it stays in blood for a longer period of time, and it's given in a weekly dosage schedule. This is the pharmacokinetic profile, which speaks volumes of how this drug is so beneficial, because it's suitable as a once weekly dosing. And then the pharmacokinetic profiles of this approved GLP-1 receptor agonist, if you compare all of them, then the one drug that stands out as a once weekly preparation is the semaglutide one. The semaglutide additional benefit, you know that insulin, whenever it secretes in a type 2 diabetic or a normal individual, has got a first and a second phase secretion. It tackles with both of them. Semaglutide also increases the fasting C-peptide level and decreases the postprandial glucose and glucagon level, meaning thereby the chances of hypos, as far as you have with normal drugs, is much lessened when you are on a GLP-1 receptor agonist, particularly a long-acting one. Semaglutide does not compromise glucagon response during hypoglycemia, which is a beneficial effect. That is why it is to be advocated and can be given very safely, and that is why it is being given to normal obese individuals also. And thereby saying is, we know that we are, all of us are treating our obese patients with this GLP-1 receptor agonist because of this profound effect that it does not cause any hypoglycemia. It reduces fat mass, and primary mechanism of weight loss as is given over here, and you can see for yourself that there is an appreciable decrease in the body composition of fat when you give this salt. It reduces energy intake and expenditure. It improves control of eating and food cravings, and has got a anti-atherosclerotic effect more than any other anti-diabetic agent available in the market. It improves postprandial lipid control because of the effects, and as we've been discussing with you previously and summarizing, it increases insulin secretion and beta cell responsiveness. It suppresses hepatic glucose output in a glucose-dependent manner. It reduces energy intake, food consumption, and body weight. It lowers postprandial lipids, attenuates plaque lesion progression in atherosclerotic modules. The SUSTAIN 6 trial was only talked about very shortly, and only 3 or 4 slides. I am jumping very quickly because I know all of you are very, very impatient. I am also very impatient. So as you can see over here, this cardiovascular outcome trial, the SUSTAIN 6 one, was basically to evaluate type 2 diabetes mellitus, evaluating the safety of new drugs for improving glycemic control. The model was to see the effect of semaglutide 0.51 versus placebo over a particular period of time. As you can see here, I'll go to the results of this trial too. The primary outcome was that once weekly semaglutide reduces the risk of MACE by about 26% versus placebo. Individual and expanded composite outcomes, as you can see here on cardiovascular risks, non-fatal MIs, on non-fatal strokes, and expanded composite cardiovascular outcomes, you can see there is an appreciable difference. Changes in it affects the changes in systolic blood pressure also, and importantly, one part that we did not know of previously and was not studied was the effect and the beneficial effect of this drug on the kidney. So summarizing, the primary outcome of cardiovascular death, non-fatal MI, and non-fatal stroke decreased by 26%. Number of patients needed to treat to prevent one cardiovascular death, non-fatal MI, and non-fatal stroke decreased by 45%. Semaglutide significantly reduced the HbA1c and body weight, risk of new or worsening nephropathy, risk reduction by 36%, risk of diabetic retinopathy complication by 3%. And thank you very much for being such a wonderful audience.
There is only one presentation between the smartwatch. ये इधर से आपकी जेब में जानी है, ये सिर्फ लास्ट प्रेजेंटेशन है. और लास्ट प्रेजेंटर इज़ Dr. Suhail Anjum. He is a very renowned presenter. He represents Pakistan in the various international forum. He is diabetologist. Now I request Dr. Suhail Anjum.
Bismillahir Rahmanir Rahim. Let me to extend my gratitude to PCDA and especially Dr. Ahmed Shahzad, Dr. Ijaz Anwar, and PSIM under the kind patronage of Professor Ahmed Shahzad. Thank you very much for organizing such a wonderful symposia today. It is, I must say, it is the international standard symposia, and we learned a lot. Thank you very much for coming today. You have a wonderful audience, and I'm really feel honored and privileged that you stay awake and focused. I will not hinder too much between the lunch. Today's talk it's a kind of a workshop in which we will focus on evolution of different technologies. Nowadays, if you are not stay ahead of change, you are going to suffer a lot in your future clinical practices, because the medical scenario is ever changing, and modern gadgets are more commoner now than they were a few years before. And my aim today is to get familiar with the modern gadgets. You don't need to go to Europe, to Dubai, to USA to get a first-hand experience on all the modern gadgets that are available in the market today. I brought it with myself, and you might have some first-hand experience after the lecture if you want to have that. Evolution of diabetes management since 1776, urine testing, then urine strips, discovery of insulin, blood glucose monitoring devices in 1970s, insulin pump treatment in 1980s, and then glucose sensor devices, and then of course artificial pancreas nowadays. One of the main treatment in the international management of diabetes. It is 1921 when the both scientists Best and Benton they discovered insulin. But my question is, are the first one to do that? No. Claude Bernard was the one who discovered the glucose metabolism, and the Langerhans was the one who discovered the relationship between the diabetes and pancreas. He is the person who first discovered the insulin. He published insulin and his trials 1 year before Mr. Best and Benton, because he was from Romania, so he was much neglected. So these guys run a first human clinical trial and treated the well-known Leonard Thompson in 22, and he stayed there for many years. And unfortunately in 1935 Mr. Leonard Thompson died because of some complication of diabetes. The first portable glucometers, they were in 1970s. In our country they were not available until 1990s or late. Before that we were doing some urine coloring test in order to know the level of diabetes. A1C, you can see they are huge machines in 1970s. Nowadays we have a very small devices which can see which can detect that. Easier and safer management, 1985. The syringe is converted into pens. Unfortunately, we still not able to get pens in our community as a whole. We are still lagging 40-50 years behind the management of diabetes. 1999, the first CGM was FDA approved that, and since then many new agents which we already discussed about those. I have to jump the slides because we have a shortage of time. 2010 was the time when the insulin analogs were available. Number of patients with diabetes ever increasing since then. We were thinking that 700 millions 2045, but I think we will hit that mark 10 years before that. We need to be very vigilant about the management of diabetes. Management of diabetes cannot be fulfilled until we start measuring diabetes, we start monitoring diabetes, we start using the modern gadgets. In USA alone, you can see there more than in 2007, there were more than 400,000 patients were using insulin pumps in US alone. Now their number is from 1.5 to 2 million people, but in our country their number is only few hundred to 1,000, which is really, we are lagging behind the technology. Why we are, we should focus that glucose variability predicts future risk of hypoglycemia. If you do not, monitor, you are going to suffer complications. If you getting more strict and stringent controls of diabetes, you are going to suffer with hypoglycemia. We can only, prevent these if we have a better monitoring devices. Without the devices, we will skip many hypos, we will hyper, and the A1C is not alone enough to tell the entire story, because the patient might have a very good A1C level in the range of 6.5 to 7, but might have frequent hypos, so it is not a good indicator. Without CGMs, we cannot, outperform diabetes. Lower variability, the increased risk of hypoglycemia. A mere one severe hypoglycemic event would lead to, the cardiovascular outcome in a much worse position. We will skip few slides. CGM, nowadays it is not only the A1C. We need to more focus on the time and range. Our patients most of the time should stay within an acceptable range, which seen in trials, that if you keep your patient more than 70%, between 70 to 180, in this window, your patient is going to enjoy the 10% extra benefits of reduction in cardiovascular morbidity and mortality. At the same time, the reduction in A1C benefits would continue. So this is very important, especially in type 1 diabetes, especially patients with type 2 diabetes, where fluctuations are more, with more complications. So we need to get the numbers right. We cannot get the number right if we do not monitor the disease closely. You cannot achieve A1C less than 7, less than 6.5 if you do not have CGM and monitoring devices, because the chances of developing hypoglycemia would be much higher in that category. In USA alone, the expenditure for the CGM insulin pumps, it is over $8 billion now. It is a huge market. We well familiar that just mere a 1% reduction would lead to a significant reduction in micro and macrovascular complications. Your patients at the diagnosis of type 2 diabetes, about 33% patients have some sort of complication in the form of microvascular or macrovascular. So in order to get the numbers right, with the same patient with the same A1C, say 7, if you will put CGM on that patient is going to enjoy 10% extra benefits in reduction in cardiovascular outcome. We will go directly to the, so this is very important saying, what gets measured gets managed. So if we do not measure the things, we cannot manage it properly. We are all focusing on the drugs, on the monitoring of the diet, exercise, and patient education, individualizing A1C targets, but our more emphasis as a community physicians, as we have seen, is solely on the pharmacological management, and we are neglecting most of the the paradigm shift and the treatment of diabetes. We are ignoring the glucose monitoring devices. We are ignoring their integration. We are monitoring we're not measuring the blood sugar levels as the rest of the world is doing. I think it might be due to the lack of resources, and secondly, our physician might not be familiar with those devices. Type 1 diabetes is the one which is carries the burden. So over 95% patients with insulin pump CGMs, they are usually with the type 1, and the remaining are type 2. If you put CGM and insulin pumps in type 2, your patient need 20% less insulin. It means less side effects, less weight gain, less lipodystrophy effects. I'm pretty sure that most of you are not familiar with these companies. These are the insulin, and CGM making companies. Only one is available in Pakistan. Unfortunately, Medtronic has left already. So we will familiarize now. So this is a device. You can see there. We will put a CGM a monitoring device here. It will in real time will transmit the data to the device or your smartphone. And this is insulin pump in which you will put a small needle there. It is also, it will inject with some cannula. There is a reservoir there, and once it's been inserted and it is calibrated with the modern devices, either you can have your smartphone attached with it, or you can have a separate device which is integrated with that. It will start relaying data, and you can see there is a continuous data 1 to 3 minutes apart. You can in real time you can calculate the blood sugar levels, and then you can adjust your basal rate for insulin, and then you can give the boluses of insulin, and in which you can keep that range within an acceptable range. With the basal bolus regime, you can only give the boluses and with the basal portion, but you cannot if you have a buffet or you are doing some exercise and doing some extensive workout. So those cannot be managed properly. But with insulin pumps, you can titrate the dose. You can give them a long extended bolus, the boluses, short extended boluses, multiple injections, dual treatment. With the help of the insulin pumps, you don't need to monitor the blood sugar conventionally. In 1970s, these were very huge, and then these are the the portable one in 1987, 1978. You can see it's a huge machine. But nowadays, the insulin pumps are very smaller. They are more acceptable. Their size is merely slightly bigger than a penny, and their devices are more smarter and more elegant. And these are the modern devices. You can see they're very small, and now the technology has changed since the last 2 years before. Now the tubeless insulin pumps are available, in which you don't need to put the tube separately, and you don't need that. You had a portable patch. For example, I have here. So you can have that portable. It's a very small patch. It's you can see the size there. It is very small. You just need to take the patch out, and then you need to put your software in your mobile phone, and then you click. You are going to start that, and then you just inject 200 units of insulin into it, and remove the covering and put it on your body, and just click it from your smartphone. It will self-inject the needle, and then here you go. You have the insulin pump inserted. There is no needle. It contains 200 units. It is Omnipod 5. And it is disposable. So along with that, you need to put some sort of sensor on the other side of the body, where your body is going to in real time sensing the data, and that data is then integrated with the insulin the insulin pump via your smartphone, in which you need to make some setup, in which you need to set the basal rates, and then you need to calculate how much grams of carbohydrate required for 1 unit of insulin. You need to put some data into it, and then after that, it has a new function that is automated regulation of insulin, in which you don't need to calculate self-inject. You just set up the formula there, and it becomes an artificial pancreas nowadays. It is a closed loop system, and it is very safe. It has an auto function in which it will switch off once the blood sugar levels are going low. You can use these. These are the 3 devices which are more prevalent in the international community. A Medtronic 640. Previously, we were using a Medtronic 554. That was lacking the function of integration and artificial pancreas. There are many available in the market. We have available here is Abbott's Libre. It is very simple. You can. There is a small device in which you need to just to unscrew this one, and just take the covering out of it, and then you put this box there, click it, and when it is loaded, you just need to put that device. You just clean the surface on your arm, and then to put it there, and slight pressure, it will self injected. There is no pain. It is almost a painless device, and it will start measuring your blood sugar levels after 60 minutes, and it is continue to it will continue its function for about 14 days. Nowadays, there is a Libre 3, which is even a size of a penny. It's a very small, device you can see there. There is no need for a separate device to check the blood sugar level anymore. So that concludes, although we have unfortunately some short of time. But after that, if you have any queries, questions, I have all the devices with me. You can have a first-hand experience of CGM, insulin pumps, and I have some, the devices for glucagon. With the low blood sugar levels, you need those devices, and type 1 patient must have one of those pens. Thank you very much for your patience listening. Thank you.
थैंक यू सो मच. अगर कोई भी इन्फॉर्मेशन है तो अभी लंच में ये हमारे डॉक्टर साहब इधर ही होंगे, तो आप इनसे इन्फॉर्मेशन ले सकते हैं. नो आई क्विकली गो टू दी पैनल ऑफ एक्सपर्ट्स. आई रिक्वेस्ट डॉक्टर इकराम साहब टू स्टार्ट विद ओनली 1 or 2 lines ड्यू टू द शॉर्टेज ऑफ टाइम.
First of all, congratulate Dr. Ijaz, Ahmed Shahzad and his team, Dr. Yusuf Ikram, Dr. Masood, Dr. Tariq, Dr. Naeem and Dr. Irfan Saab. Please give a short clap for these personalities. The other point is that as a family physician or primary care physician, we have to see the patient as a whole. And other point is that for the family, give time to the patient, he will tell you the diagnosis. Thanks.
बिस्मिल्लाहिर्रहमानिर्रहीम. सुबह से माशाल्लाह बहुत बातें हो चुकी, ज़्यादा बातों का टाइम भी नहीं है. मैं आज के दिन को अगर समराइज़ करूं तो 3 P में समराइज़ हो सकता है आज का दिन. Prevention is the number 1 P. Second P is polite. Be polite with your patients. And third P is be positive. Patient को hope दें, patient को डराए ना. Patient को जितनी hope देंगे, be positive रहेंगे, उतना ही patient आपसे ज़्यादा समझ आएगा और ज़्यादा प्यार करेगा. Patient को डिग्रियाँ बाद में पता चलेंगी, पहले आपका इखलाक पता चलता है. Thank you very much.
As a member of organizing committee, I convey my humble thanks and gratitude to all the participants, panelists and speakers. And our aim of this gathering is to empower family physicians to treat diabetes according to the required standards of care. I thank you all once again for participating in this symposium.
I've been told to restrict my comments to the minimum because the lunch is waiting for you. I congratulate the audience who have taken part in this conference because the number of people who have stuck to the auditorium is really remarkable. The only comment I want to make is that drugs that we are now introducing against diabetes are very, very costly. The other day I was reading about Jamun. It is a GLP-1 agonist, which may be surprising to you. What I want to emphasize is that all the research that we have been showing, all the technology that we have been showing is coming from the West. Now that we have universities of our own, we need to introduce a culture of original thinking, creative thinking, and inducing our juniors to research and bring in new ideas. I thank you and thanks the organizers for giving me this opportunity to sit in the chair. Thank you very much.
Thank you so much. अब स्मार्ट वॉच किस किस को चाहिए वैसे ही बता दें, हाथ खड़ा कर देगा. अब 5 से ज़्यादा हाथ खड़े हो गए. अब मैं डॉक्टर अहमद शहजाद साहब से रिक्वेस्ट करूंगा कि कुरानंदाजी अगर 5 होते हमने दे देने थे, बहुत जल्दी आ गई. No, I request Dr. Ahmed Shahzad for the lucky draw and I request Professor Dr. Akmal Sharif Saab for the gift presentation. No, पहला ड्रा आने वाला है 5.
मेरा अगला ख्याल है कि थोड़ा जो प्रिवेंशन पे काम करना.
ये देखें कोई निशानी ना लगाई हो डॉक्टर साहब ने. लाए सर साथ साथ
क्राउड इकट्ठा कर रहे हैं डॉक्टर.
can talk about it sometime.
सही कह रहे हो। ले सर।
मैं थोड़ा लाया सी तो मिलन दी बस
I could see you. I had gone with something.
डॉक्टर एहतशाम,
ड्रॉप कर गया।
डॉक्टर एहतशामुल हक हैं नहीं है, नेक्स्ट वीक अगला कर। डॉक्टर रूही मेहताब, डॉक्टर रूही मेहताब नहीं है, हैं? चलें जी डॉक्टर रूही, आ जाए जल्दी से आ जाए, चलें जी डॉक्टर रूही। चली गई है मैडम, कह रही थी कि मेरी निकल आनी है वो कह के गई थी, मैं बड़ी लकी हूँ नहीं वो डॉक्टर मोहम्मद यूसुफ, अजीज़ फातिमा नहीं, आगे नेक्स्ट। जी सर, अभी तक एक वॉच ही गई है, बाकी बची हुई हैं, 4 पड़ी हैं। जी सर, समीता साजिद, डॉक्टर समीता साजिद चली गई जी, आगे नेक्स्ट करते जाए फटाफट सर। डॉक्टर मोहम्मद वसीम, मदीना टाउन, जी सर प्लीज, डॉक्टर मोहम्मद वसीम। चलें जी 3 वॉच रह गई हैं, 3 वॉच चलें, अब मैं रिक्वेस्ट करूंगा डॉक्टर अहमद शहजाद साहब से कि आप इन्हें दें। ले चलें जी 2 वॉच रह गई, 2 वॉच लेफ्ट। डॉक्टर हाजिक अली PGR मेडिकल यूनिट 1, हाजिक आ जाओ हाजिक। स्मार्ट वॉच आप। डॉक्टर मोहम्मद हमाद खालिद नहीं है, नेक्स्ट करते सर। डॉक्टर नासिरा सुल्ताना नहीं, चली गई, नेक्स्ट कर दे सर। डॉक्टर अली एहसान FIC चलें जी। On the behalf of Pakistan Care Diabetic Association, I am very thankful to this great crowd. आप लोगों की ऑडियंस इतनी ज़बरदस्त और इतना अच्छे तरीके से सुना और इतना इन्वॉल्व हुआ है, मैंने ऐसी ऑडियंस वाकई नहीं कभी भी देखी कि एट द एंड के लिए। तो अब लंच इज़ ओपन, तो नज़ारा हाल में है लंच, नज़ारा हाल। चलें, थैंक यू सो मच।